of Gujarat meeting. It's a very proud moment for all of us to establish this society under the mentorship of Dr. Kamar sir. And I would like to mention the special efforts put by Dr. Parth and Dr. Kushal in forming this society. I think the basic purpose of the society and its activities will be told to you in future. But again, I thank all of you coming from all over Gujarat, and a special thanks to our faculty, national faculty, Dr. Mahesh from Bangalore, Dr. Divyansh from Bangalore, Dr. Sangeet and Dr. Sudarshan from Chennai for coming all the way. We have tried to formulate the program, make it more interactive. So essentially the entire conference is going to be a case-based discussion conference. So I urge each and every one of you to keep asking questions and let us learn from the experts who are here. So keep asking questions. We also have a special interesting panel discussion on retinal detachment by Dr. Gaurav, who will join us virtually from San Francisco. I'm sorry to say, but I'm going to be the strict teacher maintaining the time because we have a very long program. So kindly stick to your time. And with that, I hand over to Dr. Kushal, who will start the proceedings of the scientific session. And again, thank you all for coming here.
Very good morning to all the dignitaries present here. So we will start first session for the medical retina. So first of all, I would like to invite the esteemed panel that we have with us. So I will request Dr. Manoj Bhatt sir, Dr. Ashok Talati sir, Dr. Milan Thakkar sir, Dr. Mudit Bansal to come to the front for the being part of the panel. So we will be having case presentations, and each presentation will be of 4 minutes. That will be subsequently followed by the discussion for 6 minutes. And with that, I would like to invite our first speaker, Dr. Ronak Punia. He is currently a fellow at Retina Hospital, Rajkot. So Dr. Ronak.
Good morning, distinguished dignitaries, respected seniors, and my dear colleagues. I am Dr. Ronak Punia, and I will be speaking on a unique case of a branch retinal artery occlusion as a manifestation of severe iron deficiency anemia. A 26-year-old female came to our hospital with chief complaint of sudden diminished vision, painless diminished vision in left eye for 2 weeks. On ocular examination, conjunctival pallor was noted, and best corrected visual acuity in right eye was 6/6 and finger counting 2 meters in left eye. Vital signs revealed a normal blood pressure and a bounding pulse. There was no history of associated flashes, floaters, or any systemic disease, and no history of any drug intake. On fundus examination, there was a disc edema with retinal whitening along the inferior temporal vascular arcade with few cotton wool spots and a retinal hemorrhages with white center. And OCT showed the thickened hyperreflective inner retina and the hyperreflective outer retina, which was suggestive of retinal arterial occlusion. Looking at her marasmic look, complete hemogram was advised, which revealed a hemoglobin of 3.9 gram per deciliter. Normal platelet counts and serum ferritin level was also very low. The peripheral blood smear revealed a microcytic hyperchromic anemia, which was suggestive of iron deficiency anemia, and the lipid profile, coagulation profile, and Doppler all were within normal limit. The physician reference was done, and patient was started on ferrous ascorbate 100 mg twice a day and called after 2 weeks. But she came after 3 months, and to our surprise, the visual acuity improved to 6/24, and the hemoglobin and serum ferritin levels also improved. These are the comparative pictures after iron supplementation with the recent fundus photo showing some disc pallor and arterial attenuation. This is the comparative OCT showing, which is showing the macular thinning in the recent OCT. Now, the anemic retinopathy occurs in about 20-25% cases of severe iron deficiency anemia, and it is more common when the hemoglobin is less than 8 gram per deciliter. And the ocular manifestation of the anemic retinopathy is mainly conjunctival pallor, retinal hemorrhages, subhyaloid hemorrhages, and these all are due to tissue hypoxia, which leads to vasodilation and increased capillary permeability and abnormal vascular leakage. And the severity of anemia is an important risk factor for the development of anemic retinopathy. And the vascular occlusion is a rare manifestation of iron deficiency anemia, and it can cause severe, significant visual loss. Thrombocytosis, anemic hypoxia, and angiosperm are the three proposed mechanisms for the microvascular occlusion in severe anemia. In our case, there was no thrombocytosis or hypercoagulability state, hence the anemic hypoxia and angiosperm could be the two factors responsible for the microvascular occlusion. And our patient was treated with oral hematomics only, and the reversal of anemic hypoxia and angiosperm may be the possible explanation of the improvement of vision in our case. In the last, I would like to conclude that the retinal occlusive events may be the first manifestation of severe underlying systemic disease, hence the complete systemic examination is warranted. And by just correcting the hemoglobin, she had a major impact on her visual acuity. And anemia should be considered while evaluation, especially in those cases which were associated with conjunctival pallor. Thank you.
Thank you, Dr. Rana. Nice case. So we'll invite Mahesh sir for your initial comments on this case.
Very striking case, the fact that the hemoglobin was 3.9 was something which you don't commonly see. And of course, like, it's a very rare possibility. That's something which has to be looked at. So, as you very rightly said, any vascular occlusion, the systemic factors are the main reason, and we have to kind of look for it. And here it was obvious, and the outcome is quite striking actually. That's what it is.
Manoj sir, please.
So, do you see the rock spots like the white central hemorrhages? So, I think that could give us a clue where we need a detailed systemic evaluation. Any thoughts on that? Manoj bhai? Please feel free to ask questions. There are rotating microphones, so we would like interaction from the audience also.
Yeah, a very nicely described case. And as Dr. MP is saying very correctly, that in such scenario, the most important is to find out any systemic underlying cause, and severely reduced hemoglobin in this case, and excellent outcome. Very nice case.
It is very common to
the road spot which you said, yeah, it definitely is a good clue.
Yes. It is very common to find such findings, not only restricted to macula but all around the retina, having recurrent hemorrhages with road spots, even in anemia or following BT after anemia.
Yes, sir, please.
So I think for the young, it becomes very important to have these hematological workup. Rather than we just giving these blood investigations, it would be better to send to a hematologist for a thorough workup. And these young patients would generally have some or the other hematological disorder. It could be a chronic event or something which has happened acutely. Unlike the arterial occlusion that we see in older population, where they would have some systemic manifestation. If nothing, then maybe just atherosclerosis also. But in these 25-30 years people, there has to be some hematological disorder.
So I think here we are seeing two scenarios. One is the arterial occlusion and the hemorrhages. So whenever there is an occlusion, as Mudit said, particularly in a young patient, I think they recommend a complete stroke workup, which is very, very important, and that has to be done within 24 hours. So that is extremely important because we all know young patients, if they develop any embolic or an occlusive event, they usually have a very bad outcome, whether it's a heart attack or a stroke. So any occlusive event in a young patient has to be dealt in an emergency and has to be referred to a complete stroke workup. Yes, Mike?
There's possibly a little component of central little vein occlusion.
Exactly, I was saying. There was a CME also.
Yeah, central little vein
So
occlusion.
you will only see only CME.
And the vessels are dilated and tortuous. So, and the hemorrhage is there involving this big retina as well. So, there's a possibility of a central little vein occlusion component in addition to a central transcendental artery occlusion. The PIV also probably it's related, it's limited to a one particular branch because it's not extending, the whitening is not extending beyond.
So Mahesh, would you treat differently if you have a combined CRAO and a CRVO?
Yes, I would treat them differently. In contrast to what? In contrast to
Contrast to only CRAO.
CRAO.
Yeah.
CRAO, CRVO has got a more ominous prognosis because and more ominous systemic implication as well. A combined occlusion usually has an underlying systemic disease and they can be very dangerous diseases like a systemic malignancy as well or a hematological malignancy. So a combined occlusion or an orbital lesion can also be there. So a combined occlusion is something which can, one, have different systemic implications. Second, they can progress to a neovascular glaucoma much rapidly and the visual prognosis is also bad. So that with those factors in mind, we should look at them. The management part of it in the CRAO, you would try to do a paracentesis, decrease the pressure and see if you can reperfuse it. But in a combined occlusion, whether it works or not, I am still not sure. But though I have tried a couple of times, but something it doesn't work, it probably doesn't work. And whether the hemorrhages because of the venous occlusion will get worse after doing a paracentesis is something which is not clear as well.
Would you recommend doing an angiogram to see severe non-perfusion? Would you recommend doing a prophylactic PRP just to prevent a neovascular glaucoma?
In a combined occlusion?
Combined?
The problem is the visual prognosis is bad either way because the patient already has a CRAO, so the visual prognosis is bad either way. And in that, if you were to do a PRP prophylactically is something which is not warranted, I would usually follow them up to see if they develop a neovascularization only then I will do PRP.
Madhavi?
Yeah, I was suggesting that considering that they did such a good workup, maybe after the patient recovered and knowing that the central fibers were spared, have you tried doing a perimetry in the follow-up?
No, actually, on the first visit, the visual acuity was finger counting 2 meters.
On the follow-up, after the recovery. Maybe it will give a
Thank you. Last question. We move on to the next then.
Is there any role of subcutaneous low molecular weight preparing or intravenous prostaglandin in particular disease?
I think there is no role of any systemic medications in any of the occlusions as far as the ophthalmic or retinal is concerned. But as Dr. Mahesh said, if you find a systemic factor, then of course it is up to the neurologist or the vascular specialist to give that treatment. Not for the eye, if I am correct, right?
I think there was some study about trying to use systemic treatment, the same stroke protocol, there was a paper that the last couple of years, like stroke protocol saying to be used for CIO, and if I remember correctly, they found a reasonably good outcomes. But like to get a patient at that particular point and then go ahead with such an aggressive treatment for an eye problem, which may have other systemic issues, is the question as to whether it should be instituted or not. But if I remember in the last 1 or 2 years, there has been a paper of same stroke protocol being used to treat the CIO.
Thank you. I think we move on to the next presentation. Thank you very much.
Thank you, Dr. Bala. And also I would like to invite Dr. Ramesh and Dr. Nivesh to join the panel in the front. So the next case is being presented by Dr. Gunjan Shah from MNJ Western Regional Institute of Ophthalmology. It's a case of a posterior microphthalmos. Dr. Gunjan.
Good morning everyone, and thank you for giving me this opportunity to present this case. So I would like to discuss a rare case of posterior microphthalmos. So we had a 7-year-old child who presented with complaints of blurring of vision in both eyes since 2 to 3 years. The best corrected visual acuity was 636 and 660 right and left eye. Clinical examination, relatively anterior segment was everything within normal limit. On dilated fundus examination, we had a slightly crowded hypometropic disc with unusual fold on the macula. So we did an OCT for this patient where we saw that there's some fluid, intraretinal subretinal fluid with a central focal thickness of 430 microns and 440 microns of right and left eye. On USG, there was slight sclerodermal thickening which was seen. With above findings, we actually thought that could be because of the macular edema, so we did blood investigation to rule out any inflammatory markers, which all came out to be negative. So we actually planned for the FFA for the patient to rule out for any potential leak causing that macular edema. But then again, the folds and everything did not fit in properly with this given picture. So we did a cytometric reflection where we came to know that the patient's correction was plus 10 ds plus 11 ds in right and left eye. And there was axial length was very small, which was 15.2 mm in right eye, 14.9 in left eye on A scan. However, the other anterior segment findings were normal. So with above picture, we reached to the probable diagnosis of posterior microphthalmos. As of now, we have given the full hypometropic correction to the patient so as to prevent further vision loss and his advice for close follow-up. So microphthalmos is a rare developmental disorder where one or both eyes are abnormally small when axial length is less than 2 standard deviation for the given age. And posterior microphthalmos is a type of microphthalmos where anterior segment findings are relatively normal, where there is foreshortening of the posterior segment. So common findings associated with this are high hyperopia and papillomacular folds. However, it could be related to optic disc drusen, pigmentary retinopathy, foveal stices or macular stices. It is suggested that this fold is caused due to arrested growth of the outer layers of the eyes such as sclera, choroid, retinal epithelium. However, the growth of inner layers continues, which causes the retinal folds due to the redundancy. So the diagnosis, this case is important because the diagnosis of posterior microphthalmos may be overlooked due to the relatively normal anterior segment. Hence, such patients who present with hyperopia should have thorough evaluation and they have poor visual prognosis due to amblyopia. However, there was one case report by Takako Hanyo et al. Which showed that there was visual improvement with resolution of macular folds due to early diagnosis with timely treatment of amblyopia, although there was no change in axial length as such. Recognition of microphthalmos will help to treat the accompanying hyperopia and amblyopia to take precautionary measures against the complications of same. Early diagnosis must be performed, thorough dilated evaluation, biometrics, ocular sonography and OCT should be done. Thank you.
Thank you, Dr. Kundan. It's a nice case. So, would like to start discussion with opening comments by Dr. Talati.
Nothing much to add. I mean, this is a rare phenomenon and we hardly see many cases like this. The diagnosis is hypermetropic fundus only and the treatment of the employer. I think that is the comments.
Milan sir, your comments.
Jignesh, you had a comment? Yeah, flat.
In the past, in the past we came across 2-3 such cases, and I tried to treat it with on the basis of macular edema. So it's nothing to respond there. Is it to be treated or not? The first things which is to be like to be asked. Intravitreal steroids or ILM pilling could work in such cases to reduce the folds and to improve the visual acuity. That's the question here.
Yeah, Ramesh.
So we have published a larger series of posterior microphthalmos, and what's important to understand is that the folds which you get is because the shortening happens only in one meridian and not all throughout. It's not a globular phenomenon which happens like a keratoglobus where it's not uniform. It's the shortening which happens only in one particular meridian. It is also important not only to focus on the macula but also to see the periphery, because you will have an association with the frizzle gene receptor mutation which happens because and leads to pigmentary retinopathy.
Yeah.
So you think that there is an RP with microphthalmos
Yes.
or a hyperopia. So so the periphery also is equally very important. And what's interesting is when you see these patients growing to around 15, 16, 18 years of age, the papulomacular fold which you get actually starts to flatten out because the globe starts enlarging in size and therefore the crowding starts to release overall. So the fold which you have so intense in your case, because it's a 7-year-old child, will actually flatten over a period of time.
So, to answer this question, any intervention? Any
No,
sort of intervention?
nothing.
None.
Any genetic studies?
Yes. The frizzle gene mutation is what you have.
Is it transmissible?
Ma'am, I'm not an expert in that.
So there are many populations where the families have been affected with that. So, but I'm not sure whether it has autosomal dominant or recessive kind of an association. But yeah, there are familial papers where the mother, parent, and the child and the grandchild also is affected. So as he suggested, one very important thing is to look for glaucoma association, because right now we are classifying this as posterior shortening only. So the anterior association should be ruled out, because as they grow, the AC can become shallow and then they can develop glaucomas and lose vision because of that also. And another thing is, later on in their life, they can land up into UES type 1 year. So that also needs to be followed up closely. So as he suggested, the RP changes, whether those are because of the fluid which gets absorbed or is it because of an association of an RP. Frequent follow-up and those understandings.
Any other comments?
Do you have the OCT picture?
OCT picture, can you put it on?
With the proper refraction, they can get the revival of the vision. I think if it's less with the intense hypermetropia at plus 10, plus 12, so over the period of time in the central therapy, initial vision which was less good, ultimately a lot of these cases may have relatively decent vision recovery.
Yes, you are absolutely right. If you look at our cases for 15, 16, 18 years, these patients even with a plus 10, plus 12 refraction, they end up reading around 612, 618 vision. You don't find a very, very poor vision which you expect with such high grades of refractive error. That doesn't happen here in posterior microphthalmos. The axial length, yeah, it usually is around 16 to 18 millimeters. It doesn't go beyond that, but that is something which we have seen.
It can be because of bilateral amblyopia, but with current modern amblyopia management techniques, this can improve even after age of 10 years. So vision can be improved after 10, 12 years also if we use some perpetual hand-eye coordination and other techniques that will help.
And as Dr. Divyang said, when it goes in the uveal effusion phase, and when this patient can also develop exudative retinal detachment also, and in this patient the sclera is excessively thickened, so we might require to do in that case partial sclerectomy in all quadrants. So this is the thing when it goes in the exudative retinal detachment. So I think.
So how common is the uveal effusion syndrome in these cases? Ramesh? How common is a uveal effusion syndrome or exudative detachment common in these cases?
That's what I was telling Divyansh now. I have not seen a single case of PM actually developing into UES, because the classical thing in these cases is the anterior segment is absolutely normal in these cases. If you do an A scan or even you do an IMM, the AC is actually deep in these cases. Unlike the nanophthalmos, where the angles get shallow, the entire globe is shorter. So those cases they end up with more UES-like features rather than this. These cases they require only monitoring. That's it.
comments?
You can't say that like if you followed up a micro-ophthalmos to develop UVS, but like the eventual type 1 UVS is something which can happen. And type 2 again, once again, like where there is a common sense they develop UVS can happen. So Ramesh probably has a serial follow-up, but I don't know. But if they develop a UVS, because all factors to develop UVS are there, because there is sclera is thicker and axial length is shorter, so they are possible that they can develop a UVS. Another thought is like if in case the sclera is shortened in only one meridian, there is a possibility, but like of course yes, these people go up the macular folds flattens out. Otherwise, like you can probably relax the sclera there by doing the conscious sclerotomy that may open up the fold also. That's a concept which can be thought of.
Thank you. I think we've learned very nice things in the first two cases.
Thank you, Dr. Gunjan.
Thank you, sir.
For next case, I would like to invite Dr. Vaibhavi Notiswala. She is going to present on submacular hemorrhage in a one-night diabetic patient post-Vitreo.
Good morning, everyone. Thank you, VRAG, for giving this opportunity. I'll be presenting a submacular hemorrhage case in one-night diabetic patient post-vitrectomy. It's a case report. My patient presented with me with PDR and TRD. She was having lost eye in the left eye. Right eye she presented with one NFC, and we decided to go ahead with vitrectomy. And in post-op she was stable, maintaining 6/18 vision. But 1.5 months after surgery, suddenly there was a decline in her vision, and what we found was a submacular hemorrhage. The multimodal imaging confirmed the same, and we were thinking what to do next. There are the various treatment modalities which are available. We can go for anti-VEGF. As we all know, TPA is there, PD is there, vitrectomy is an option as well, and other which we can go for is an observation. But as it was a one-eye patient, already one eye was lost, I didn't want to take any risk, so I asked my senior, Dr. Alesar, for the same, and he helped me with it to go with the anti-VEGF. And this is the 1 month follow-up OCT, where macular hemorrhage was spontaneously resolved. So why it is important, as we all know that it can lead to loss of photoreceptors and damage to the macula. Why this case? So after PDR surgery it was developed, loss as compared to the CMPM which we most of the time has. So what I found here is the patient was on anticoagulation therapy, and the physician started clopidogrel, and I tried to find out if any neovascularization is there, but I couldn't find any. And with the systemic correction of the coagulation therapy and the anti-VEGF, we could save the eye. Thank you.
Just take that slide. Comments from any panelists? Divyansh?
Finish the slides about the teaching because she has to. Where slides would have been.
Next.
Or does she want to take them later?
Yeah, plus just leave this. So I think just to initiate the discussions, post-vitrectomy hemorrhage in diabetics, there are a lot of issues. First of all, what are the causes of recurrence? How do you manage them? And then special situations where you operate the diabetics, particularly patients who are on dialysis. So just would like to know comments in respect to this case also.
Do we have any photograph of eye?
Do we have the photo, the fundus photo?
Patient was not that cooperative at the first time of presentation, so we had the OCT. Yeah.
There is oil inside, is it?
Yeah, it's a oil-filled globe.
So what is the pre-operation, post-operation and post-submacular hemorrhage?
Okay. pre-op vision, when we operated for the TRD, it was 1 MFC. After surgery, she was maintaining 618 vision. And when SMH developed, it was again 1 MFC. And after the treatment, here she was having 618 vision again. So we could manage the vision.
Usually starting anticoagulants do not give rise to submacular hemorrhage. I haven't come across one like that, and particularly a post-TRD surgery. Was that patient a CRD to begin with? Why was oil used?
Sir, actually, the history was that other eye was already treated for TRD. At that time, gas component was used elsewhere, and she developed recurrent RD along with the PVR changes. And this was a very valuable eye, so I didn't want it to go for the gas component this time.
At this point in time, what I will do is once the hemorrhage is absorbed, we probably think of doing an FFA to see if in case they are missing out on a RAM or a CMVM somewhere else. Because usually starting anticoagulants does not give rise to submacular hemorrhage.
Sir, yeah, actually the thing is at that time we were thinking about the same, but the patient was not very anxious, and we focused on the treatment, and as we gave anti-VEGF, there was immediate response within first week only.
Where do you think an anti-VEGF made the hemorrhage go away?
So the first week was really nice, and
Why do you think, how does it make the subretinal hemorrhage go away? I would have thought like if you were to give an anti-VEGF and put a gas bottle and ask the patient to maintain prone position, then it will shift. Why would an anti-VEGF make the subretinal hemorrhage go away like that?
Sir, one is we used two approach. Anti-VEGF could have worked on neovascularization, and the other thing is we worked on the blood profile. The anticoagulant which was added apart from ecosprin, we stopped all of them.
No, but this neovascularization is what I'm asking. Where is this neovascularization just caused the bleeding? So that's what we needed to find out. And anyway, there's oil inside, right?
Yes.
So there's no question of putting gas inside this patient. So probably a prone position may have also worked. Just a prone position without giving anything.
Okay.
Is there a detachment?
Yeah.
Is there a detachment which is still persisting? Because if you can see here right now on the nasal side or whatever the scan is, there is still some fluid, and the fluid was more in the previous scan. So it may have been that there is one fibrovascular proliferation which you have trimmed, and there could have been an active traction and there is a break with below that or somewhere adjacent, and which is still active and which may have bled because the retina is still detached. That's why it has flown from the epiretinal or the preretinal space into the subretinal space. And now because that detachment for whatever reason has settled, and that's why the hemorrhage has moved away is what I feel, and not the anti-VEGF which has worked. But because the fundus photo would have given a big better answer to this.
There was a traction inferiorly. But I will check it again.
Post-op, how many days patient develops subretinal hemorrhage?
Sir, 1.5 months.
See, my suggestion is if this patient spontaneously absorbs subretinal hemorrhage in your cases, but I would ask other analysts, do you recommend removing the oil and put a gas since 1.5 months is over? So,
one eye patient.
But the subretinal hemorrhage patient is developed. So, in this case it has observed, but since the oil is, can we remove and just put the gas?
So the patient, she says, had a persistent inferior traction, one eye. So probably removing the oil early, there is a risk of having a recurrent traction. Just a question, does anybody stop using the blood thinners prior to diabetic vitrectomies?
I had a very similar case, but there was no subretinal hemorrhage. It was pre-retinal hemorrhage. It was not an oil field eye. And one eye, of course. And once I finished the surgery, what I found was there was a large pre-retinal hemorrhage. I waited, and then it dispersed, and then it did not resolve. So what I did was with this Novak, and everything was fine. But it was not an oil field eye.
Anybody using tranexamic acid intraoperatively? Dr. Barbara has presented a few scenarios where now she's using tranexamic acid intraoperatively in cases where you have persistent bleed. Because in many diabetics, when we operate, there's a constant oozing. So, any experience, anybody? Yes, question.
to us and then we had to do a retinal program and remove the blood. It was not a small bit but a massive all over there.
Ramesh, last comment?
We have used actually brain monitoring. So instead of analytic acid, I have no thing. But brain monitoring we have used actually preoperatively in patients where we think that they may bleed. And brain monitoring is used specifically in surgeons as well, topical surgeons. So we have used brain monitoring. Brain monitoring has been used in the eye. So we have used it preoperatively as well as symptom. We have not published it as yet, but then it does seem to stop the bleeding, but we're not very aggressive with the use of it.
So you use it as a routine or just in very aggressive cases?
As I mentioned, most often we would prefer not to give anything, but if we have these patients where we know that they will bleed. So we have given antibiotic despite which they keep oozing. In those patients where they will elevate the bottle height, weight close to sclerotic and weight, despite which it bleeds, then we have used antibiotics.
How does it help, sir? Remonitoring?
Remonitoring does process vasoconstriction.
Yeah, last comment.
No, I was waiting for the answer, which the question you raised. Were do you use anticoagulants prior to diabetic surgeries?
That was only if the patient is in aspirin, we don't stop and continue. If the patient is on warfarin or any other anticoagulant, we usually stop it. For the clopidogrel, we do stop.
Clopidogrel also?
Yeah, we stop for
how many days?
3 to 5 days.
3 to 5 days. And then when do you restart?
See, the question of rebleed is the one.
No,
Restart for the first week, we restart.
Oh, no, my question is that these neovascularizations which bleed in drop, they are coming from the neovascular processes and not from the major vessels or through the new vessels. So stopping the anticoagulants, if you really want to stop the neovascularization from bleeding, the best way to treat is to give an anti-VEGF or something prior to the surgery rather than waiting for the anticoagulants. So how does stopping an anticoagulant or restarting actually help? Because here you are not going to damage, mostly, you are not going to damage those major vessels or the original blood vessels.
You're cutting the vessels, they are going to bleed, right? You're cutting the new vessels which they are going to bleed. And these new vessels start off from the existing vessels, correct? So the bleeding tendency is a little bit more with the anticoagulants.
No, it's about retaining the vascular bed, in the sense that the vascular bed to the major vessels, means from where it is originating is still retained, and you just cauterize it. Probably wanted help.
Yeah, there will be an extensive cautery, and then there will be along the arcades, if you cauterize, there is a possibility of the cautery causing occlusion of the major vessels. So that's the reason stopping the anticoagulants will decrease the risk of bleeding during the surgery and so on. So it doesn't have any other impact. So the degree of cautery you want to do, and degree of uncontrollable bleeding which has during the surgery, which may stop you from doing further surgery, is what you prevent by doing stopping anticoagulants.
Thank you. I think we move on to the next presentation. So I would like to invite Dr. Mahesh, who is our first keynote speaker today, and I will have Kushal introduce Dr. Mahesh.
So we are happy to have Mahesh sir, a teacher for excellence, and the list is endless, and you can see sir is being currently working as a head of Vitreo Retina oncologist with the Shankar Hospitals India. He is co-founder of Retina India, which everyone is very much excited to attend every year. Currently, sir is holding a position of scientific committee chair convener at VRSI, innumerable publications and citations and chapters. So we are fortunate to have sir here today, and we will be eager to learn from him today. So we welcome you, sir.
Thanks, Dr. Kushal, thank you, Dr. Alec, and thank you for this opportunity to speak to us this morning. Of course, that is not how I looked at those photographs probably about 50 years back. I think it was taken in the net. Anyway, Dr. Alec wanted me to speak about like innovations in retina. It's not innovations in retina per se overall. So it's kind of what we have done. So just to show that like research doesn't mean that like, we need lab like this and people donning white coats and everything. We can do research as to wherever we are, and I'll just show you some examples in the past over so many years what we have done. So if you just see a way, and you will find a way. So necessity is the mother of invention. So when I moved out of the teaching hospital in 2006 and moved into a corporate hospital, and the children
the children with retinoplasty continued to come, but then there was no way of imaging them. So I was wondering how do we document these patients with retinoblastoma. That's when I found that like we all of us have these cameras lying around inside the house somewhere tucked in. So I was wondering if we can use this to image the retina. So, and then we needed a powerful light source also. So found this torchlight which can be mounted onto the handicap which we had. And this expensive looking intricate equipment what you find here was sourced out by gaslighter. So we took it out and cut it and put it onto the flashlight holder and then put the light, and then we had this video internet. So this was actually the first time we used the handicap or any camera to image the fundus. And subsequently this is how you do it, like you do a monoclonal indirect ophthalmoscope with the light in one hand and the camera in one. And these are the images which we could get, and the purpose was solved. We could image these children with retinoblastoma and document them. And Divyansh was a postgraduate that time, so he used a mobile phone. He took this concept forward and used a mobile phone. We probably were the first to use these devices to image the fundus, but then he went on getting award after award in Andhra Pradesh, but then it didn't publish. But then subsequently somebody else published, and then he used the mobile phone for doing indirect ophthalmoscopy. Some of the images which we get, we are doing the mobile phone. Then we went on to make this as a direct ophthalmoscope. So this 10 rupee diode and a light source, keep it very close to the phone. You can convert the mobile phone into a direct ophthalmoscope. The flashlight which is there existing doesn't work because there is no distance between the camera and the flash. So we need to have a light which is very close to the camera, and these are the images which you offer direct ophthalmoscope. So you don't need a 20D lens, you just take the phone and attach this light and you can create direct ophthalmoscope. And we went on to compare this with existing devices. There are some 3 or 4 devices which are direct ophthalmoscope that can be used for bracket screening. And we found that this device, which cost about like 100 rupees to make, was as good as any other commercially available device in detecting diabetic retinopathy. One of the dreams is to have the indirect ophthalmoscope so inconvenient to carry. We're trying to see if we can create indirect ophthalmoscope which can be put into a pocket. And we used to have this device way back in Sarkhej, which was intraoperatively used indirect ophthalmoscope for surgical purposes to extract the public. And then we find this device, that you can find this illuminated reading glasses. You can like buy it off Amazon or Flipkart. So where you can read in the night in the bedroom without disturbing your spouse. I don't know why you need to lie down in the bedroom with your spouse and then read and then not so they can go on to the narrow that is all game. But then you find the offshoot is you can use this to do the indirect ophthalmoscopy. Of course, Divyansh has been guinea most of the time that you can see him doing indirect ophthalmoscopy with illuminated reading glasses. But of course, he didn't disturb his wife as well. So we tried creating this device, but then unfortunately, it's so easy to create actually. It's like a mobile phone, you just charge it with a mobile phone charger, put it on, switch it on, and then do it. From the order, saying, Doctor, I think I have a detachment already. So he came over, this was just about like 4-5 days after the fake Dr. Lens. So he came back to Bangalore and his honeymoon was to Sarkhej hospital because he flew directly and got for surgery. And made me thinking, we are just putting a fake Dr. not the anti-segment surgeon putting the fake Dr. Lens in the anterior segment. How does that cross the retinal patch? So we wanted to see if we can recreate this situation by doing this like near Apple view. That is like they cut the eye, put it there, and from back you put a camera and see from behind what's happening. So but then like we can't do this for like what happens to vitreous. So we're trying to see if we can put the endoscope through the optic nerve and then try to manipulate the anterior segment and see what is happening to vitreous. So this was how the thought process came when I wanted to see what was happening. But like, the problem was like by the time I put the endoscope through the optic nerve, the globe collapsed and we couldn't do anything with that. But in the process of experimenting, put the endoscope on the cornea and we found that we could image the fundus. So this is essentially the red cam. So you can have an endoscope, you can put it on the cornea and image the fundus. That's how the red cam is. So this is, you can use this tool as a pediatric imaging tool. So that's how we came up with this. So you can see the nasal endoscope, which is used to image a child with retinoblastoma. Currently, there are many other devices which we have been working on, which is extremely cheap to create, but then hopefully we should have a very cheap fundus camera, not as expensive as 35 lakhs to a crore for this particular purpose. So there is a comparative image of an endoscope versus a commercial camera. One day I was driving back from my hometown and there was a lot of glare and we used one of these polarized glasses and you know that the polarized glasses give you a much better vision. But we need to see can we use this in ophthalmology. So there's a 32-year-old lady with subretinal hemorrhage and we used gas and anti-VEGF to dissipate the hemorrhage. And subsequently found the patient had a cavernous anemia of the optic disc and which was treated with photodynamic therapy way back and it did regress. But then there was some amount of disc because of subretinal hemorrhage and the PDT and she had decreased vision. And you can see that when we try checking her vision, she's having difficulty. Like she's moving ahead this way, that way. She's not comfortable. So now you just put this polarized filter. There's a commercial polarizing filter which is available for the cameras. So you have to keep tilting your head. Now you see how much her vision improves with just the polarizing filter in place. And you remove it and she literally asks for it. So the polarizing filter does improve the vision and we used it as a study and found that like in diabetic patients and macular edema because of many other diseases like vein occlusions, AMD, PFD, and even in optic nerve lesions like NAO and optic disc diabetic, we found that like in 78% of the patients you can improve the vision by one additional line. So, and the effect of the light source, if it's a tungsten light or the metal halide light, that also has an impact on it. So polarizing lenses, we found that with this polarizing lenses, these are circular polarizers, not the regular polarizers which we have in the squint clinic. These are circular polarizers. We found that like, they can improve the vision, and we have actually received an Indian patent for the same. And when we call this, like we need an array of polarizing lenses to see which patients improve, which patients don't improve, what is the type of polarization which we use, and we are still working on it. We have not come to giving it as a mark or giving it to the patient as yet. So this is once again Divyansh, when he was a fellow, he was having difficulty doing still buckling to localize. So all of us know that like whether it's a sharp localization or the thick localization is difficult. So we came up with this using the 20-gauge illuminator, 20-gauge illuminator, use that to localize. So that way you know exactly where the dip is. So and the false localization is something which is not something which happens with the illuminator. So you can use a 20-gauge light to localize. I'll just take another couple of minutes. So similarly, you can create an illuminated cryoprobe. So like a light pipe which is broken, remove the tip and the naked fiber, fix it with a small piece of the IV tubing to the tip of the cryoprobe. So you can create an illuminated cryoprobe. Once again, precisely where you want to cryo, you know that the light source light will be there and you can precisely cryo rather than wandering into the shaft of the tip. So you can see this is the illuminated cryoprobe in action, and you know exactly where the tip is, and we can precisely do the cryo there. And you can do it as a standard system with the same broken light pipe, remove the handle, and then put a small piece of the buckle which we throw away, like the 240 band. just make a small hole in it and thread the light back through the naked fiber. So you can create an illuminated like a Shanghai system, VRAG Shanghai system. And there is this micropulse laser therapy all of us have been looking at, and then people, some of us have the machine to do a micropulse laser therapy. That got me thinking, so micropulse is a very mild laser, so is it something which we can try with just the sunlight which is there? So this, we came up with this photobiomodulation concept. Again, once again, we have an Indian patent for this. We have this we created this 577 nanometer filter. So use this filter, and the patient was asked to look at the sunlight. So instead of the micropulse, which is a low level laser, the 577 nanometer light alone goes into the macula. So the patient was supposed to look at the sunlight for about 10 minutes or 5 minutes in the initial phase of the study. So this patient was a decalcium DME. He had reactivated to internal steroids, PPPL, but you can see the edema still persisting. And this is post the photobiomodulation with this 577 nanometers. You can see the edema is going away. It's not as though it's gone away completely, but you can see it's decreasing. And at RV crossing now, you can see that the visual field effect because the edema is actually decreased, not worsened. And in contrast, you can see the other edema has not got any better, in fact, it's got worse. And like post-treatment, whether to know if the concept is working or not, you have to stop the treatment. So you stop the treatment of photobiomodulation, you can see the edema is coming back, showing that the photobiomodulation works. It's in addition to whatever treatment we are doing. This is a very short, small study. We found that 70% of them responded favorably to photobiomodulation. So we're in the process of finding alternates to only the sunlight. That's something which we are doing. So it is possible to do meaningful research in your clinics, and there are problems everywhere which are there to solve. And identify the problem as create a solution. If yes, think about it, and sometimes the answer will pop in the head. For me, it's usually early in the morning. There's a saying in Tamil which says, so it's a little difficult, but then it says, even a blade of grass is a worthy tool for the capable. They should think of me as a monkey. Thank you so much for your kind attention.
And it makes us all think about something similar to what Sir has achieved. And simple thinking, and it comes to very effective outcomes.
So I think we all know Dr. Mahesh, one of the biggest innovators, and they form a great team with Dr. Divyansh. So just a simple question, of all these, which one do you use the most in your current practice as of today?
Probably the endoscope. Endoscope is something which is available, which I use it quite often, because for quite some time, until a couple of years back, we didn't have a wide-angle fundus imaging system for pediatric patients. So that's what we were using quite often. The others, of course, still need some work on it. That's what. And of course, the chandelier and the localizer, that's something which I don't use because I have gone past that stage. But for all our fellows, we do ask them to use that very commonly.
Yes.
Just wanted to share. Yeah. So I was wondering whether you are thinking of putting the polarizing into the glass like they do for the polarized glasses for the Formula One and the bikers and that kind of a thing.
Correct. You're asking as a part of a spectacle.
Right. So the only downside, when they give you the Polaroids to check them out in the stores, that Westside and Usme, they give you glare cutters. When you put on the Polaroid, like they show you you're driving at high speed and there's sunlight on the hoarding. The minute you wear the polarized, you can see what's written on the hoarding. Or they show you water on the road, and you put on the Polaroid, you can see the fish in the water. The only downside is it takes away the electronic displays. That means if you're using it for driving, you cannot see your watch, your mobile, or even the car displays. I just thought I should share that.
Okay, and I really don't know exactly whether this is how it's going, because this is what we are looking at as a circular polarizer.
Circular polarizer is different from the linear polarizer. So circular polarizers probably don't have this side effect.
Right. So I just think that needs to be looked at.
Sure, thank you.
Divyan, any comments? Yes, sure.
Sir, I questioned the cryoprobe with endo illuminator what you showed. Can we use it for the tumor cases and as an endo, like trans-illumination for?
Yeah, trans-illumination, the problem in Indian people doesn't work too well. So in Western population, when you go there for a fellowship, they show you beautifully, but then we have pigmented RP, so trans-illumination as such, I do have a regular trans-illuminator as well. But I don't use it commonly because it doesn't work too well. So, but of course you can use it, but the light intensity with the 20 gauge light pipe is not too great. So it may not be as good as what you would want to use with trans-illuminator, but definitely you can use it.
Yeah. Any comments? Anybody else who's come up with some indigenous innovations, they can share it on this platform.
Plus inspired.
So that's why we have Mahesh, Divyansh, I think we all get inspired by having difficulties in our situations, daily situations, and we try to. Yes, sir.
Just one thing. This is related to a different kind of thing when we are doing buckling procedure and when we try to localize our hole. The way I try to see from aura to that hole in the kind of a disc diameter. Say it's 4 disc diameter, then it is multiplied by 1.5. So I have to put my first suture once they are 40. So I don't struggle with the localization. If you follow this pattern, probably the localization will be much perfect and without any struggle.
Very practical comment. Any other comments? Yes, Ramesh.
I have a question for the localization itself. So once you start the cryo, does the cryo reaction actually lose your illumination source, in the sense you don't know where your means the reaction actually whitens the entire thing, or it is just that you're assuming that everything is in place?
You can still see it.
So as you could see that the trans-illumination is seen, and you would see the cryo around it as a cryo reaction. So it would be, there would be one area where only trans-illuminated and the other area would be showing the cryo. So this is because when I was not able to localize the cryo correctly and do the cryo correctly, this was my initial years, and we are assisting to show the students and our fellows also, because the false localization is the biggest mistake which we do it in our department.
I would like to add from learning from the sir, one of the presentations which inspired me was that humble needle. So a lot of times in diabetic cases we don't need those scissors and forceps. So I've been starting a lot of cases using 24 gauge needles and it is working wonderfully. So I'd like to thank sir for that. So we would like to felicitate Shanmugam sir. So I would request Dr. Bhavesh Kama sir to come on the podium. Mahesh.
Just a minute. Yes, sir.
Hello. Hi, sir. How do you use endoscope actually? And is it possible to see in all technique for pseudophakic eyes?
Sir, can we talk over that in the break, because we have a very long program? We'll ask him to say any details in the break, because we all want to learn that. So I promise you, he will tell us in detail. Promise. Sorry, sir. Yes.
So I invite Dr. Vishal Kedia for his presentation on novel protocol of treating zone 1 aggressive retinopathy of prematurity. Dr. Vishal.
Good morning everyone. Thank you for inviting me for this talk. My topic for today is novel treatment protocol in Zone 1 aggressive retinopathy of prematurity. No financial interest. AROP is a severe form of ROP, involves Zone 1 and posterior Zone 2. It's a rapidly evolving plus disease. Neovascularization can even be very subtle and sometimes intraretinal in nature. AROP, if not treated early, can lead to detachment and blindness very quickly. So the objectives were, it was a prospective case series with 1 year of follow-up. Novel treatment protocol involved treating all the Zone 1 AROP with intraretinal anti-VEGF injections first, followed by early laser in either second or third week, only to the Zone 3 to meet the following objectives, either regression of AROP or look for reactivation of AROP. Informed consent was taken from all the parents. Inclusion criteria involved only Zone 1 AROP cases without any prior treatment. Exclusion criteria was no fibrovascular proliferation, stage 4 and 5 ROP. This was the study design. First we injected Avastin half dose and followed by early laser only to Zone 3 in either second or third week. This was followed by either regression. If there was any remaining ischemic areas, it was followed up with supplementary laser followed by regression. So total of 90 eyes were taken in the study. 88 were bilateral, 2 were unilateral. Laser timing was either 2 weeks or 3 weeks post the anti-VEGF injection. Second supplemental laser was required in 4 kids. Second dose of anti-VEGF was required in none of the babies. Complications were macular dragging and periretinal hemorrhages. So these are few cases. This was an AROP involving the posterior pole, post-injection and then followed by peripheral laser. The second case again an AROP involving Zone 1, showing the plus disease with flat globules and new vessels in the posterior pole. The lower photo shows the regression of the plus disease following the injection, followed by peripheral laser into Zone 3. This case again a case of posterior pole Zone 1 ARP, regression after the injection and followed by laser to the peripheral areas. This was again a case where we had a complication post the injection. So this case was a very severe AROP, basically half Zone 1, and this was given an anti-VEGF injection. Following the injection, we had a massive periretinal bleed. We waited for a few weeks. After 3 weeks, we gave a supplemental laser to the peripheral area, and then once the bleeding resolved, we again gave a second setting of laser. And this was the pre and the post images after a few months. Again, one more case of Zone 1 AROP having a periretinal bleed, flat globular neovascularization. Post the injection and the laser treatment, we can see the resolution. Also, we can see the normal vasculature formation post the periretinal hemorrhage after the laser treatment. So we have 3 options: either anti-VEGF alone, laser alone, or a combination of anti-VEGF and laser. There are a lot of studies which have shown that only laser can cause eye recurrence. There is risk of myopia, field loss and scarring. Also with only anti-VEGF injections, there are late recurrences up to almost 69 weeks. So once there is a late recurrence, the problem is the kids grow and examination becomes very difficult. Need multiple EOAs. Even after the vascularization, FFA shows that there are leaky vessels and need to be monitored. Long-term safety of multiple anti-VEGF injections is also a concern regarding the neurodevelopment. So in our treatment, we combined advantages of both the anti-VEGF and laser. We did only to the Zone 3 so that there was less field loss, also less follow-ups are required, cost-effective, and there was early resolution of the retinopathy of prematurity. Thank you.
Thank you. Rekha, your comments?
I have used a similar approach, but in my hands it didn't work. I used in some 10 cases, but those were the cases where we didn't have a growth of vessels post-injection. So I waited for 3 weeks, 4 weeks, and at the 4 weeks also there was no progression of vessels there. So I ended up doing the laser in the Zone 3 and Zone 2 anterior. Still there was a recurrence in all 10 cases. And then we have to add up the laser. So second point, the advantage what can be there for beginners in doing laser is they can add till the aura when the baby is small. Once the baby becomes big, it becomes difficult to reach the aura and laser up there. Still, if you have done a laser to the aura, you need to follow up these babies and depress the aura and see in the follow-up because there is a growth of the retina in the future. And you can still have a skip area near the aura once, even if you have finished it before. And you need to go back and add the laser in those areas in these cases.
So all these babies, the entire zone 3 was lasered, including the aura, and there were no skip lesions. So basically we left the zone 2 and waited for the vasculation. Only we had a big bleed in 4 cases. Apart from that, there was a good...
Yeah, there is a series, I suppose, there was a discussion from Dr. Subhadra ma'am.
Yes.
Where she has shown there is a development of retina anterior to it. And when you laser so early, you need to go back and see the aura 360 degree again in the future. There can be the growth of retina, and from there the recurrence happens in the future, and then you need to add up the laser in those areas. So those are the few points which I would like to add.
Shilpi?
Yes, yeah. In AROP cases, as you suggested, laser and anti-VEGF combination works better, for sure. But the timing of laser is an area of debate here, which means when to do laser. Especially when you're using bevacizumab, best is to wait for the maximum effect of Avastin to work. So, and generally in these cases, if you watch them closely, the recurrence doesn't happen before 8 weeks. So between 8 to 12 weeks, at least let the vessels grow into zone 2, mid to anterior, and then you can add on laser. By then, as Dr. Rekha said, there is a growth of eye, and there is an area, retina being developed, aura is developing, so you can add laser there. Which helps that in one sitting you can complete the laser. Meanwhile, once you have given the bevacizumab, work on the general condition of the baby, improve the anemia, oxygen management, etc., which helps. And sometimes about 20% of these, even AROP in zone 2 posterior, they do develop truly after Avastin or injection. The studies show. So give them the maximum benefit of anti-VEGF once you have injected.
Many of these babies were doing very badly in the NICUs, and the risk was getting them again for follow-ups, multiple follow-ups. So the idea behind doing an early laser was to reduce the VEGF load, so that hopefully we don't lose an eye, and we are doing laser to only the zone 3, so we don't lose that much of the visual field. And early closure of the RP.
I think a very good point that Rekha has pointed out, that, and when you are saying that you are lost to follow-up, and don't tell the patients that I've done laser, so now follow-up is not an issue. Okay,
yes.
I don't differentiate follow-ups between anti-VEGFs and laser. All my ROP babies have to follow a strict follow-up protocol. So don't talk about it, even in the podium. Tell everybody the message should be follow-up is absolutely necessary for any ROP baby, whether you give laser or anti-VEGF. That should be very clear.
Usually,
that should not be the reason why you're giving laser.
Yes.
Okay, don't give this message. It's very, very clear. And I think the second point, as Dr. Shilpi said, most babies, when you use Avastin, very few babies would need early laser as compared to when you use ranibizumab or other biosimilars. Mostly, 90%, 95% of the cases when you use ranibizumab, they will need early laser or they will need a repeat injections, particularly in AROP cases. They do not respond well. So for AROP, as of today, amongst the ROP experts, bevacizumab is the drug of choice. That's beyond doubt. Last question. Yeah.
You brilliant results with, I think, recurrence rate of 4 to 5%. Just thinking out loud, could you keep the other eye as control? I mean, you can do laser in one eye and probably just keep the other eye under, your intermediate injection. Is that something that might...
No, I don't think that would be ethical at all.
The small kid.
Because there's no fixed protocol in terms of you have to do the injection with laser. So is it possible to study the progression?
Unfortunately not. That's why nobody has come out with such multi-center
One extra point about the follow-ups which you were telling. So we are coming with the guidelines, Indian ROP guidelines for anti-VEGF in ROP. So we need to follow up these baby at least every 3 weeks post-injection, at least. Okay, so when you are in zone half or zone 1, you need to follow up more frequent, 1 or 2 weekly. Once they crosses zone 2 posterior, they reaches to zone 2 anterior, then you need to follow them every 3 weeks till you get a full vascularization or you have laser to follow the avascular retina. So those two are the deadlines there.
When I give a treatment, whether it is anti-VEGF or laser, and the first consent that I take is that your follow-up is lifelong.
Lifetime.
You have to tell the parents. because it's not just the anatomic response. You're going to have your refractive errors and a lot of other things when the child grows older. So I think it is very important at the first counseling and first consent, you tell the parents that any ROP baby which is treated, irrespective laser anti-VEGF, it is a lifelong follow-up. Thank you. I think we'll move on to the next.
Thank you, Dr. Vishal. So now I invite Dr. Ramesh Venkatesh. So currently Dr. Ramesh is a consultant at Gandhinagar, Bangalore, and he completed his research from clinical year fellowship from Sarkhej, Chennai. And he is again an avid researcher. He has strong interest in his academics as well as patient care. He is also authored numerous publications in peer-reviewed journals, and his more of research is centered on the retinal imaging. So today he is going to share his experience with Affiliate set. So over to you, Dr. Ramesh.
Thanks, Kushal, and congratulations to VRAG on their first meeting. This is a great thing, and I've never seen a full house like this at 9:30 and 10 o'clock in the morning. So I'll be sharing a few cases of treatment with aflibercept, and it's not going to be all great cases where the outcomes and the fluid keeps resolving, but I'm going to show some interesting findings in these cases. So let me just start with the two cases. The first one is a 74-year-old male with a known case of age-related macular degeneration, complaining of blurred vision in the left eye since 1 month, with a visual acuity of 6/9 in the left eye. And when you look at the fundus photograph, what you see here is that there is probably a grayish yellow lesion which is there just temporary to the macula in the left eye. And the OCT actually shows you that there is a precoroidal cleft and there is a CNVM which is there next to it and a Schlem overlying it as well. So this patient was then treated with the first injection of aflibercept 2 mg, considering it as a treatment-naive neovascular AMD case. And 1 month later, though the patient did not complain much, his vision actually had dropped from 6/9 to 6/15 in the left eye. And this is what you see on the first month post-operative visit. You can see that there is some kind of an atrophic patch which is there just on both the sides. And when you run the OCT scan, you can see that there is an RP rip which has developed, and there is an RP tear which has happened in the larger extent. But what's interesting is the mirror RP rips. So this is a very, very rarely seen double mirror RP rips, very, very rarely seen, especially in a large TED which is containing or harboring the CNVM to the entire extent, and therefore the rip has contracted in two opposite directions, and therefore you have the band of the scrolled up RP in the central area, and that is what is giving the impression of a mirror RP rip in this case. So this is 2 months after where we stopped the treatment, and this is where we found that things are still stable and the vision is still 6/15 in this patient. Let me show you the second case. Again, a 74-year-old gentleman, a diagnosed case of neovascular AMD, right eye already lost to a scarred CNVM, and left eye diagnosed elsewhere with an active AMD with a presence of a pre-existing RP tear. So the left eye initially was treated elsewhere with ranibizumab injections, couple of them, and it was a long time since the last injection was given. And when you look at the photograph, what you can see, this is the pre-treatment photograph. You can see an inferior RP tear which is there, along with the subretinal bleed which is there in the left eye. The autofluorescence clearly showing you the RP tear and the atrophic patch. And this is through the macula, which is showing you the CNVM. There is a type 1 CNVM with probably some changes as well, and the neurosensitive detachment. And this is through the area of the pre-existing RP tear. So this patient was treated with the first injection of aflibercept, which is a treatment switch case. And when you look at this second image, you can see now there is a fresh RP tear which has developed immediately after the first injection. After a month, and this is where the autofluorescence is now going through the macula and showing you the fresh RP tear. So this patient takes the second injection of the aflibercept, and what's surprising to us is the development of a third RP tear which develops immediately after the next injection as well. So these are three RP tears or sequential RP tears which are developing immediately after the injections with anti-VEGF. So we also gave the third injection, considering we may probably see a fourth RP tear, but that did not happen. And therefore, I just want to look into the factors which actually cause the sequential RP tears. What is the role of choroid? Because what I was observing in these OCT scans is the choroid in the area of the RP tear was much thicker. Does it contribute to the development of the RP tears? And does the choice of the anti-VEGF make any difference in causing the RP tear?
Thank you, sir. So we have another cellular talk with the biocellular. So before that, we would like to felicitate Dr. Ramesh Venkatesh, sir. And so I would invite Dr. Manoj Bhatt, sir, to please come on the floor. So the next case we will be taking such a time. Manoj.
I think we'll take the two cases together and have the discussion because they are similar cases.
Thank you, sir. So the next case is by Dr. Rutul Patel. So he is showing the management of RP tear in wet AMD with biosimilars. So over to you, Dr. Rutul.
Good morning, everyone. My topic of presentation is management of RP tear in wet AMD with the biosimilars. As you know, anti-VEGF is one only very breakthrough treatment for AMDs as well as PCVs. And RP tear is a rare complication in the treatment of patients with acute AMD. It can result in a vision loss, as we saw earlier with Dr. Ramesh's case. And this can happen as a natural course of the disease also after the treatment of AMDs with the anti-VEGF or PDT. Coming to the epidemiology, it was first reported in 1981. And it's part of the natural course of the treatment after the treatment of PED due to the occult CNP or RAP or the PCV, and the incidence is reported between 5 to 27%. Coming to the diagnosis, in the imaging part, color fundus, you can see the subretinal or sub-RP bleeding, as well as hyperpigmented area where the RP is rolled out, and the depigmented area where the choroid is exposed. And Sarkhej has introduced grading system from the color fundus photography as well as FFA. Grade 1 is less than 200 micron of the size. Grade 2 is between the 200 micron to 1 disc diameter. Grade 3 is more than 1 disc diameter, and grade 4 is the grade 3 which involves the center of the fovea. In the autofluorescence, we can see the reduced autofluorescence because the RP containing the lipofuscin is lost in the area. And in FFA also the same area will be showing hyperfluorescence because of the side of the exposed choroid over there. In OCT, we can see three compartments. The first part where the outer retinal bands are normal. The second part where the retina is forming a dome shape because of the detached RP from the choroid. And the third part where the RP is completely absent. Now coming to the mechanism, how the RP tear formations. It may occur as a spontaneous process or following the treatment after injections or PDT. And this is due to the contraction of the fibrovascular membranes after the treatment. Here we can see this image, there is a fibrovascular membrane toward the left side, and the other side there is a force of the attached RP, and after giving injections, the contraction of the neovascular membrane gives an opposite traction. So because of that, two separate tractions, the tear occurs in the area of the white star which is shown over here. Now coming to the predictive factors, it is very important to see prognostic markers before giving injections in particular situations. Like first is the PED lesion's height and the diameter. As you can see, there are different opinions for the cutoff point. Larger the PED diameter, more chances of RP tear formations. And the cutoff points are different in different studies, but mostly above 400 microns is the cutoff point. Coming to the IR image of the PED, where the hyperreflective lines which are shown in IR image, which is a predictor of the detectable stress in the CNV under the PED. Coming to the third point, that is the CNV to PED ratio. If the CNV size is less compared to the PED size, chances of contraction is more and chances of RP tear is high. Coming to the micro dips, which is also a first stage where you can see the earlier changes in the RP. Coming to the fifth part, there is subretinal cleft, which was seen in the first case of Dr. Ramesh, where the cleft is seen, which is showing the increasing mechanical pressure in the sub-RP space. And the duration of PED, interestingly, the fresh PEDs are more prone to develop RP tear because the neovascularization is very fresh and it responds very dramatically with the anti-VEGF. Now coming to the therapy in high-risk patients, how we should proceed further. So you should carefully look for all the risk factors, and if one or more of the risk factors are increasing, we should wait for 2-3 weeks, and if it is reducing, we can further continue with the injection treatment. Now coming to the higher potency of CNV contraction which are seen in the normally adolescent or chronically fat, the chances of developing RP tear is more. Now coming to the therapy after the tear formation, we should definitely have good chances of vision improvement even after re-injecting after the RP tear. But definitely we should look for all the parameters of the risk factors for further developing RP tear. Now coming to the case,
go through fast.
yeah, so 87 male with a right eye, the vision loss comprehensive is 1 year, the otherwise was 2 feet vision because of the scar CNV, and the presenting eye was 636 partial. Here you can see a large RP tear just temporal to fovea. And this IR images also show the RP tear. Now first intravitreal ranibizumab pass injury was given in the right eye. And there was a very dramatic response and the vision improved to 618 with the flattening of the PED. And again monthly injections were given with the biosimilar and vision improved to 612 after the second injection and it maintained to 612 after the third. So you can see the pre and post treatment after the injections.
Thank you.
So, Mary sir, I would like to have your comments on how will you proceed in such cases which have developed RP and what will be the molecule of choice for it?
I am not aware of any particular molecule is better than the other. So I will continue the same treatment, whatever it is. The key part is to continue the treatment. So otherwise, like they may have an issue. So I will continue the treatment, whatever they are on.
Any preference for the panelists on using any particular anti-VEGF in certain situations? You know, people talk about PCV or myopic CNVM. Is there any particular preference on using any particular molecule?
PCV, yes, 80%.
Please.
Or PCV, yes, 80%.
Anybody else, sir?
More often I would be using 80% right now because the newer ones are showing some promise, but then bevacizumab with some inflammation is there. So it has got a wow effect, and the faricimab doesn't have an early like improvement. So most often I prefer 80% this time.
So just a show of hands, how many of you are using crowne or Patinex as the first line? And how many of you have seen complications due to Patinex? Be very truthful. So almost all who have used Patinex have seen some form of complications. So that is again, I think.
Yeah, but like the VRAG study, we have shown that the incidence is quite less as compared to what is reported in the literature. So it is reasonably safe. It's not that it's that common like what was reported earlier.
Regarding the choice of the antibiotic, which you said that there's probably nothing, it's no anti-VEGF is going to cause an RP death. But when you
I didn't say that. I said that like, there's no difference between
difference between the anti-VEGFs to cause an RP death. But if you look, when do you think an RP death can happen? Then the vascularization retracts or contracts very fast. So if you have more potent anti-VEGFs, it's probably a brolucizumab, which works better at sub-RP fluid or sub-RP membranes, then would it cause more RP deaths according to you?
As I mentioned, right, so I said that you don't have a literature support to say one is better than the other. So what I say will be my experience, which is not what is accepted. So I don't see a literature support to say one is better than the other. That's what I'm trying to say. So whether what I will be using is different. But then it's anecdotal. So you need larger studies with comparing all of them to say that this is the incidence of RP tears. But from what I understand, the RP tear incidence in any of the applicants seems to be the same 100%.
There was one, I have done a blind multi study of using various biosimilars. So it's a totally double-blind study of all the biosimilars that are available in India. And how this came up is I started using bunches of ordering 5 or 6 from each this thing in a blind fashion, and I've used that in AMD and diabetic and followed them for 2 years. So totally blind, and it was like for the CMV it was a fixed protocol of giving 3 loading doses, but for diabetics it was on PRN, and a 2-year follow-up showed absolutely no difference in any of the 6 biosimilars that I have used in, and we just presented at the KSRS meeting. So as we said, when we talk about the efficacy wise, I think it's almost same around the whole spectrum of the biosimilars.
Because you compared it within the biosimilar group itself, which was ranibizumab.
So I don't have biosimilars.
Yeah, but when you compare it with bevacizumab versus a more potent molecule, probably like an aflibercept or this, because I have seen literature which actually says that potent anti-VEGFs, which have got deeper penetration and faster regression of the neurovascular has got more chances of it happening in those cases.
I don't know. I mean, personally,
one more kind of practice which is followed in few cases I have seen that half the dose they are using at frequent intervals. In such cases where there is a large PED, half the dose of the normal anti-VEGF, and it is frequented after a shorter interval.
Similarly, does that use pegapenic but then move on, it's got a less efficiency, so it doesn't collapse the PED. But what I'm trying to say is, if you look at the RP rates based on every study, it's the same. So the cases are different, I agree. But there's no, the RP once again is so rare a complication to say that like this many will increase with particular anti-VEGF is something which we don't do. That's exactly what I'm trying to say. 1 year, the lot of system acts very, very rapidly, it can cause increased risk of RP, but the numbers in the studies is not there to say that one is better than the other. That's what I'm saying.
And I just wanted to know your thoughts on tone of choroid, because what I observed in my 2 cases is that wherever the red was happening, the choroid was very boggy and thick in those cases. So do you think that the choroid is actually contributing to
The second case seemed to be a little different. It had those like multiple hyporeflective areas. So there seems to be some other predisposition in the second case where they developed third RP area. So I'm not too sure if we can bunch it up in the previous case to this. Frankly, I don't know the answer to your question of whether the choroid has any factor to play. But for me, the height of the PED and whether it's fresh and the extent of the PED are the factors which cause
this way. This way.
Please use the mic.
Any role of steroids would be maybe a week or so, not diabetes, of course.
Whatever I say will be anecdotal, so I really don't know whether we can use steroids to treat this. But we have published along with Raja, we have published steroids plus anti-VEGF in PCV patients or patients who are resistant to anti-VEGF. So there we have used the steroids plus anti-VEGF and we found that it worked better for regression of the disease, not for the RP.
So, one comment before. So we actually published on Ahmedabad as well. Oral steroids for very high PEDs to reduce the exudation prior to injecting, so that it decreases the chances of RP. So steroids will not affect the course of polyp treatment or recurrence, but they definitely reduce the chances by reducing exudation. But if you reduce the RP? Yes, actually. It can actually flatten out completely before you inject.
Anybody else? Any different views on using different molecules? How about the Pagenex people? Can you comment on your experiences? Milan, you are a very prolific user of Pagenex.
I have not observed any of the RP reef after Pagenex, not that frequent. As well as the IOI part regarding Pagenex, touchwood, I have not experienced that after Pagenex.
I have seen 2 of your cases anyhow.
Maybe directly reached to you.
So that's okay. I think we have cases on that. So we will have a discussion on the adverse events following anti-VEGFs. I think now,
Just
last question.
Comment on Dr. Aditya's, there's oral steroid for large PEDs. Basically, majority large PEDs are seen in PCVs, where we have seen. And PCV is a pachychoroid disease. So oral steroids may aggravate a pachychoroid disease because CSRs and all, it's a end stage of a pachychoroid disease, PCV. So whether it will not increase the pachychoroid etiology behind it?
In fact, we always saw favorable response. With number two, we also published our RP with recalcitrant subretinal fluid. So there was a very large PED, and because of that, all of that transferred subretinally after it retinal. So it was not responding to anti-VEGF. So we actually primed the patient with oral steroids. That reduced the height of the subretinal fluid as well, the volume level. And then we injected, and then it happened.
So the etiology was not pachychoroid or just a wet AMD or?
Wet AMD. So not just PCV, in wet AMD also for recalcitrant fluid, the course of, because ultimately it is inflammation. So any form of anti-inflammatory therapy. And why oral? Reason being the location of the disease, the outer blood retinal barrier, as opposed to the inner DME. So possibly oral or subtenon route would have better access to that, as opposed to intraoral.
What is the... So I think we'll continue the discussion. The session is not over. But we have a very exciting session in store now. Dr. Gaurav is going to join us from San Francisco. And we have planned a very interesting panel discussion on management of retinal detachment. Dr. Gaurav practices in the West Coast Retina Medical Group. And he is a graduate of the University of Illinois. And he did his internship at Kaiser Permanente, followed by a residency at the University of Minnesota, and his retina fellowship at the Wills Eye Hospital. He's won numerous awards and honors, including the inductee in the Retina Hall of Fame, American Academy Senior Achievement Award. He's an avid traveler, and he does a lot for the Indian Vitreo Retina Society. He's a very active participant for all our VRSI meetings. And incidentally, he is one of the main organizers for the upcoming American Retina Society meeting at Los Angeles. So over to Gaurav, if you can join. And we welcome Gaurav. We are a full house and we are awaiting your panel discussion. Yeah, we can see your slides and can see you.
Slides?
Yes, we can hear you also. Can you hear us?
Yes, I can hear you. Thank you so much. I can hear you just fine.
You can start.
Okay. I was able to hear you, but I think hopefully you can hear me. So first of all, thank you for allowing me to present some stuff that hopefully we'll find interesting. So I wanted to talk about phakic retinal detachments and all kinds of retinal detachments. So I will, there's a lot of stuff to get through. So this is from a paper that we did looking at how people fix retinal detachments. So I will ask you, 55-year-old phakic superior retinal detachment, what's your procedure of choice?
I'm not supposed to answer. We have a panelist. So let's say, Mahesh, just one sentence answer. We want it quick because we have 5 cases.
I do still buckling.
Buckling. Manoj Bhai.
Buckling.
Milan.
Buckling.
Mudit. Divyansh. Pneumatic. Ramesh is doing pneumatic.
Buckle. Okay, it's interesting.
Pneumatic.
Buckle.
So we have two pneumatics.
Buckle versus pneumatics.
Yeah, we have 2 pneumatics. Sangeet and Ramesh are for pneumatics. The rest are all buckles.
Okay. So if I was this just shows you that what is being done currently. In the US, 56% pneumatics. In India, more buckles. South America, half and half. And Europe, actually buckle as well. So 54-year-old phakic. So between half and half. But pneumatics, as you'll see, could be a good procedure for this patient. One solitary phakic detachment. Now, how about this one? 35-year-old phakic
if I can
with an inferior detachment. Everybody's in agreement that buckle is the way to go?
Can I ask you one question pertaining to the first case? Do you think the geographic distribution plays a role in deciding the procedure? Like in India, we have a different type of population who's traveling, who cannot come for frequent follow-ups.
Yes.
So do you think people are more, doing buckles because of that rather than pneumatics?
Probably. I think it probably depends on where you live and if the patient comes back. But I do think that, pneumatics require much more follow-up. And as much as I love Rajiv, who's a good friend of mine, I think you have to be careful with pneumatics, as we'll talk about, that, when they don't work, it can be an issue, just like every procedure. So I do think you have to keep that in consideration. It requires a lot of follow-up. Okay, so 35-year-olds, I think most people just showed, even in Europe, India, South America, that most people typically would do a buckle. Now this is where it becomes interesting when you have a 60-year-old phakic patient with an inferior retinal detachment. So the options obviously here, scleral buckle. There are some people who do a buccal vitrectomy, as you can see, both in the US, Europe, India, and South America. And there's some people who might take out their cataract and do a vitrectomy and no buccal. So I'm curious to see in the panel what people will do here.
Can we start, Mahesh? Quick.
He has a PVD.
I will go gel buckle to the inferior.
Okay.
Gel buckle.
Manoj bhai?
Single break, buckle.
Milan?
Obviously, buckle.
Anybody else doing something different? Yes. Sangeet? Yeah.
If there's a PVD involved, patient's age
60-year-old.
I do a primary treatment.
So even if it's a phakic eye?
Yeah, even if it's a phakic eye, because the patient is going to.
And what kind of tamponade do you use?
I use gas only.
Gas. So Sangeet says primary vitrectomy with gas.
Primary vitrectomy with gas. So it's interesting. I see more and more trend towards this. But when I look at least patients we see here, the people who tend to fail are the ones who've had this procedure, vitrectomy, where everybody's vitrectomy is very different. But it's the younger vitrectomy patients in their 50s and 60s, I see a failure where the vitreous is abnormal. So you might think they have a true PVD, but when you go inside the posterior vitreous base, or they've got an abnormal vitreoretinal adhesion, and these vitrectomies, when they fail, they just don't do well. So for me, the procedure would be a buckle, but I think it whatever works in your hands. But this is where it becomes a little tricky. So you have not obviously seen my slides, but we talked about a tamponade, the tamponade of choice. So do most people there in the panel, because obviously I can't see everybody, would they use SF6 or C3F8 or silicone oil?
Yes, can we start? Can we have more microphones here? Yeah.
Yeah, I would probably use gas. It could be C3F8 or SF6. If there is no PVR, the simple detachment inferior.
So can I just add, if it's a single break and if it's a multiple break, does it differ? Your choice of tamponade?
My difference is like inferior detachments, multiple breaks, I would put an NSET latch. So if I put an NSET latch, then it doesn't matter what gas you use.
Manoj bhai?
Same. If you put the belt buckle and then even if multiple breaks, no PVR, I would use gas.
Same here, gas.
Madit?
Any inferior tears, I would put the belt buckle.
And tamponade? Mostly oil, okay.
So I would want to use PFCL.
So what was the, because I have a hard time seeing everybody, like, what was the consensus?
So most people say that if you have multiple inferior breaks, they would like to put a encerclage, a 240 band, and then the choice of tamponade would be mostly gas. A few people would like to use oil. But if you have multiple inferior breaks.
I just did a case with 2 inferior breaks, and I actually used fibrin and air, and patient did fine. It was a one-eyed patient who had to travel, had to go over mountains, and so I learned this trick from our colleagues there in India, and but I have been using. I typically don't use C3F8 unless there's some reason to use C3F8. I think gas long-term in the eye can have deleterious effect. At least for me, that's been an issue. So I try to use some tamponade that is there least amount in the eye, at least for me.
Only when it is required gas. Why do you require gas in such case? If you have proper focal height, then you see that the retina is totally flat. Why do you want to put the gas in, if at all? In some cases, yes, but not in all.
You would just do a buckle, no vitrectomy.
It's not required, no?
Yeah.
If you have enough focal height and all that, you know.
Yeah, so as Gaurav mentioned, I think Udit Tyagi from Hyderabad does a lot of the glue, particularly for inferior breaks, and now he's not even putting any tamponade. He just puts glue and that's it.
Can you ask how many of these?
So I'll let that was the first case.
Just 1 minute, Gaurav.
I didn't want to go into the notes.
Yeah, Gaurav.
I didn't really, I never used it. So I did put air, but maybe as I do more, I will do no tamponade.
Anybody using glue?
Again, that's if I would do a vitrectomy. No. For this patient, I would have done straight buccal and drainage. Okay. On to the next one. Pseudophakic superior retinal detachment, single tear. Now you also have inferior lattice and break. So what I'm trying to figure out in pseudophakic detachments, you know, what drives you towards putting a buccal on? Is it the breaks? Is it a little star fold next to it? Is it inferior location? Or is it multiple breaks? Or is it blood? So maybe for the panelists, if you have a pseudophakic retinal detachment, what in the eye leads you to putting a buccal on? This is kind of a key question that everybody has different answers for.
Can we start, Mahesh?
If there are multiple breaks and inferior breaks, and the vitreous is still attached to the anterior flap and a posterior migrated vitreous breaks, I would put an NSF large. If it's an overplated break, the traction doesn't delete, then I probably not put an NSF large.
If you have breaks in multiple meridians, let's say there's a superior and inferior break with lattice,
yes.
What would you do?
Again, like if the lattice once again, it will prompt me to put an NSF large. So now, if it's a pseudophakic patient, we do vitrectomy. It's not all the time necessary. The first case which Dr. Gaurav showed with the superior HST with multiple breaks with no detachment, you can still get away with actually a buckle. Because we have done buckles in these patients, not as all the cases fail. It's not just a post on comparisons and so on. So, case to case basis varies. You just can't take every pseudophakic patient to do vitrectomy is not the answer. You can still do a buckle, you get away with it. So, if the multiple inferior breaks, I find that the vitreous is densely attached and postally migrated to vitreous space, I would put an NSF large in those patients.
So I'm going to stop here, Gaurav, because all the panelists, they are actually all senior retina specialists and they are all speaking about buckle. But I'm going to ask the audience, there's a very young audience, and how many people in the audience are still doing with buckle cases? You are senior, Kaushal. So, and how many people are doing primary vitrectomy with silicone oil? Quite a few, equal. So you can see the younger generation, you know, they tend to do primary vitrectomy with silicone oil rather than doing a vitrectomy buckle and a gas.
So I would just say the thing I've learned is anytime you have blood in the eye with any detachment, those are at high risk to have recurrence. So I should kind of think about which detachments I would put a buckle, which I wouldn't. If I see blood in the eye, whether they're phakic, pseudophakic, if I'm going to do a vitrectomy, if they have blood, we had a paper that clearly showed that was a big risk factor for PVR formation and redetachment. And I think whatever way people fix it, the best solution for PVR is fixing whatever procedure works in your hands the first time. So whether it's the younger generation or the older generation or what generation, the patient's only care, did it work or not? And I think you should do whatever is in your hand that works. But for me, if I see blood in the eye, they get a buckle. It's just, I've had too many times when, you feel like, oh, vitrectomy might be okay. But, silicone oil also has its own set of complications. So we have to be careful with that sometimes. So this, I think we already asked this, what is a tamponade of choice? Or inferior detachment, inferior retinal break. And now this is in a pseudophakic eye versus a phakic eye. Does the panelists, do they make any difference whether it's phakia versus pseudophakia in terms of campanile, whether it's air or whether it's SF6 or C3 effect?
So I think you have the answer right here, what I was saying. More frequent use of silicone in India, particularly with 15 years of less of experience. So that's what I was trying to see.
So I would want to prefer a PFCA because the tamponade is better, and by the third or the fourth week you can remove it, and depending whether the retina is attached, you need not have any tamponade in the eye itself. If you feel there is a recurrence, then you depend whether it's a superior or inferior recurrence. If it's still a superior recurrence, you can still manage it with the gas and avoid oil.
So very interesting. Divyansh uses short-term perfluorocarbon tamponade.
So it is medium term, so short term
For-
is 1 week.
Yeah,
So
this is
3
like
to 4 weeks. So by the 4th week, the PFCL is out.
So you use it for all your inferior detachments.
So all the inferior detachments. So we are doing a study which we are comparing. It's obviously the surgeons are different, sir is different, I am
I
different.
think there's a paper from Naresh, I think just
Yes, so
recently published.
Naresh Officer from Madurai.
Madurai.
Yeah,
They've used short-term tamponade. So, Gaurav, this is an upcoming thing, use of PFCL as a short to medium-term tamponade.
Yeah, I think that's a good approach. That is my go-to approach for somebody with a giant tear. I'll show a couple of giant tear cases. I used to do a perfluorocarbon siliconoid exchange and all of that stuff. I think which is fine, but now my go-to technique is PFO in the eye for 1 week and take it out. I think beyond 2-3 weeks, we've had patients with some inflammation. So, within a week, you've already had laser, so I just do vitrectomy, PFO, and then air afterwards. And then that is sort of my approach. We're not going to waste too much time with this. This is always an interesting thing. When people are doing a retinal detachment repair, how many, because I've kind of changed what I do now than what I did before. How many people just treat the area of the pathology, or how many doesn't matter what the pathology is, always 360 laser on the buccal?
Yes, Mahesh.
I'm curious.
360 or local?
Just local.
Local. Manoj bhai? Local. Milan? Local. Anybody different? Anybody doing 360-degree laser posterior to your buckles in a big buckle?
Just a caveat, if it's a recurrence, then I would do rest of the laser. But as a primary surgeon, only at the local.
Okay.
But
So,
it is not without the.
Okay, what was the assumption?
So the answer is most people do not do a 360-degree laser. They just do a focal laser.
Okay. I think, we've all learned over time, more laser doesn't mean better. More laser means potentially more seeing, neuritis or PBR. So I typically only treat the area of the pathology and nothing more. Okay. So we talked about this a little bit. This is an interesting discussion. So a phakic inferior giant tear, how do people fix this? And you can see in the US, the procedure choice was buccal vitrectomy. In Europe, primary vitrectomy. India, buccal vitrectomy. South America, buccal vitrectomy. But phakic inferior giant tear. Well, what about, is this true for the panelists there? Is this how they would do it?
Let's start
Buccal
with
vitrectomy?
Sangeet.
I do vitrectomy.
Vitrectomy with?
With oil.
With oil. Sir? Vitrectomy oil.
Oil with
Oil.
Anybody different? So here, most of the panelists will do a primary vitrectomy with either PFCL or silicone oil.
I see, and no buccal.
No buccal.
I see. Okay. So this has changed from the time that we did the survey, and again, this was done about 3.5 to 4 years ago. But my only rationale for putting buccal in these eyes is nothing to support as much of the break. It's really PBR prophylaxis because these eyes that are high risk. So I typically just put a very low 41 band in these eyes in phakic eyes with an inferior problem. Now here's a pseudophakic inferior GRT, and here more people are doing vitrectomy, but still in the US around almost 67% of buccal vitrectomy. So what's interesting is when people talk about it at meetings, at least sometimes you go to from the meeting, they said, I never use a buccal. Maybe these people don't attend meetings. but it's 60% buccal vitrectomy. So we were trying to find out what is driving people to doing a buccal. Is it phakia or pseudophakia, or is it the location? And it seemed like the location of the retinal detachment or the giant tear drove people to putting a buccal on, not as much as the phakia or pseudophakia part. So it's a location, location, location. And any comments on this on the audience? What the audience is doing?
Yeah, anybody doing differently? As you said, if it's inferior, most of us would do either a primary bit SOI or would add a buccal as compared to a superior break. So
GRTs put the buccal because of this more of a, it's 3 o'clock hours. The redundancy of the retina aid towards slippage, not about the temperament, but for GRT specifically, not for general orthodontics.
So there's a question that for giant retinal tears, would addition of a buccal cause problems at the edges of the GRT slippage?
I think that people have stated it. I haven't had that issue. I mean, again, I put a low line band, and again, giant tears come in different locations. There's very anterior ones, there's very posterior ones, but that has not been an issue of a buccal vitrectomy, short-term PFO, and then air 1 week later. So that's just been my approach. So I think, again, whatever works for you, but I find giant tears, people have all kinds of different combinations and permutations. But this is more about timing of retinal detachment, something you cannot do. How much more time? I have 5 more minutes?
Yeah, just 1 minute. We have a question.
So one thing, it also depends on the experience of the surgeon. A less experienced surgeon, a young surgeon, I will always advise he goes with a buccal and not do a primary vitrectomy. He goes with buccal if he plans to do vitrectomy, rather than doing whole vitrectomy.
So the problem is that we have fellows which we train. If we train them to make them decision to do a buccal, they are very worried. The problem is because they don't see it enough as clear as what they're seeing vitrectomy. So their answer will always be vitrectomy. And I am trying to explain them, no, it's not that the vitrectomy is sacrosanct and everything will go good. And then after 10 years, you would understand that probably I would have started buccal, it would have been better. But as we are suggesting, when I'm telling them, their first answer is no, I would want to do vitrectomy.
That's what I'm saying.
That's why the thought process is.
The youngsters always think that primary vitrectomy is
like easy, I can do well. So,
but at least add a belt buckle.
That's what you should add a belt buckle, but then.
Yeah, so Gaurav, you have 3 more minutes, and your slide, I would say, rather than Friday, we'll keep it Saturday because in India we work all 6 days a week.
Even on Sunday also.
Okay.
And
so,
even on Sunday.
Let's just say, let's say this is on a Saturday night, right? Like, because maybe nobody's working on Sunday, or it's hard to get operating room time. But we're always faced with this superior RD with the hemorrhage, cannot do pneumatic retinopexy. Well, when do people do this? Would they think about putting a ball in the eye to keep the macula detached until the patient can get surgery? Or what I sometimes end up doing is, if for whatever reason, I bilaterally attach them, and that works amazingly well. But I'm just sort of curious what people do to keep the fovea from detaching until they get to surgery. And again, there's a lot of background noise, so I can't really hear what anybody's saying. So I'd appreciate if you can just summarize what they're saying.
Yeah. I think it won't matter which day. If I feel that the patient has come.
No, Saturday, just one line. Saturday afternoon, Saturday 4 p.m. You are leaving the clinic, macula on RD counts.
Yeah.
Will you post it for Monday?
No, I will try to do it as soon as possible.
As soon as possible. So, as soon as.
So if I'm not able to do as soon as possible, what Dr. Gaurav is saying will be that we put the gas, given the prone position, not allow the macula to get detached, and then wait for a Monday and then operate.
Yeah.
Strict supine position, probably not matching, but as much as possible better. So.
Yes. Udit?
So if possible Saturday, otherwise, every day, depending on if the patient is coming at 6 o'clock, maybe then Monday.
Monday. Milan? One word.
Monday.
So if it's possible, same day, otherwise the next.
So people don't mind doing it on a Monday, and as you said, they usually advise the patient to be strict bed rest and they would schedule it for a Monday in their routine OT, which is always more comfortable than doing it in an emergency situation where you do not have your routine OT staff.
Okay, and what if it's your mother-in-law? What would you do?
Open the clinic, operating bed.
Okay, all right. How about this one? We always see this quite a bit, right? Then you get a call from the referring doctor, and for us it's on a Friday night, or you maybe on a Saturday night. This is the referring doctor themselves who has this, right? This is an optometrist who I saw who had this. Says, I need to have surgery like right now. What do you tell that patient?
Mahesh, optometrist.
You would stretch when there is a need. You would stretch, see if you can treat it. Just your paramedical staff are available, get reserved. Because Saturdays are the ones when you get undergoes a deep cleaning, things like that. So when there is a necessity, you do stretch. You do go ahead and create surgery the same day.
So I think why Gaurav is asking these questions is that it was a myth that whenever there is an RD, macula on, macular splitting, you need to do it urgently. And what the publications are showing us, that if you take certain steps and do it maybe 1 or 2 days later, then the visual outcome doesn't differ much. Is that right, Gaurav? Is that what you are trying to point at by this?
Yeah, exactly. I think they are urgent, not emergent or emergencies, but they need to be done promptly. I always tell people within 1 to 3 days, right? And bilateral patching works well. There's literature that shows that even macula off detachments should be done sooner rather than later, depending on what the outer retina is, and Rajiv has taught us a lot about this. But just for the audience to know, in 30 years of medical malpractice in the US, in the OMIC database, there has not been a single lawsuit on the timing of retinal detachment repair or macula on. So it's not like people got sued because you could have done the surgery, earlier. People get sued because the outcome wasn't great, and maybe it's always best to have the operating room that you always know your personnel in a timely fashion. So I think that's the thing I've learned, that do it in a place and time when you can get the best outcome, not whether it's tonight or tomorrow night, whatever that could be.
Thank you.
So I know time is short, and I've got a lot of other things, but that's the last thing I have. It's just really on timing, because this becomes an issue all the time with us.
So we have one last question, Gaurav. We are out of time.
This case, if I can't do it right away, then I ask the patient to sleep on the left
side. Position.
Not gas and prone and all that.
Just position.
Just position to one side, it will help.
As Gaurav said, bilateral patching also works wonders. The old time school thought, until you...
Yeah, but left position. Bilateral patching with left position.
So Gaurav, thank you very much. I hope you enjoyed the discussions.
One question, if I can. In your point regarding when you put a belt buckle to a giant retinal tear, what are you supporting? Are you supporting the posterior flap of the tear? Are you supporting the horns of the tear? What are we supporting? And will it determine whether the GRT is posterior or anterior? And I will look more into the location of the horns of the tear rather than where the flap is located.
So what is the purpose of putting a buckle in a GRT? That is the question.
Well, what is the purpose of putting a buckle in a GRT? I think the buckle purpose is really to support the area of the vitreous base that does not have a detachment. The problem with GRTs is we know the vitreous base is abnormal. So again, it depends on the location of the break, whether it's anterior, posterior. But really, if I can't shave the vitreous base in a safe fashion, I'm supporting what is still attached in the retina. It's not as much as the detached part. Obviously, you like to support the horns and so on and so forth, but it's really the attached part that's there.
Thank you, Gaurav. I'm very sorry to keep you up late on a Saturday night, and we really enjoyed your panel discussion. And I will keep the memento with me and deliver it to your hand when you visit us in Ahmedabad. Thank you again very much.
Okay. Thank you. I appreciate the comments, and from whatever I heard, the good thing about retinal detachments is many different ways to fix it, and again, whatever works in your hands to give the patient the best outcome. Thank you so much.
Thank you.
Thank you, Dr. Gaurav sir, for this wonderful talk. So we'll be continuing with the remaining presentation. So now I would like to invite my good friend Dr. Divyansh Mishra. So Dr. Divyansh is currently Vitreo Retina consultant at Shankarai Hospitals, Bangalore, and he's been mentored by Mahesh sir. So we are fortunate to have him also along with him. So again, he has co-authored over 75 publications, and he is also an avid researcher, and he has also received a lot of prestigious awards, and the recent one being the Young Researcher Award at VRAG 2022 Nagpur. So we are fortunate to have you, Dr. Divyansh. Over to you.
So thanks Dr. Vishal for the invite and fantastic meeting. So I would be presenting our experience, but in this there will be only one single case. This is a mistake. So this is a 48-year-old male, as you can see, is having issues in both eyes. If you can see one eye where the vitrectomy has been done, oil is in place because of breakthrough vitreous hemorrhage. And the left eye, what we are seeing over here is having a central sub-RPE hemorrhage. Vision right now in the left eye is 6:6 and the right eye is 6:12. As you can see in the opta, we can see that there is a network of VVN in the right eye. In the left eye there is a VVN, but which is inferior to the PE. So here at the center of PE there is no network which is visible. So the plan was to do an FFA. This was the time when we had the flash FFA with us in ICG. As you can see, the right eye had a large network, and the left eye had a small network which was inferior. So this was the time in 2018 where the availability of the anti-VEGFs were not as much as what we have the arsenal right now. As you can see, the left eye we started managing with bevacizumab. And as you can see, there is no or minimal change, and after around a month or two, we could see that the PED was increasing. So the plan was that let's continue the bevacizumab with the eye which has less vision. And at that point of time, we had an availability of aflibercept, so we started with that. And as you can see, after aflibercept, a minimal change of PED, but again, it's a kind of a poor response, what we can see over here. So right eye, as you can see, is still showing some signs of progression. And there you can see that there is a large tall PED which is having a kind of a very tense outlook, so whether to treat or not to treat, the discussion happened with the patient. And then we thought of treating the right eye and the left eye both together. So as you can see, after the aflibercept, the PED has started to flatten down, but not very significantly again. So at this point of time, we planned of doing a PDT. Yes, with the large PED itself, the half fluent PDT, what was planned in the right and the left eye. The left eye responded very well, but the right eye, as you can see, the PED is flattening. Again, probably the PED has worked well in this case. So this was the era when the PED was available. So this was the kind of presentation before and after PED. As you can see that the response of the new, so as you can see, this is before and after. So here is what we can see now, the polyps have started to occur in the PED which were not there before. That means the disease was active still. So what was the plan is to still continue doing an anti-VEGF. So we continued to treat anti-VEGF in both eyes. As you can see, the response was a part poor. The right eye, as you can see, has started to flatten up, but there are some kind of PEDs which are away from the macula also. The left eye has now multi-lobe PEDs, dense PEDs. So at this point of time, we did not have the option of any other anti-VEGF, so we thought of doubling the dose. So doubling the dose as to what we were giving at that point, so 2 milligrams, we thinking to have 4 milligrams, but right now that is rather than giving as 0.05, we gave 1 milligram. So as you can see, even though there was a large PED, even after treatment, the response has not occurred. So at this point of time, because there was a poor response and we had the availability of PED, so we did a full fluence PED at this point. As you can see, the both eyes have responded pretty well. So the PED was probably the crunching point at this point. So even after this, you can see that the fluid was coming up in between. So the treatment was to continue with the aflibercept that was available with us, and then we continued with double dose. Considering that we had an option of pralicizumab at that point, as you can see, this is after the first pralicizumab where the PED and SRF was significant, and that had responded pretty well. And this is after the second dose, and we tried to do a treat and extend, and we could reach to 14 weeks. And then after this, the problem was that the patient still required multiple doses. So the question was,
what is an ideal interval, whether we should give it at 8 weeks, 12 weeks, as we were discussing that most of us had problems of inflammation, whether the treatment extent to be done in brolucizumab is what I do usually, that I don't treat on a monthly basis. And if you have a poor response, whether we decrease the follow-up to 2 or 3 weeks and then again inject at that point, is there any contraindication for bilateral brolucizumab? Because in this case, we had the issues in both the eyes. So, and this is the most recent, after around 12 injections of brolucizumab, where as we were discussing that once you have a rib, we have the network which goes on to one side and gets crunched. So that's what I was discussing with Ramesh when we were sitting down. And this is the other eye. So that's the end of the presentation. Thank you.
Thank you, Dr. Dinesh. So we have another related talk that we will take up the discussions together. Meanwhile, I would like to invite Dr. Ashok Talati sir to felicitate Dr. Dinesh. We have seen fantastic results with brolucizumab, but once in a while, since we had also in previous talks mentioned about some IUIs, so let us see in this case how Dr. Deepak has managed. And preferably rapid fire kind of a case presentation. Just to also announce that we do have a case of the session awards as well, so do stay with us till the end.
This case is mainly for discussion because we've been seeing magical results with anti-VEGFs. So there are some adverse events also which keep on happening. You just need to have a close look on all your cases to see what is happening. So this is basically a general ID gentleman, 72-year-old gentleman, no systemic comorbidities, hypertension or diabetes. He comes with diminution of vision, right eye at 6/16, left eye less than 6/16. So basically he came to me for left eye treatment. So on anti-segment we use pseudophakic, intraocular pressure is normal. So on examination, he has an active disease in the right eye. So here you can see there is exudation happening, subretinal exudation, there are PVDs, specks of heme. So there is an active CNV process in the right eye. On OCT gives you more clues. The morphology of it, you can see a double layer sign, you can see the PVD, SRF, more pointing to a pathology that it could be a PCD case. Left eye also shows you some signs of aging, possibly a drusen-like deposits, a reticular kind of drusen with pop-up on OCT, like mouse. So he was diagnosed with having clinically PCD active CNV on the right eye. The left eye was kept on observation. So treatment point of view, various options were discussed because I was thinking he basically has a PCB. So I advised him either IDEA or Vitreo Retina or aflibercept. He chose brolucizumab. So left eye was kept on observation. Luckily, on first injection, we got a good response. So we all know brolucizumab has a magic drug. So you can see the SRM is going down, the PD is going down. The patient has improved in vision from 660, he's 366, he's escalated. So I advise him as a part of loading dose, we continue with the second injection. After 5 days after injection, he comes to me with a sudden drop of vision. From 636, he's at 40 feet 1 meter. So on first thing, what I look at posterior pole, if you see, there's retinal whitening, especially on the posterior pole. That was the first striking sign, positive sign. Second positive sign are the vessels. So if you see the vessels, the inferior branch, tributaries, the superior, inferior, the branches, tributaries, everything is occluded, more of a sheathing kind of thing. And this thing is more prominent on the posterior pole itself. Posterior pole is showing me as retinal whitening, all the vessels are occluded. So, but the negative findings, I saw the patient again. Anterior segment, no inflammation, no KPs, no deterioration. Fundus picture, you can see there's hardly any vitritis. The fundus picture is telling you that there's no vitritis. Retinal whitening, if you cannot see on the previous image, here it is beautifully lightening, retinal whitening, along with vessels. Vessels are occluded and sheathing. Only the arterioles are occluded and sheathing. Venous, you see there's nothing going on in the venous side. No dilatation, no tortuosity, no exudation, no hemorrhages, nothing, all negative. So mostly when I was reviewing the rasters, I saw some hyperreflectively, especially where the retinal arterioles they were going on. The inner retina, some layers, usually we wish to distinguish these layers, they were indistinguishable. So there was something going in my mind. So this is possibly an adverse event. The commonest adverse event which we note with Vitreo is possibly an intraocular inflammation. But the eye was silent. There was no vitritis, no AC reaction. Only positive thing was retinal whitening and the arterioles were occluded. So I had inquiry in mind whether it is vasculitis or it is occlusion. So keeping both of them diagnosis in their mind, I treated this patient with paracentesis and asked the physician to give a clearance for starting oral steroids. And also because I wanted to document it on angiography, so I did a cardiovascular workup to get a fitness for angiography and also to see whether the patient is hiding any comorbidity which is not telling to us. Unfortunately, the patient was not interested much, so he was lost to follow up after 2 months of treatment. So on discussion, mostly we know occlusive vasculitis is commonly associated with rituximab, Pagenex, as well as faricimab, both of them. So interestingly, arterioles are the most commonly affected compared to venous. And the most common side effect noted is 92% of cases you have some sort of inflammation. In my case, I didn't have any inflammation, only the retinal arterioles had a ischemic kind of event, possibly an occlusion. And most of the cases, if you see any patient with adverse event, half of the patients, they don't have any good visual acuity. You need to keep on injecting them or you leave them. The Indian study usually in a technical serious adverse events, during the Hawk and Elliott trial for Wilson, they documented a high risk, more than 4% cases will have more than 4% cases. But overall the Indian study, like Mahesh pointed out, is less than 1%. So there are some mixed reviews on it, but I had some practical incident with this, which I would like to share with you. This is possibly a second opening for some second chapter, possibly second meeting we can discuss with other entities also, the same phenomenon happening in the eye. I would like to invite your discussion and your pearl points on managing such cases.
Thank you, Deepak. Interesting case. So, your comments, Divyansh, following your talk. And we would like to have questions from the audience. I am sure there are a lot of questions regarding Pagenex and adverse events.
So if you go back to the OCT, I felt there was some replaced cells which were there. The next OCT.
First OCT.
So I think it's slide number 3.
So after the adverse event or before?
After that.
After the
time when, after this one. So if you can see the OCT is showing vitreous cells are there and the below OCT also is showing some kind of a stalactite, stalagmite kind of an appearance where those small fine deposits which are there on the retinal surfaces. So
to be honest, I would see it as active because I don't have a very high-end machine. I have a usually unit kind of machine which is kind of noise which we see on such images. Clinically, to be honest, I wasn't seeing any signs of inflammation. Otherwise, when you see the fundus picture, I have some idea.
The OCT does show a lot of cells on the surface of the retina.
If you leave the vitreous also, I am talking about the
surface of the retina.
At the interface there are multiple.
On the retina.
On the retina. This one. So finally here also, this OCT also is there. So finally the treatment is, as we were discussing, the IOIs, depending upon if we see that it's a posterior segment involvement, then starting oral steroids would have been the best way. Fortunately, I haven't got it, but Mahesh had one of the cases where there was vitritis, and also in those cases again PST and oral steroids immediately resolved most of the inflammation. So we do not know exactly what is the cause because that is the publications have not suggested what exactly is the cause, but whether it is a molecule or is it the substrates within the molecule which is there, we do not know about that exactly.
So I've seen 6 cases of severe reactions to, none of them were mine, they were from periphery. Unfortunately, 4 of them were very young patients who had developed venous occlusions and had treated with Pagenex. And 2 of them ultimately landed up into a very bad endophthalmitis in a plain full blind eye. So, if you see those, I'm sure it's very rare. It's just probably one of its kind. Probably it has happened even after Eylea or ranibizumab, but it's not been reported or not been highlighted as much.
So one of the studies which I want to tell you about is I was part of one of the phase 3 trials of a biosimilar, which I do not want to take a name because why we are discussing is in that we do a control arm where we do the blood analysis and identify the antibodies. So you are able to find in 40% in even control arms for patients who we were giving another injection. So it's not that, or right now all the studies are also suggesting that the similar IOIs are occurring not only with Retin or brolucizumab, but even with faricizumab, also the newer molecules. So we are not sure that whether already there is some kind of innate response in the body which has developed, which is to this anti-VEGF, or is it to the substrate? As we are discussing, we just know one molecule, but there would be 10 or 15 other molecules which are stabilizing the whole molecule together. So whether responding to that, so we do not know about it.
Yes.
So I read Dr. Vatsal has come across 2 cases.
Yeah, just yesterday he's been put on the group, VRAG group. He has had 2 cases. But that is following Babismo.
Yes,
that is Babismo.
Yes. So just, we had a similar case in Germany, and then they, as per their protocol, they referred that patient to the stroke clinic. And of course, she presented within that window of what we consider critical, response time. So she responded very well to intravenous heparin along with steroids for this, and complete recovery of the blocked area. So she presented with a typical field effect and did very well with heparin. So similar case.
Yeah, Mukesh.
Usually the IUI happens after the 2nd or 3rd injection. First injection is very rare. So some sort of sensitization is there. Immune.
Anybody in the audience who has had such an event can share their experience, please. Nothing to hide, but we are all learning.
Probably what Kesar is saying, and Devanshu is also saying, the serum levels of brolucizumab, they've supported these anti-brolucizumab antibodies. So what Kesar is saying, probably it gets sensitized more after the first injection. Cases are less seen after the first injection, more so after the subsequent injections.
I had 3 cases where we had a vitreous inflammation, severe vitritis. All 3 responded to the BST. But unfortunately, I have never seen venous occlusions and arterial occlusions after this. How do you explain the patients? Do you explain this rare risk, side effect happening to the patient before giving up? How many of us?
Most of the patient will be out of your loop. You will be fighting to your colleague.
Yeah. Yes,
actually, you can make it as a habit to give something on steroid along with brolucizumab. That's one Japanese study also. That's what I do usually, except for the concept of steroid-induced IOP elevation. You can give something on steroids along with brolucizumab.
I have a question for you. You said you have seen 6 cases. How many of them were DME-related brolucizumab inflammation?
DME?
Means where the brownie was given for DME cases, because so that's a very important point to understand, because the RP is the area where there is innate immunity, and in AMD cases the RP is already damaged, so the immune mechanism is already altered. And if you have a drug which is actually so small in terms of molecular weight, with a deeper penetration reaching right to the RP, the immune mechanisms, they get altered so much that the inflammatory reactions happen. So this is a concept which people haven't spoken about till now on any of these forums. So always putting the blame on the drug, I don't think should be the right way, because there are certain set of indications where you're actually not getting too many reactions to happen. It's only in the AMD disease where it is happening.
My question should have been how many cases you have given brolucizumab for DME. That also should have been the question.
Yes. Yes, we really use brolucizumab in DME, but it is being promoted in DME by the company a lot. So I'm sure people who are using brolucizumab are using routinely in DME.
Whatever 3 cases I have seen, all same cases. That's why I.
So since I have started using brolucizumab, I always put my patient on oral steroid for at least 5 days, and that works very well for me. And I haven't found any adverse reaction till date. And I think similar experiences with Aditya also. He starts oral steroids before 5 days. I start on the same day and for 5 days. So it works absolutely fine. So that can be done. We don't need to give PST injections or.
I think thank you very much.
Just a last update regarding the etiology which we were considering. So I came up and read up many articles. There are some theories. First theory is possibly a type 4 hypersensitive radiation. Second theory, like Devraj pointed out, it is anti-VEGF antibodies, which is found in 40% of cases. Third theory, all anti-VEGF agents, you know it. We have asked that we are very careful to use in patients having cardiovascular syndrome because they increase the chances of thromboembolic phenomenon. So these smaller molecules, they change the local environment in the eye which predispose them to occlusions because they are not systemically administered. These are the 3 theories I came across. Thank you very much.
Thank you very much. So we end the medical retina session and we move on to the surgical retina session, where we are going to have exciting videos. And over to Kushal.
So thank you the esteemed panel for this session. Mahesh, I would like you to hold on for the next session as well as in the panel. So now I invite for our panel Dr. Nanavati sir, Dr. Madhuri madam, Dr. Jignesh sir to join the panel. And first presentation, we would like to invite Dr. Mukesh Porwal sir for his talk on pneumatic retinopexy tips and tricks. It's going to be an interesting one. Over to you, sir. Meanwhile, the refreshments are ongoing outside, so we can have a cup of tea and coffee and join back.
So they will go in to get it. Self-service. Self-service.
Good morning, everyone. A nice meeting. Thank you, Dr. Banker, Kushal, Park, and the rest of the VRAG Meeting. Now, let me see how much I can cover of pneumatic retinopexy in 4 minutes. We'll jump straight to the case. This is a 51-year-old lady with no previous surgery, that is phakic, and recent onset retinal detachment with a fairly large tear, progressive field loss, and the detachment threatening the fovea. There is a lattice degeneration in the other eye, and there is a family history of retinal detachment. This was the picture with temporal detachment with a tinge of villus hemorrhage and pre-retinal hemorrhage. So the patient was given all the options. Though buckle would have been difficult in this case, but probably not impossible. Vitrectomy always there, but because she was phakic, I wanted to try pneumoretinopexy. And the pros and cons of different procedures of rheumatologist detachment is all known to us. We'll delve on it maybe in the discussion later. And what is an ideal case for PNR? Pneumatic, that is usually a small break in the upper part, or a collection of breaks in one quadrant or 1 clock hour in the upper part, where positioning can help. And in this case, this is the fundus picture. The tear is slightly towards 10 to 11 o'clock with a lattice adjacent to it. And the essential part in pneumatic is you have to treat the lesions which are pre-existing in the attached area before you undertake pneumatic retinopexy. Otherwise, the procedure will fail. Okay, so the laser has been done for the part of the lattice which is in the attached area. You will see that it is incomplete in certain areas because there is fluid and you can't do laser in the area where there is fluid. Now, what next? So, usually you do it under topical anesthesia. You keep a subconjunctival injection ready of xylocate so that in the area where the gas is to be injected, sometimes you need a subconjunctival anesthesia. We have to do a paracentesis with the open tuberculate cell without piston. Usually about 0.4 or 0.3 cc of aqueous is drained out, and another 0.3 cc to that is added in SF6 gas. That is, if you aspirate 0.3 cc of aqueous, then you add 0.6 cc of pure SF6 gas in the upper quadrants. And then you have to do this positioning of the patient, steamrolling. That is, initially it will be prone so that the fluid is displaced away from the fovea and the fluid drains out essentially through that break. And then gradually, every 2 hours, you shift the patient, tilt the head by 30 degrees or so. And as soon as the retina is flat, that is usually in the same evening if you have done in the morning, or the next day morning if you have done in the evening, laser the flat break. Okay, so this is gas. In spite of some fish eggs, the break was flat and the laser was done. Previously, before the pneumatic in the attached area, and then after the pneumatic in the detached area which is now flat, the laser was done and the patient was positioned as per the break. And these are the pictures, sequential wide-angle pictures, ultra-wide-field pictures. These help a lot in knowing the size of the gas bubble as well as the positioning, if it has to be maintained correctly, and the patient understands what's going on when you show the pictures of gas and the laser. So this patient was actually seen 5 days ago, well settled retina, 6 both eyes, and other eye also laser lesion. There are other cases which probably take it up in the discussion later, and this is just to start off any discussion on the matter.
Thank you, Mukesh. So to start the discussion, pneumatic Vignesh, it has to be. Can I have the microphones?
Meanwhile, there is a small trick for positioning. Usually I follow this. I put an arrow on the patch. In whichever direction the patient has to tilt his head, the arrow has to point up.
Correct. The main important thing and the most important thing is the position in these cases. Before that, actually, I would like to emphasize on the PVD induction in such cases. The cases where PVD is already induced, such cases probably won't work very well, and the secondary breaks are very well possible in such cases. So in initial my 10 cases, I found the secondary break was developed after PNR, and that cases were redetached and I had to went for the vitrectomy. So probably there is something related to PVD in such cases. So those cases which is very, very healthy vitreous, that works very well.
Sangeet?
So I think I do it in very selected cases, and what I feel is like pneumorectopexy is a very excellent procedure, but it is much more difficult than what we are doing routinely in our practice, and it's a misconception that you have to spend lesser time with the patient. You have in fact spending more time with the patient in the post-operative period, though the intraoperative time is quite less. I think it's a wonderful procedure in selected cases.
Go ahead, right? Okay. For retinopexy, I have learned when I visited Dr. in France. She is doing all the retinal surgery with the elbow-free mirror. She doesn't use any other things. And she is particularly see whether the part or even tag of vitreous which is attached with the tear or not. If vitreous is free, this will work. If vitreous is attached, this will fail. That was a call. And I also follow the same.
Mahesh, comments?
See, pneumatic has been there for years together. What is different now, what Rajamuni has been popularizing is the use of laser, number one, in contrast to doing cryo increase the risk of oxidative RD as well as PVR. Second one is the positioning and the amount of gas which he injects. So he injects double the volume of gas, that's the second one. And another bottle of gas about 3 to 4 days.
Yeah, he does it twice.
Yes. See, it's difficult on the patient, so that's another issue. The patient takes care, he has to be involved in the treatment. So, and Rajiv says that you have to maintain 22 hours of a 24 hours position like this. If I was a patient, I wouldn't be. I had 2 patients, one I did pneumatic, the other one I did buckle. The lady who I did buckle was up and about the next day. And the pneumatic patient is still sitting like this for the next 5 days, 6 days, and in between he comes to the hospital and then you struggle to do the laser. That's why it's a good procedure, I'm not saying no, but then it's not something which is propagated as the panacea for everything. That's not true. So buckle is a wonderful procedure. Same thing, you go buckle patient is up and about the next day.
That's what I was asking Gaurav, that in our setup, in our type of population, probably it's not a very well accepted procedure in the society.
We have difficulty with getting it at a time, but we don't have difficulty in getting it at a time. So
yes, exactly.
Practical problems than clinical.
Yeah, I had a comment about fish eggs and people who have used buckling and there we have a separate procedure. You can tap.
Yeah, you can tap the cornea at the end.
Yeah, you can
just
tap
it.
You can use a
Bud and just slip the bud.
Yeah. So it might become a little more.
Yeah, same thing you do in a buckle also.
Yeah,
correct.
Any other comments?
So sir, basically what I feel like this procedure is very good. It's like the oil complication and everything is not there. But most of our patients, when we counsel them for like a simple pruning, and otherwise in this proper positioning and daily follow-ups. We are not able to do this daily follow-ups in our routine setup. So what I feel so many times, it depends on patients only. If patient is like that, then definitely we can go ahead with this. If patient is educated, patient is following our instructions, then we can go ahead with PNR. Otherwise, it's kind of difficult.
I think case selection is the key.
Yes. As an institutional practice, generally I admit that patient for 2 days at least. That's just not possible without it.
Also, when you want to estimate the accuracy, we are trying to get the maximum amount. So sometimes it's better not to use just, without the piston, you don't do that. You try to get 0.2 to 0.3 plus it's a controlled drainage. So if you are looking at a pseudophakic patient or someone with a long-standing detachment, they might have an NVI in the angle. You don't get a sudden bleed or a sudden collapse.
Kaushal, any comments? Pneumatic retinopathy. You don't know. Anybody else in the audience?
Well, I just want to know the opinion of the panel regarding the displacement, retinal displacement, what they talk about when they... Any experience? Sir,
I don't have any personal experience. The thing is this will impact when you are doing a vitrectomy. So for those of us who do a buckle versus pneumatic retinopathy, there is not much of a difference. Only if you have to do a vitrectomy and forcibly attach it. But the via media is don't drain the fluid dry. So do a vitrectomy, leave behind a little bit of fluid so that this displacement doesn't happen. So that's a
very good message. People should hear that if you're doing a vitrectomy, don't force the retina to be completely dry. You can leave a little bit of fluid on the posterior pole just to prevent the issues of the rotation, which Dr. Rajiv talks. And he believes it is less in pneumatic than, and as Dr. Mahesh said, when you compare buckle versus pneumatic, there's not much of a difference. So it's a teaching tool for all of us. Don't force dry your vitrectomies to be completely dry. You can always leave a little bit of fluid on the posterior pole.
So once you put a gas temporal and ask the patient to maintain Crowne immediately after vitrectomy, won't it be almost the same as a
So that's what it's saying. So that you don't need to have your retina completely dry on the table. If you're putting a tamponade and if you're going to position the patient, within a few hours you're going to have a completely dry macula anyways.
Would you charge less for the pneumatic retinopathy than a buckle? That is the, that's how when you're counseling a patient, it does matter. It's a surgery and it takes a lot less time.
That is a complicated thing. It needs another 4 minutes.
Okay. Thank you, Mukesh. This is OPD procedure. We move on to the next case.
So now I invite our keynote address Dr. Sangeet Mittal sir, and he will be speaking on basic vitrectomy hacks, things that they do not teach you during fellowship. Sangeet sir.
I think this is going to be a very interesting talk. When I discussed with Sangeet, he said that this is going to be a teaching for all of us.
So Sangeet sir, we all have been following his lot of surgical videos and lot of teaching is there in his videos, and he's currently the director of Vitreo Retina at the Tindai Hospital, Jalandhar, and he's done his VR fellowship from Sarkhej, Chennai, and you can see the list of awards, and list is countless, and we hope that sir keeps on adding the awards and make us proud. So over to you, sir.
Good morning, everyone. And the first thing I'd like to thank Kushal Park and Gujarat Retina Society for giving me this opportunity to be here at the first meeting, at the first annual meeting. And when I was invited, they told me don't speak too advanced and don't keep it too basic. So I thought something moderate I'll just keep, which will be of interest to everyone. And I think everyone, this talk, maybe most of us may be doing in our practice, but it's not just listing the things that I do something differently, and which you will be able, if you're not doing, you will be able to do routinely in your practice. So some hacks, I'm going to say, how to fix a contact lens. So we are doing sutureless vitrectomy, that if you say that I'm going to suture a ring, if I'm doing a contact-based vitrectomy system, then that is not ideal. But if you are doing everything sutureless, why put suture over there? And this contact lens should remain stable and should be easy to use and cheap. So what I generally do is I just take the Lander's ring, put 3 micropore this is sterilized micropore strips, and I just attach them and I pass my trocas cannulas through these strips, and these 3 strips then keep this ring stable throughout the vitrectomy, whatever you do. So you do your vitrectomy and you put your viscoelastic, put your contact lens, and then you are able to move your eye here and there. You see the lens will remain stable, and you do all your macular surgeries. If you prefer to do it under contact lens, and you don't, the lens won't move while you are operating. And so this is being used by a Lander's lens. We can use other contact lenses also. And if you don't want to continue with the contact lens, just remove the contact lens, put in more viscoelastic, and you can use your non-contact system. In fact, with the ring in place, the viscoelastic holds for a much longer time, and you don't have to repeat the viscoelastic again and again. So this is the first vitrectomy hack. Basic vitrectomy. Now checking the cannula placement. So this misplaced infusion cannula usually leads to intraoperative complications, and routinely what we do is we push the infusion cannula, switch off the microscope light, and put an illuminator on the side and just go under the microscope and see whether the cannula is visible or not. And still, if the media is hazy, still you are not able to see the cannula. And so, what I do differently is I use that endo-illuminator reflex test. So what you do is, like, you have made your sclerotomy, you remove the trocar, you take your endo-illuminator and you keep it in the trocar midway. Don't go through in, just keep it midway. And if you see this red reflex coming, it means that your cannula is misplaced. So I'm now making this another sclerotomy. I'm using now, you see this is a white reflex. This is your normal reflex, what should come if your cannula is in place. And you see the third one also showing the white reflex. So I'm using the other sclerotomy to start the infusion cannula. You see there was choroid over this cannula, and you just now release this. And now you shift your cannula, infusion cannula where you want it to be. Now you see, after doing that, you see that the reflex has changed to the white reflex. And now you see, this is the patient with a total cataract, and you have to do a lensectomy. You see there's a white reflex. You can see whether the cannula is in place or not. This is a patient with endophthalmitis. Again, there's a white reflex. You can see a patient with a dense vitreous hemorrhage. You see there's a white reflex. So it holds true even if the media is hazy, you can use this test to see whether your cannula is misplaced or not. Then again, I have so many queries regarding the chandelier. The people say that we don't have a chandelier. What to do if you don't have, you can use your old light pipes to make a chandelier. Dr. Mahesh showed in the morning also. There's another way of doing it. Just with the modern systems, you just break the light pipe and remove the steel pipe and expose the fiber optic. And then you can use this fiber optic. You just cut it to the proper length, and you can use it as a chandelier. And the advantage is this: because this light now comes with a handle, even if you have an assistant who can hold the handle, he can hold it properly without causing any further damage or without dislocating this endolite and hitting the retina. He can easily do it. And you can even, like, because of the handle, you can even tie it, you can fix a tape to the nose, and you can have it properly placed. So another complication which we usually see is when you are removing the posterior removal of the interior highlight, you touch the lens. So what I have been using is the micro bubble technique. So once you remove the maximum anterior vitreous what you can, and you clear all the sclerotomies. But one thing you have to take care is you do not cross the midline if there is a lens there, because then you are going to surely touch the lens and that will cause problems. So once you have removed the maximum amount of anterior vitreous, just inject some air into the this. There will be some small bubbles which through the micro holes in the interior highlight will go and settle behind the lens. And now just take these bubbles one by one. Try to take, with your cutter, try to take these bubbles one by one. And eating the bubbles expands those micro holes, and then you get a cleavage plane from where you can detach the interior highlight from the posterior surface of the lens. So here, again, you see this cleavage plane has been achieved now, and you can easily now detach the interior highlight from the posterior surface of the lens. Again, I would like to warn that don't cross the midline, because if you try to cross the midline, you will end up having a lens touch and a cataract. So this is another hack that I wanted to show. So next is how to remove subhyaloid or subretinal black hole in, this is the hole in hyaloid approach. So sometimes, do I have time? Or?
Yeah.
So so you see when you try to remove the whole of the highlight, when you're doing truncation of the cone, suddenly the subhighlight blood will come into the vitreous cavity and cause the whole media will be obscured. And you spend a lot of time just to clear the media. So how to avoid this is just create a small hole in the posterior highlight and try to remove all the blood there only. Now don't expand this hole and just keep on removing all of the blood below this posterior highlight which is still there. And once you have got maximum amount of this fluid blood out, then you expand this highlight. And you can make multiple holes. You don't need a single hole. You can make multiple holes, and it will help you clearing the subhighlight blood without causing any media problem. So small gauge forceps, they are unable to remove the thick ERM in one piece, and it often comes in bits and pieces. So you can use your cutter to remove the epiretinal membrane. This is what the technique is known as the engaged second peel, and it's quite prevalent nowadays. People using the cutter as the forceps to remove these membranes. So here, during the pre-op OCT, you see there is an edge of the membrane, and just scratch that edge with your cutter, and then just grasp this edge and apply gentle suction. Don't use very high suction. Gentle suction, you just keep on moving closer to the retina, and in the moment, there is no editing in this video, and you see that how easily you are able to get out the membrane in one single piece rather than having it to do it with the forceps, in which it will come with bits and pieces. So many people I'm afraid to say, are afraid of doing a direct PFC silicon wall exchange because they say that there is a lot of chances of slippage. So this is my way of how I do it. Just flatten the retina. This is a patient who had undergone a 360-degree retinectomy. Just flatten the retina and then do laser all around. In this case, and once the laser is done, put this vent here and top up more PFCL until you see this. Then you clamp the infusion line. Once you clamp the infusion line, then you tilt the eye and put in more PFCL till you fill the PFCL up to the brim. And then you start extending the PFCL with silicone oil and keep the cannula anteriorly, keep the backflush cannula anteriorly, and slowly as you are extending, move it downwards. So in this way you are able to clear. And this is my last video. So how to use the most commonly available Sarkhej IOL to use it as a secondary IOL. There is no need for any separate inventory. You don't need any special lenses for that. This was I did once. I missed because I was doing an NIDDL lens, but then there was the haptic of that NIDDL lens broke, and it was a high hypermetropic. There was only lens of that power available was this Sarkhej lens. So what you do is they just pierce the haptic of this IOL. I'm using a 50 chlorine here. Make a flange. Similarly, make a flange on the other side, and you don't need any special IOLs with a needle in the haptic And then after creating those flaps, just bring out the trolley suture from one end and from the other end. And then you create flanges outside under the flap. Inject the same IOL. And then create another 2 flanges outside and then close these flaps with the glue. So this way, if you don't need to maintain a separate inventory, in need, if you can use your routinely available IOL, which is most commonly present in our hospitals for this. Thank you.
Thank you, Shami. Again, very innovative, very useful practical tips. Any comments from the panel? Yes.
We use 3-piece IOLs, which is readily available now.
Yes, you can use 3-piece IOL, and you have to then bring out the haptics and make pockets, and you can use that. Definitely, you can use that. Yes. But with that, again, there is it has its own disadvantages. Manipulating the haptics of those IOLs again is very difficult, and sometimes this is very easy and very to use.
Yeah, it's really very easy one, but even the flap won't make any difference. Even if you put it under the conjunctiva cover, it works very well.
So it's just to prevent. I foresee that they might erode this because this is a 5-0. If you're using a smaller suture, you don't need a flap, but this is a 5-0. So I created a flap just to be sure that they don't erode out.
And in case of the vitreous hemorrhage, which you have shown very well, create one hole and remove the vitreous, that can, I think, be done under the air also. If you fill the whole vitreous cavity with the air by clearing one side and do a dry vitrectomy on the other side, works very well.
Yes, sir. So that just gives you an additional step that you have to do. It is just, when you are doing it, just make a small hole and remove all of the blood there only. It's in the one hole only. That is.
Sir, just wanted to ask regarding this foldable IOL. Now, when you pull the rolling out, so how do you titrate where the haptic will stay? Because we know those are pliable, so it might have some. So how do you titrate those?
I think I just think the maximum possible what it comes out, because the suture is not very lengthy in those cases. So if you keep it loose, in fact, it might tilt later on.
So do you, sir, adjust after pulling out both sides and again make the flanges more and more towards whatever the suture length is there?
Yeah, once you start doing it, you come to know how much I have to pull and how I have to adjust. I think that will come. But initially, when you are doing it, try to keep it at maximum because it's a stretchable IOL, it just stretches.
Hydrophilic.
This is a hydrophilic.
Yeah, I wanted to just add one thing, like what you showed for this chandelier thing. If we don't have chandelier and we can make for this light pipe, there's one more thing we can use it is like flange of the syringe. Like any like 1 ml syringe or 5 ml syringe, we can just remove the rubber part of that syringe. We can make a hole in that, and we can pass this through that. So what happens? It is a controlled way. Like I have used 1 or 2 times. Like when my staff is handling that, so he doesn't know like how much he should go inside and how much the part should be outside. So he's using it like this stopper. Yeah, stopper. Yeah, stopper is there. So he knows this much he can go inside, or more than that he can't push it.
Last cautery which you are using is a heat cautery or electric cautery?
The cautery
that is a heat cautery, sir.
Thank you.
No, even somebody has also known that even laser can be used for the same purpose rather than cautery.
Vishal Agarwal published one
Yeah,
small video where basically it is also kind of a heat laser, so ultimately
Yes, sir. Mike.
A couple of points. One is regarding this making a small hole and drying the blood. One of the reasons why it disperses is because you are using a cutter, where there's a lot of swirling. So use a fluke needle right through that also works much better because there's only unidirectional, there's no swirling. So there is the mucking up of the vitreous cavity doesn't happen. Dr. Sangeet showed the way of red reflex, white reflex, if in case you are not sure of the camera's inside. Despite all that, there is still a possibility that it can reduce the frontal space. Any doubt, do not use it, use a 6 mm camera. You can still use a 6 mm camera even if it is a phakic patient. Just not manipulating it, you can still get away without touching the lens. And the light pipe, one thing is that if I break the new light pipe like this, my system will break.
Old one.
Yeah.
So instead of breaking that, you can break the handle and then use the bad fiber.
So the flanges you can actually cauterize with the endolaser probe itself. But what you actually need to do is form the block. So what I do is that I just hammer that block with a cotton bud so that it flattens it. And we do trans-inject it. We don't bury it under the sterile flaps. So even if there is a block, then you flatten it, the pricking sensation doesn't happen.
Rekha, last comment? Same
using the laser.
Thank you, Sangeet.
Thank you.
The laser actually we have used it post-op. We have used 3-piece ION and then the haptic is like this. So Divyansh published it, used the laser, stick lamp laser to burn the tip so that it goes inside.
Does it cause a conjunctival scarring?
Not really, because we have used laser for many reasons earlier. Punctal occlusion.
But so that heat will be generated onto the conjunctiva.
No, the conjunctiva heats over it, doesn't matter.
Thank you, sir. So I would like to invite Dr. Mehul Shah sir to felicitate Dr. Sarkhej with us. Thank you. So I would like now to invite Dr. for his talk on Ozurdex as an entry to the surgery.
Thank you. Very good morning to all, and thank you for making me a part of this first meeting. It is indeed an honor. I've just put up images in the interest of time, and we'll just run through it along with the discussion. So this was a 60-year-old lady of this bilateral direct macular edema, scheduled for cataract surgery. So we initially treated the edema. And at the time of cataract surgery, we concurrently gave an Ozurdex injection as well. This is what it looked like. At the time of the second surgery, that is the right eye, she eventually developed post-operative edema. She did not have it pre-operative, so we did that. Quite a routine case. The only reason I put this up is she was a known ocular hypertensive for 20 years prior to the injection. So we have been following her up serially with perimetric scans. Never showed any abnormality, and she showed no rise in IOP with Ozurdex as well. So just a point to put forward that even if the patient is an non-ocular hypertensive, Ozurdex doesn't necessarily cause an IOP scar. So again, a routine case, cataract with DAB went off well. Obviously, the patient continued on injections, but infrequently, simply because Ozurdex lasts longer. Yet another case with similar outcomes. Of course, this patient needed more injections. This patient, this is a preoperative scan of a patient. The preoperative being pre-cataract. So there is some element of VMT, but very minimal, and it's not really evident here because of the grade of the cataract. This was the post-op picture. So at this point in time, we injected Ozurdex. The edema resolved, but then the VMT component continued to increase. So eventually, degenerating into a full-blown macular hole. We operated her for that with an inverted flap. That's C. The second eye underwent the same thing, but it did not need an injection because it did not show post-operative edema. But the VMT definitely worsened, and she had a similar fate in terms of the surgical necessity. That eye also needed a surgery to close the macular hole. This was a patient, very obvious PDR with this thing. The left eye had an ER. So the right eye received the 3 anti-VEGF injections with pan-retinal photocoagulation. For this ERM, because of the tangential traction, we initially operated her, removed the ERM, was persistent subretinal fluid at even 3 months. So we gave a DEX implant at this stage. It of course did not restore the foveal contact, but it did improve her vision. This is I think just one case where I just want to highlight the importance of chronic treatment or persistent treatment. So this patient had received a couple of intermittent transdermal injections elsewhere, and this was at baseline. And because he did not show response, he was told to quote unquote live with this. So the patient was interested in therapy, no financial issues. This is serial photographs. I just, in the interest of time, I've just put in 3. But this patient received 1 to 2 intrathecal injections per eye every 6 months for 2 years, and that led to significant flattening and significant improvement in vision. He was a teacher, and he could actually resume his profession. This is the last case, bad traction. We removed it, and this was the OCT picture. The top one is the baseline. The edema did not subside. At that stage, we injected Ozurdex. It led to anatomical improvement, obviously not a very good functional improvement. So, this is often discussed for all injections, for all treatments of DME, early and continued treatment. So, very often the surgeons themselves, feel a lack of conviction insofar as the treatment goes, simply because, the patient is not responding. But because DME is chronic, the treatment often has to be chronic. Thank you very much for your attention.
Thank you, Aditya. Any comments from the panelists? Use of Ozurdex?
As to the cost, so that prevents sometimes.
Yes. Yes.
Most of patients we have to think of.
DME generally I use intravitreal anti-VEGF along with the cataract surgery, not Ozurdex frequently. Works very well, I guess.
No, Sarkhej, any particular type of patient you have in mind where you think Ozurdex would be better option than anti-VEGF?
When we are planning for a cataract surgery,
yes.
I usually use an expensive implant. Or if the light bits are quite high, the RDG rates are quite significant, then I would use Ozurdex. Not that RDG do not make the RDG rates go away, but they go a little later as compared to steroids.
And do you like to use it before the surgery or at the time of surgery?
Cataract surgery?
Cataract surgery.
Cataract surgery, usually give it at the time of surgery, because if the cataract has been planned, then it's easier to give it at the time of surgery. Otherwise, if you have the time, then better to give it earlier, make the edema go away, and then do the cataract surgery. That's a better practice. But you can give it at the time of cataract surgery if there's no time for the patient.
Because you would expect the peak effect around 50 to 60 days. So,
but the thing is, like, the point of giving it on with the cataract surgery is the cataract surgery induced inflammation also is taken care of. I think that for the ERM surgery, I think Divyansh has some, he has been giving dexamethasone implant along with ERM surgery.
In DME, if there is subfoveal fluid, then definitely dex implant works better than the anti-VEGF.
So I usually use IVTA in my ERM surgeries if it's a severe edema, depending on so it's a cheaper version of the Ozurdex. At the end of the surgery.
I use for steroids when there is a large cystoid space at the posterior. There maybe it's better.
Any experience with suprachoroidal steroids compared to
anybody?
I've started using in few cases. It works. The thing is the needle is short, so you need to be little cautious when it's going suprachoroidal. Many times it's coming to intravitreal injections.
So anybody in the audience? Suprachoroidal
So there was
injections?
a trial start on that for suprachoroidal.
They have done some studies.
That was a trial for RVOH, not for The injector is still not available commercially. So
No, there is a needle from Tricon.
Yes.
One more thing I would like to add, in intravitreal dexamethasone, we do see a lot of rebound effect compared to anti-VEGF. Like explosive aflibercept, the rebound effect is less compared to intravitreal dexamethasone. You give injections and after 3 months you see that the full flare edema is there. When you use aflibercept, the rebound phenomenon is low.
Any comments on that? The rebound effect following intravitreal dexamethasone versus anti-VEGF?
Dexamethasone kind of erodes slowly only. So there is, it doesn't like on the day suddenly it doesn't increase, and again it depends on probably the follow-up. I wouldn't expect dexamethasone to work for even 3 months. So 2 months is my cutoff. So beyond that, like it doesn't work. So usually I call the patient at about like 6 weeks to 8 weeks is when I call.
And you would repeat dexamethasone implant if there is a recurrence or a persistent edema at 2 months?
Yes, if the patient has a recurrence, yes, I would repeat the technique.
Like
But I think it's individualized treatment. Some patients respond to steroids, some patients respond to antibiotics. So given that particular patient's tendency to respond, I would use that particular agent.
Any case selection criteria do you see, like, do you give any topical drops for a week or 10 days to see whether any IOP spikes are there or not, any flaking cases, and if any cases like where you have to remove the DEX implant?
No, I think overall as a, one of the positives of the DEX implant is that even the IOP vasculitis is gradual. It's not, as dramatic as we see with clamidoma. So there is generally time for you to initiate the patient on IOP therapy. Secondly, with dexamethasone implant, I'm sure shares, generally even if the IOP peaks, it will almost always go back to normal by day 180 at the most. So persistent rises beyond day 180 has been very rare. And we did this study, one of the reasons why I photographed the implant was we did a study on the position of the implant inside the eye and the relation to IOP spike. So what we saw is that the closer it is to the pars cilia, the higher the chance of IOP spike. And the hypothesis of course was that the entry of the steroid molecule is facilitated easier, and it's easier for the steroid to enter the anterior chamber and have its effect on the trabecular mesh. So that was the reason. So last thing, as we spoke about DME and rhodocytomia, even with DME and DEX implant, the chances of IOP spike in patients with DME is lower as opposed to say vein occlusion patients or uveitis patients. And probably that has something to do with the fact that vein occlusion is more common in glaucoma patients who themselves might be steroid.
Thank you, Aditya. I think we move on to the next case.
So now I invite Dr. Kapil Devangan for his talk on spontaneous separation of epiretinal membrane. Dr. Kapil.
Good afternoon, respected seniors and my respected teachers and my colleagues. I Dr. Kapil Devangan in this meeting on spontaneous separation of epiretinal membrane. So going through a case report, a 65-year-old woman presented to us with a cheek complaint of decreased vision with flashes of light in left eye since 2 months. Her visual acuity is 20/14 left eye and 20/20 in the right eye. Anterior segment given vision intraocular pressure were normal in both eyes. On frontal examination, left eye we found cerebral reflex with a few retinal striae over the macula with peripheral retinal degeneration with pole, which is not shown in this picture. On OCT of the left eye, we found thin hyperreflecting layer over the macular surface and confirming the presence of the ERM with diffuse retinal edema with square changes. On the same day, the glass laser was done for the lattice degeneration and watchful waiting strategy was chosen for the ERM. And advised the patient to come to follow up after 1 month. But she returned 3 months after 3 months with a cheek complaint of new onset of floaters in her left eye from 2 days. But surprisingly, her vision was improved to 20/25 in her left eye. On further examination, revealed a base ring and resolution of the previously noted wrinkles retinal wrinkles. This is the OCT picture of the follow-up on 3rd day where we can see the restoration of the foveal contour and decrease in the retinal edema and disappearance of the ER. So this is a comparative picture of the patient where we show the disappearance of the ERM with presence of a complete PVD with a slight decrease in the central foveal thickness in the retina. So epiretinal membrane is a common disease of ER interface presented by a series of avascular fibroscular translucent tissue growing on the internal limiting membrane. It is classified into idiopathic, secondary and hydrogenic. Mild ER may not cause any visual symptoms, but severe ER may present with a blood central vision which can significantly affect the quality of life of patients. So basically 2 mechanisms have been proposed for the spontaneous separation of epiretinal membrane. First one is due to the first and most common is the process of the injection of the posterior detachment, and second is the tangential traction occurring over the cells of the internal retinal layer. So there are different studies which also showing that the cells of the retinal layer appear with the reduction of the PVD in the most time. This is recently published in February 2025. Another study is also showing that spontaneous separation of ERM appear due to the injection of the PVD. So coming to the conclusion, spontaneous ER suppression and improvement and visual acuity is possible. Case symptomatic patients require centers can be monitored conservatively. OCT can be used to monitor the progression of ERM. Thank you.
Thank you. In a very interesting case, comments from the panel? I think probably what induced the PVD was the laser, I guess. Doing laser to the lacus actually induced the PVD and led to the spontaneous suppression. Can you put the pre-post OCT? So at this stage, if the patient came to you, how many would you advise a vitrectomy with ERM removal surgery?
What is the vision?
20/40.
20/40. 20/40 vision with this OCT picture. Patient complained of micropsia metamorphosis? Nothing. No, sir.
Decrease of vision.
Only decreased vision. So how many would recommend doing a vitrectomy with ERM at this stage?
Previously, on the first visit, PVD is not covered.
Yeah, that's fine. But I'm just saying, if the patient presented to you,
Patient is
symptomatic. If patient came because
I would advise surgery, even the patient's vision is pretty big. So earlier it used to be 6/18 is the cutoff, but now I don't think it's not the cutoff. So the patient is symptomatic with the metamorphosia bothering them, then even 6/6 vision is an indication for surgery nowadays. That's what I follow as well.
would it change if it's a phakic or a pseudophakic?
It doesn't matter. It doesn't matter. But if the patient is asymptomatic, then yes, you can watch. These conditions can remain stable for years together. There's a study where they've shown 3 years, 4 years, they remain same. Even BMT, BNA, they remain same. So vision better than 6/12 and patient is asymptomatic, then I will not touch it. The patient is symptomatic, yes, I will touch it. And I'm not convinced that the ERM has gone away. If you see the OCT on the right side, the ERM is still there, actually. On the temporal side and the nasal side, the ERM is still there. Probably PVD has happened, but the ERM is still there.
Yeah, so it just got lifted up from the foveal area. Another question, do you peel your ILMs along with the ERM in your ERM surgeries? You do it as a routine, or let's say if it comes off as a complex, then it's fine?
Yes, I would repeal the ILM just to decrease the recurrence of the ERM.
So you always actively go and remove the ILM?
Yes, because I have had cases where they peel the ILM and then you find the recurrence of the ERM beyond the area where they peel the ILM.
Any difference of opinion? Do you actively go for the ILM after ERM removal? Sometimes, not always.
Not in all cases, but after removing the ERM, if I feel there are holes behind that.
There will always be holes.
Not in all cases. Many times it comes out very easily and it gives a very good foveal contour. I don't remove.
Sometimes the ERM is coming out in there.
Yeah.
Yeah, most of the time it comes off, but I try to remove the eye, make sure it goes.
I remove ILM in all the cases of ERM because even if a small chunk which I feel like I have removed and if it's left, it goes off with that.
Sangeet?
So I agree with Dr. M. Whatever Dr. M. has said, just one disagreement is I won't operate the 6/6. I may operate if he goes from 6/6 to 6/9, but not at 6/6.
I would try IVTA or Ozlodex first before offering surgery for this patient.
For this patient. Anybody else? Audience? Any different? Yeah, please, Madhvi.
I actually have a question for Shanmugam sir. Knowing that we are going back on aggressive peels, in this case where there is a spontaneous separation and there is a membrane in the periphery, so what? Do we need to worry about it?
I'm not going to operate on this patient on the right side. Patient on the left side, yes.
It's the same patient.
Same patient, I feel. No, I'm saying the situation on the left side.
So is there a chance of causing a hole, lamellar hole while peeling? If you see the roof is very thin.
Yeah, if in case in that situation you can do a phobia sparing ILM peeling. So that's what I would do. So let me be clear, it's not actually every patient who walks into the opening 6/6 I operate. But the same thing, metamorphosis. So patients complain of metamorphosis and one eye metamorphosis interfering with the other eye vision.
Right.
So those patients are the ones they operate. So I'm not an aggressive surgeon that like I jump up and operate on every patient. But disabling metamorphosis, even if the patient's vision is normal, is what I operate.
I think that is very rightly said because it is interfering is binocular vision. And we have a lot of patients complaining that if I close one eye, I'm fine. but I am having a lot of problems with through eyes. Now, Nick, last comment.
I have one question. Like in this case, like there was a peripheral lattice degeneration. So in such cases, DRF with peripheral lattices. So prefer to do lattice degeneration laser first and then operate, or?
Well, I think you can do it whichever way you are comfortable. You can do it during your ERM surgery or prior to.
The thing is, injection of PVD has to be careful. As you go closer to the lattice, it should not be an aggressive PVD injection. Trim it and leave it there. Don't try to lift the hyaloid beyond the lattice. That's when it's likely to tear.
So you don't need to do an aggressive base excision in such cases in your ERM.
Only thing is, looking at the ERM, don't miss the lattice or hole.
Yes.
Then you will be in a problem.
Thank you, Dr. Bakul. So now I invite Dr. Rekha Sindhu for her presentation on PVD induction in stage 4 ROP. Dr. Rekha.
Thank you, Kushal. Thank you, VRAG, for giving me the opportunity to present my work here. So, I have a surgical video to show the PVD induction technique in stage 4 ROP.
Chances of retinal detachment in future. However,
It's okay. You can keep it just keep the microphone there.
but not further without inducing retinal bridge. Special techniques for PVD induction are often necessary, and it has been postulated by most surgeons and in ROP surgeries that there is no need to induce a PVD in these cases, and just dissecting all the connections are enough for success of surgery. We encounter 6 eyes presenting to us with impending macular hole or macular hole retinal detachment post-lens-wearing vitrectomy in stage 4 ROP. Thus, the need for releasing the traction from the macula and induction of PVD became important. Case with a stage 4 temporal retinal detachment, where the 3 ports were made nasally abdominal from the windows. After dissecting all the anterior and the peripheral connections, the connection between the wrist and the disc are dissected, and a gel-like substance is seen moving below this connection, showing the whitening of hyaloid. The hyaloid is attached near the disc, and with a minimal suction around 100, the PVD is slowly induced around the disc. Next, the PVD induction is moved further from the artery towards the periphery. Whether the hyaloid is separated from the posterior port towards the artery with minimal suction. We need to be very slow with PVD induction to the use of minimal suction and go on looking for the points of hyaloid attachment to prevent the inevitable breaks. We need to shave the separated nucleus and hyaloid slowly. You can use the cutter in the swiping movement slowly to separate the posterior hyaloid from the retina in a detached. Partial FGA is done and the ports are closed.
Thank you, Rekha, for your excellent surgery as always. Mahesh, comments?
It's not possible in all the cases. That's the only issue. Because particularly with the TRD, and this is like a recent disease. This is laser and settle down. But if it's an actively proliferating disease with the TRD which is happening right in front of our stage 4A, 4B, those situations it's extremely difficult to induce the PVD. So those situations you would want to probably limit the amount of surgery, just dissect between the disc to the prolif to the vitreous space and leave it and come out. Because the more we do, more are the risks of retinal break formation. The PVD doesn't happen just like how you would want what happens in an adult. I have used some adjuncts is like you use an autologous plasmid can be used. And in this method I used triamcinolone to identify the hyaloid quite
So that was the clue which I wanted to show. When you are going to dissect between the ridge and the disc, sometimes you find that jet-like substance which is moving there. That is the clue I have to write there. So in those cases, you can get an edge and then you can easily move on and then you can use the PVD. So here my major factor was because we had 6 cases where we had a macro-root attachment or attachment of the macula. Generally we had to operate and we even used 2 eyes because of that. So after that, we had made a point in the cases where we have attached retina posteriorly. We try to separate the hyaloid on the posterior pole, up to the arcades at least, to free the fovea there.
Wherever possible, we can try to induce the PVD, but like induction of PVD, like what you have shown, will not be possible in all the patients of ROP. That's what I'm trying to say. If it's a stabilized eye, yes, and the posterior pole is stable like this, then you can try to induce PVD. And this is slightly older children, younger children.
No, this was younger only. So this is an active stage 4 AI, where I have done a laser on table only before surgery, and then went ahead with the surgery.
No, younger in the sense like I'm talking about like 2 months, 3 months like that, where the active disease is much posterior. That's what I mean. Here you can see that the fovea is attached and dragged temporally, and if you were to try to use the PVD much more temporal rather than ridges, that's where the problem happens. So that's what I'm trying to say. Posteriorly, if you're able to use the PVD, yes, but towards the ridge, it will be a mess there. If you try to induce the PVD like this, it will retinal there. I'm sure you know, I'm sure you understand that. So that's exactly where. There is where you just trim it and leave it like that. Posteriorly, I will use triamcinolone to identify the hyaloid, and that will help us see where it is separated and then induce. That's all.
You actually need to do this in a stage 4A, even if it's a quiet stage 4A. Do you actually actively need to induce a PVD in all cases?
If it's possible to induce PVD, it's always good because like wherever go ahead and try seeing if the hyaloid is coming off, then yes. But then aggressively going and trying.
Anybody comments? Yes.
Excellent surgery, Dr. Rekha. Just what Dr. Mahesh just wanted to elaborate on that. In these children, the vitreous is so clear, even the core vitreous we are hardly able to see. So we will be, I definitely have very difficulty to see this, and I routinely use triamcinolone in these eyes, even to identify the core vitreous. So I think triamcinolone is a very good aid in these patients.
I have a question. How much dilution of triamcinolone you use in the pediatric surgeries? What is advice?
I use the same concentration.
Same
diluted.
As we use in adults. Yeah, Ramesh.
So I just want to ask that if you are of stage 4A disease, then is it better to do the laser first and then pose the patient a week later, because probably the laser itself can help in the PVD to get induced? Does it help like that?
It doesn't happen in ROP like that. Like you do a laser, PVD happens, then all the patients whom we operate in stage 4A and 4B should have a PVD. Doesn't happen.
Does it help in easier reduction of the PVDs?
I would think of doing laser only if the proliferation is actively vascular, but in that situation again, like now we give anti-VEGF and take it up rather than do laser and wait for it, because laser again can make the retina, particularly in about a week's time, if the adhesion is not the laser edema can also make it bad. So I wouldn't do a laser and wait. I would probably think of doing an anti-VEGF and wait.
Thank you, Rekha. Thank you for the excellent presentation.
So now I invite Dr. Avani for her surgical presentation on bilateral exudative retinal detachment with unilateral intraretinal cysts. So there is one more announcement. So pre-lunch we will be having a group photograph, and we will also distribute the certificates for all the presenters. So do stay with us.
Space bar.
Good afternoon, everyone. Went of exudative retinal detachment with unilateral intraretinal cyst. I will guide you through this complex procedure, highlighting the surgical technique and decision making. A 40-year-old male with 3-month history of progressive visual deterioration in both eyes, no other systemic illness, comprehensive optical examination performed to rule out underlying pathology. OD best-corrected visual acuity 636 with normal anterior segment, fundus showing inferior RDA with macula on. OS best-corrected visual acuity, counting window close to face with inflammatory underneath AC, cells +2, fundus photograph showing exudative RDA with macula off, B-scale showing distinctive hyperechoic line anterior to choroidal layer indicating retinal detachment. Bilateral vitreous inflammation treated with periocular triamcinolone injection and systemic corticosteroid to mitigate the inflammatory response. Slant surgical management for the left eye include lens-sparing vitrectomy aimed at settling the retina. We initiated the procedure by creating 2 ports, supratemporally and supranasally, facilitating infusion from the supratemporal port. A 3rd port was established with a trocar infratemporally. However, we were unable to visualize the tip of trocar within the vitreous cavity, prompting us to continue with supratemporal infusion. Subsequent steps involved subretinal fluid drainage. Despite multiple attempts, we were unable to establish a stable infusion pathway through the infratemporal fluid, prompting us to abandon the initial plan and perform a lensectomy instead. We maintained the integrity of the capsule for the secondary intraocular lens implantation infusion. We can inserted a light pipe through the infratemporal probe, enabling us to perform thorough vitrectomy as well as a removal of clogged lens fragments. Fluid exchange was successfully executed and the retina was settled, marking the completion of initial surgical intervention. On follow-up evaluation, we detected persistent detachment of the retina, evident on fundus photography. A B-scan ultrasound showing an intraretinal cyst in the supratemporal quadrant of retina indicates the presence of fluid-filled pocket within the retinal layers. We performed a second surgery for the persistent detachment in the cyst tumor. We used an AC maintainer that helped to maintain a stable gravity-fed fluid inflow. Despite initial surgical intervention, persistent retinal detachment necessitated a revitrectomy. To elevate the underlying traction, a targeted retinotomy was performed in the supratemporal quadrant, facilitating the drainage of subretinal fluid. Upon careful examination beneath the detached retina, a previously undetected intraretinal cyst was identified. To address this complex pathology, a deliberate and controlled drainage of cyst was executed, ensuring a minimal disruption of surrounding retinal tissue. The retinotomy was performed in the inner layer of the cyst and the fluid drained from the cyst with the help of a fluid needle. Surrounding the site Post-operative evaluation revealed the best corrected visual acuity of 660 with prescribed diopters beyond. We anticipate performing silicone removal and secondary intraocular lens implantation within 2 to 3 months. This complex case underscores the importance of meticulous surgical technique, careful follow-up, and conservative intervention to achieve optimal outcome in the management of exudative retinal detachment. Thank you. This video is showing.
Thank you. Any tips? I think we'll be talking about the sclerotomies and infusion cannulas. Sangeet also gave us some tips. So, any other tips on how you would manage a case with sometimes a very severe bullous retinal detachment with severe massive choroidal detachment?
Why was this taken up to be a exudative detachment?
Sorry, sir, I don't know.
Why was it diagnosed as an exudative retinal?
It was a bilateral retinal detachment. We found no any holes, and the patient complained of 3 months history. And the inflammatory membrane in the left eye was there, sir, with vitreous haze grade 1, sir.
But inflammation can happen even in the retinal detachment. Did the patient undergo an FFA?
No, sir.
Because the first surgery, the retina did not go backwards. It was not so bullous that it was inferior retina was still anterior.
Yes, sir.
So it was not going back. So if it's an exudative detachment, usually the anterior retina goes down the posterior fluid, the fluid goes posteriorly.
No, sir. We didn't find any break.
Finding a break is secondary. You may or may not find a break, but then the way it appeared on the video, it appeared to be a regular detachment. And you said that in the first surgery, GE was done and the retina was attached. So through what was the fluid removed?
Sir, fluid was removed through the retinotomy on the first sitting also.
So initial surgery also, the retinotomy was
yes,
done.
sir.
And second surgery, the fluid persisted. What I would have done is, the first surgery, oil was placed, right?
Yes.
And then there was a persistent detachment.
Yes.
And if you were suspecting an exudative detachment, I would have done an FFA at that point in time to see if it is really it's an exudative detachment or if it's a regularity which we are missing.
Yes.
And if it's an exudative detachment, I actually don't even go into the vitreous cavity. So what I would do is to transconnectively drain with the 24 gauge needle, the plunger removed from the syringe, the bevel facing RPE, go into the connective cul-de-sac and then enter into the eye and inject from the other side. So blindly, just through the microscope, you can do this if you are able to keep the needle tangentially and then reattach the retina and look for the cross and then do the laser. Otherwise, if you are uncomfortable doing this, yes, you can put a chandelier, then go inside and then visualize with the biome system and then transconnectively you enter the needle. You can see the needle entering into subconnective space through the biome and then switch on the infusion or inject, drain the fluid, reattach the retina without vitrectomy and then treat the cause for the exudation and come out.
Yes, sir.
You can also use your trocar, valveless trocar, just tangentially to passively drain out
the only concern is that the retina can get sucked into the trocar cannula and going posterior, and that would mean only temporarily you can go, but with the needle you can go infranasally, supranasally, wherever you want you can go with the needle. So anyway, you can use a trocar, it's a little faster as compared to the surgeries.
Sir, I have one query. What would you have done if you had found that intraretinal cyst? You would have left it or you would have drained it, sir?
Intraretinal cyst will go away if the detachment is taken care of. So if the regular retinal detachment, we have done buckle with patients with intraretinal cyst, this collapses. So the cyst did not collapse because the detachment, the hole was probably not taken care of. That's why the persistent detachment was there and probably the cyst did not collapse. If you want to collapse it, yes, you can collapse it. But what I would do is I have done a scleral buckling and then drain the cyst transclearly also. So outer wall of the cyst I perforate and then allow it to collapse rather than go from the inside.
Thank you so much. The very fact there is a cyst goes in favor of retinal disease. I have never heard of a cyst in exudative detachment.
Right. Thank you. We move on to the next presentation.
So now I invite Dr. Vijay Mehta for his presentation on post-operative surprise, managing the case of malignant glaucoma post-cataract surgery.
So till the next presentation goes on, I have a different technique of training that the suprachoroidal officer retinal fluid. I use a Venflon cannula. So just go inside and remove the steel part, and just the plastic remains inside, which is less traumatic. And you can even attach the Venflon to your extrusion pump, and you can actively drain the fluid.
Yes, sir. Excellent videos you see. They are famous all over.
I totally use a 26 gauge.
Good afternoon, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to share my case here. So, a 60-year-old female was referred to me 10 days post uneventful left eye phaco surgery. The patient had previously presented to her operating ophthalmologist with sudden painful loss of vision in the left eye 4 days prior, with associated with redness and bouts of vomiting. On examination, what we noted was the patient's visual acuity in the left eye was counting fingers close to face. We couldn't do attenuation chronometry as the patient had significant corneal edema, but digitally the eye was rock hard. The intake chamber was shallow throughout with significant AC reaction. There was a membrane covering the pupillary area, membrane in the pupillary area with 360 degrees posterior semicate. We couldn't see the fundus because of significant corneal edema, so we went ahead and did the B-scan ultrasonogram to rule out hemorrhagic choroiditis, and there were none. So the patient was started on multiple antiglaucoma medication, psychoplegics and steroid, and a provisional diagnosis of pupillary block or malignant glaucoma was made. Second day, when the cornea cleared relatively, we went ahead and did 2 YAG PI for the patient and reviewed the patient after 3 days. Patient was on maximum medical management, cornea was relatively clear, but AC still was shallow, and the IOP was 40 millimeters of mercury. So we suspected malignant glaucoma, unfortunately for this patient. Unfortunately, we don't have UBM, but what we thought was surgical intervention was the best course of management for this patient. So as you can see, the patient has 360 degree posterior synechia with a membrane in the pupillary area and quite a shallow anterior chamber. So what I did was I went ahead and put a sclerotomy port in the infratemporal quadrant, hoping that a little bit of liquid vitreous would ooze out or egress out from the port, which would facilitate my entry in the anterior chamber. And so, fortunately for me, liquid vitreous did kind of ooze out, and the globe decompressed a little. And when I was kind of okay with the globe firmness, I went ahead and made a couple of side port entries in the eye. I injected Visco to deepen the anterior chamber and release whatever peripheral anterior synechia there might have been. Use iris depositors to completely release the posterior synechia 360 degrees. With the help of cutter, I removed the evidence of iris that was stuck to the membrane in the pupillary area. Again with the cutter, I punched a hole in the membrane in the pupillary area and kind of went ahead and expanded the opening. So as you can see, there was a significant opening in the anterior membrane. I just expanded it, and once I was okay with the amount of anterior membraneectomy, I went ahead and did pars plana vitrectomy for the patient. I just did core vitrectomy. I didn't use PVD in this patient. Only thing is, when I was doing the vitrectomy, what I noticed was the patient had multiple hemorrhages on the retina. So basically, the patient might have pre-existing CRVO or had developed CRVO due to the persistent rise in IOP. Just to take care of whatever edema there might have been because of the CRVO, I went ahead and injected triamcinolone acetonide in the eye and did a surgical PI inferiorly and closed the case. So this is the patient 3 months post-surgery. Her best corrected visual acuity was 20/80. Her IOP without any antiglaucoma medication was 9 millimeters of mercury. Cornea clear, AC quiet, ILMC2. Only thing is the vision didn't improve beyond 20/80 because of the disc pallor and the issue event that had happened. Thank you.
Thank you, Richard. Interesting case. Any comments from the panel? Yeah, please.
I think this is decompression retinopathy. This is not CRE. Because if you decompress the eye suddenly from very rock hard IOP, then you will get these retinal hemorrhages. Okay. Yeah. So it has to be a very slow aspiration, if at all, and you have to use the anterior chamber maintainer actually. Okay. That will solve most of the problem. Okay. And multiple PVIs.
Any other comments, Sangeet? Mahesh?
So if we are not able to inject anything, I just use the 26 gauge needle on the viscoelastic and just inject it and just give some space over there.
Yes.
I think UBM also might could have helped for surgery. That shows the orientation in the angles iris structures. And if I would have also done iridozonulo hyalotomy, what is called, it releases, it creates the passage for the vitreous or the fluid to migrate. So even the zonulo hyalotomy with the zonules opening, with the iris opening, if we create in the same plane, then helps in relieving this malignant glaucoma.
Another thing that nowadays I've stopped using the core vitrectomy and do a complete vitrectomy in these cases.
So this is a case of malignant glaucoma or intraocular glaucoma. So there was seclusion pupillary and peripheral tear signing.
So the thing is,
peripheral PI would have.
The thing is, the operating surgeon had seen this patient twice post-surgery, and the patient was absolutely raised. He was quiet. Whatever happened, she had seen the patient on day 1 and day 5 post-surgery, and day 3 or day 4. So this happened within a span of say 2 to 3 days, and the patient was on all the the steroids and also. This is probably not inflammatory. Inflammation is not probably the cause for the raised intraocular pressure.
It was seclusion and
there was an element of seclusion. There was an element of seclusion. No, that happens after malignant glaucoma when the iris is cut. And if you see your video, most of the manipulation was done without an infusion. Yes. Okay. So that actually produces hypochrony and the decompression of the.
Yeah, Ramesh.
Post-operative UBM, after you did everything, did you do a post-operative?
So I don't have UBM facility, and that's what I said, that I should have done UBM, but we don't have a UBM facility, and so it was a confusion between pupillary block and malignant glaucoma, but I did take an opinion, just had the case with the glaucoma specialist here in Ahmedabad, and she was of the opinion that this mostly is a malignant glaucoma.
And so what is the panelist's opinion on recurrences following malignant vitrectomy for malignant glaucoma? Is it very frequently seen, or what is the thing? Because
not frequent, but I have had cases where you have repeat.
Actually, I used to see it when I used to do core vitrectomy. So since I have started doing a complete vitrectomy, I have, yeah.
Thank you, Ruchi. I think excellent, very well managed case. Yeah.
What we have learned in literature is if it is a malignant glaucoma, you need to do the iridozonulo iridotomy, what was explaining. So, did you do this in your case?
Sorry?
No, he did not. No.
So that is either or. So what you are saying, vitrectomy or pars-plana vitrectomy, either of them works. It's not that thing has to be done. You can do pars-plana vitrectomy.
Mahesh, is that a compulsory step? I do that as a compulsory step in my cases where I label it as a malignant glaucoma.
Yeah, the anterior hyaloid has to be removed, otherwise it can't recur. And one of the ways of decreasing the risk of recurrence is what you are saying, that make that one permanent opening. So I would at least anterior hyaloid, if you are not assured that you can remove completely, this opening has to be made.
Sylvia, last comment?
Just to suggest that what I've done just with the YAG opening itself. So you could keep hitting through that YAG opening and then create into the anterior vitreous opening also. So, but having then membrane in the pupillary area in a malignant glaucoma is usually not going hand in hand. So that's where it's not matching.
No, she wasn't. Only thing is with hyalotomy with YAG, there are a lot of cases of recurrence. So now the general consensus is there is only one treatment, which is vitrectomy or the hyalotomy and vitrectomy. With YAG hyalotomy, there is a lot of recurrence. so that is something that might not have.
As he said, complete vitrectomy.
Yes, complete vitrectomy, absolutely. The gag hydrotomy, there is a lot of recurrence.
Thank you, Ruchi. We move on to the last case for this session.
Now I present Dr. Rajneesh Rajput for his presentation on autologous posterior capsule graft for macular surgery. We preserve the best for the last.
Yes.
Thank you everyone. This is the posterior capsular graft for the primary macular hole surgery. Why I did this is because of the simplicity of the surgery. Simple ILM filling was done, and I found little easy than the inverted ILM filling. In that case, we are damaging more and more retina. And this posterior capsule itself has a similar basement membrane like the internal limiting membrane. So it will help in bridging the cell migration over the retinal tissue, over the macular hole. And one of the studies has shown that microglia and the macroglia of the posterior capsule and the anterior capsule is more or like similar as the ILM, our internal limiting membrane. So that itself will increase the scaffolding of the cell migration from the surrounding retina to close the macular hole. And here we can easily close the any size, we can say larger macular hole with the help of autologous posterior capsule. I did few cases. This is the one I am showing. Difficulty is we have to grasp the posterior capsule with the ILM forceps. And again, as we know, it is a transparent thing. So many of the doctors are staining with either ICG or a Japan plate to see easily visibility during the surgery. I tried with the viscoelastic over the posterior board so that most of the time it will not migrate. So this is, and again I have to shift from one hand to another hand. As you can see, I am taking from the one forceps to the another forceps. Trying to flip over the macular hole. Few cases, viscoelastic was used to stabilize the posterior capsule around the macular hole. Fluid air exchange was done. Few cases I have used the perfluorocarbon liquid to stabilize the posterior capsule in these kind of cases. This is just try to shift the posterior capsule over the macular hole. You can fairly see it just lying above the macular hole. Finally, the test was done and the C3 was injected with the prone position of minimum 10 days. So this is the pre-op. post-op after the 6 weeks of the surgery. Vision has improved significantly. Few of the queries I have made. So, what is the size of the posterior capsule we should keep? In literature, they have told 1 mm more than the macular hole size will be enough for closing.
Yeah, so comments from the panelists? Sangeet, Mahesh?
I have not used posterior capsule as such for macular holes. Actually, as a primary surgery for a macular hole, I will just do an inverted flap and put in the tamponade. But nowadays, even like I'm using inverted flap, I'm putting viscoat. I'm not using any tamponade. But for a persistent macular hole, definitely what I routinely use is a free iron flap. And move the flap under the PFCL over the macular hole. Don't stuff it inside, and then use a tamponade. I personally have not used the lens caps.
I have not used this as a primary option, but I have used this as a secondary option. But it was like probably 10-15 years back. Anterior capsule, posterior capsule, ILM flap, retinal flap, macular hole like a dustbin. You can put anything in it. That's how it is. What I would do is, like, I would not use the cutter to cut. I would use a forceps in one hand and the scissors in one hand. That gives you a nice capsular margin. So cutter, because like you make it very large. So that's how. So in a situation where you have peeled ILM extensively and there is no ILM left to put there, that's where I have used the posterior capsule. The problem with the posterior capsule, sometimes there is the dequalification of the lens cells are there. So whether it will have an adverse impact or not, we don't know. But it's the easiest available, so you can cut it and then put it there. Anterior capsule, if in case the patient is undergoing a cataract surgery plus that, in that situation, the rexus which I have removed and then used that to put it there. So you just need a template over which it goes. But it's a very large hole, and like I would agree with Sangeet, in this particular patient I would not have used anything because the ILM filling was so beautifully done. You just trim it and leave it and that would have worked. In a very large hole, now I probably, if in case the patient has an associated detachment, then I would probably think of using a retinal tract. So each case wise it differs. But yes, I have used this, nothing special except for the fact that like in a recurrent surgery where there is no ILM left, it's easiest to harvest and put it there. So it is also something which you can use.
What I found in this free ILM peeling graft and the posterior capsular graft, ILM is less density than the posterior capsular graft. So if we once keep the posterior capsule over the macular hole, it's remain there most of the time. While and even not moving during the fluid air exchange. So that is very, very safe I found. In ILM is very, very fragile. So most of the time it comes, if we have done the free ILM graft, it comes in our back plus middle. So all surgery has gone and then we can just try if patient is pseudo-phakic, we can keep that posterior capsule as a adjuvant.
No, I agree. Only problem is this tissue, what we need is a scaffold.
Yes.
And this tissue doesn't get absorbed easily in contrast to ILM. So the ILM goes away and the retinal tissue grows over it and bridges or grows under it. But here this tissue may remain. So whether it has got an impact on the closure and visual outcome and the retinal cell integration is something which we don't know. That's what it is.
Yeah.
Do you stuff it inside or just overlay it?
I'm overlaying it over the macular hole.
Ramesh, come.
When you're overlaying, do you want to know which side is going to be up, which side is going to be?
Yeah, I just try to keep the outer side of the capsule over the macular hole, but it's again a very difficult to identify because during the manipulation, like it may turn around.
Because when I was seeing the video, it was more like you were inserting it inside the macular hole.
It is because of viscomate I have just kept over it. So it is never touching the bare RP. So it's very safe.
The latest thing people have stuck is the subtenance capsule. Dr. Shengul has shown, particularly if you have a macular hole with a retinal detachment, you can use the patient's subtenance capsule.
In fact, one of my colleagues is actually stuffing the vitreous itself inside the macular hole.
Great, thank you, Alpesh. So we come to the end of the morning session, and I would request everybody to come for the group photo. We were very fortunate to have blessings of Dr. Nagpal yesterday. We personally went and met him, and he has showered his blessings for our society. This cannot be possible without him. You know, he's our father figure for retina, not only for India but for Gujarat. Is absolutely a father figure, and he especially conveyed his blessings, and I'm sure so is Dr. Badrinath from heaven and Dr. Namkaran Swami, who are the three pillars of retina in India. So we seek their blessings, and we look forward to active participation from youngsters more and more. We would like all of us to please gather here for the group photo, and then we'll distribute the certificates for the morning session. Parth has a few announcements. You can just continue the announcements while people are setting up for the photo. Save us time. The cameraman will tell us how to adjust.
I think everyone after this piece of knowledge, I think
અહીંયા સુધી છે ને સ્ટેપ સુધી થોડી અહીંયા વચ્ચે જે મૂકી દો સ્ટેપ ઉપર બધે બેસે ને થોડા ઉપર રહી શકે અહીંયા ઉપર આ કેમેરાને પાછળ અહીંયા ચલો મિલનભાઈ સાહેબ આવી જાઓ સાઈડ લઈ જાઓ
Sir, Mahesh sir.
ચાલશે આ હટાવવાની કે ત્યાં બનવાનું બધું સેટ સેલો ટેપ સર પ્લીઝ बात ही है जितने आ सकते हैं आंसर पर
नकीना क्यों ना
ये मुझे
દીપક ભાઈ લાઇટ વધારે જોઈએ છે. આ લાઇટ કરે છોકરીઓ આગળ આવી બધી છોકરીઓને આ બાજુ લઈ લો બધા. સાંભળ તમે બધા ફોલો કરશે તો અહીંયા આવી જાય मानन जय आजा
That's very good.
Thank you.
Very good job. Yes.
હવે સાંભળ ડિસ્પર્સ પછી બધા જમવા જતા રહ્યા પછી ડિસ્પર્સ થઈ જશે લેટિન હવે બધા લંચમાં હવે કોઈ ના ઉભા હવે કોઈ સર્ટિફિકેટ પછી જ આપવા પડે પછી જ આપવા પડે
મારો કાર છે એ વિડીયો
speak everything.
Say nice things about
It's live. It's live. It's
Say
live.
nice things. You're welcome.
Okay, great.
Yes, sir.
Present, Parth will be distributing the certificates. Dr. Vaibhavi.
Oh.
Dr. Praful.
Next, Dr. Deepak.
Just second.
Dr. Vishal India. Crowne. Dr. Gunjan. Dr. Rekha. Dr. Avni. Dr. Ruchir. Alpesh. Vaibhavi. Vaibhavi. Aditya. Ruchir. I would just like to mention that this has been a great team effort, and Parth will introduce the entire team of the Vitreo Retina Association of Gujarat, and each and everyone has worked tremendously hard for this meeting. It's just the first meeting, we had a very short time, so there could be some shortcomings, so please bear with us, but we would definitely like suggestions from all of you. We like to make it very interactive, and that's the whole philosophy of this meeting and the society, and we want more and more youngsters to be actively participating. Just a brief introduction about
Very good afternoon, everyone.
Oh.
Very good afternoon.
How's the Josh? Everyone's sleepy after this meal. Yes, but we have very good sessions after this. Just a brief introduction about Vitreo Retina Association of Gujarat. It's around a 1.5 year journey from where we have started this organization. Like basically, this organization is there to give you the academic support as well as practical support in your practice, legal support whenever someone needs, and even like a brotherhood, like which we can create here. Like all of us are retina surgeons, and so many times it seems like a rival or a competitor who's sitting beside, and it creates a bad impression in front of patients also and in our mind also, and we can make some difference in the society. So here is the team which made this possible. So I'll invite Alessa, Dr. Kushal, Kumar sir, Dr. Madhvi, Dr. Kaushal, please, and sir, Dr. Milan Matka. So, come on sir, come on sir, please. So, these are the pillars of VRAG. We all are
गाड़ी दे बाजू का तेरा साइज में सरकार look here. Just second. Sir, look here everyone. Thank you.
So basically we are all trustees and this VRAG, and the executive committee will be set up shortly. Actually, we didn't have the time because there were some legal proceedings for this registering the trust of VRAG, and I hope you all enjoyed here. Anyone, any suggestions if you want to give here, or there will be feedback forms which will be shared to you in your WhatsApp also and groups also, that you can do it. And I'll thank everyone for taking time on Sunday and coming here. And I'll thank all the companies who have supported us, and with their support, we are able to do this meeting. Thank you.
I think a special mention to our sponsors, because we actually had less than a month to organize the whole meeting, and it's a very complicated process to get these sponsors money, and all of these sponsors, they've been extremely helpful in doing so. So I think they deserve a big round of applause. And I think most importantly, the faculty, in such a short notice, hardly 2 weeks notice, they have all agreed to come down and spend their precious Sunday with us. So thank you very much, the entire faculty from all over India. We have a feedback form. So we plan to have an annual meeting on a rotating basis. It's never Ahmedabad. So hopefully Madhvi will take the lead in organizing the next meeting in Baroda, and probably we'll be doing it in a larger scale also, and we'll invite suggestions from you, and we'll be rotating to different cities of Gujarat. In the meantime, if you have suggestions, we can have short-term courses or CMEs or whatever. It's according to your needs. And we probably have a very small half-an-hour session now, just a very informal discussion. Dr. Kaushal came up with this idea of having a practice management session, basically for the youngsters, just to, as he said, to develop a brotherhood, discuss few problems what the youngsters are having in their initial years of practice. So please feel free, this is an open forum. We don't have a fixed agenda. We would like to have questions from you and discuss. And I invite Dr. Kaushal to lead the discussion.
There are a few questions which were asked in the group, and we got good responses. So based on that, we'll just put forward a few scenarios that are basically we come along during our meeting, during the practices. So it's basically a discussion kind of thing. Anyone can points. So one scenario is that nowadays that lot of patients, they tell that there are few of those their relatives who are working in the pharmacies, and whenever you advise them anti-VGS or let us say implants and all those things, so they a lot of times say that we will procure from them directly and we will get the injections to you just in there. So how to tackle such scenarios and how we should go about it? Because we are trying to form a general consensus that helps all the Vitreo Retina and neural practitioners across the Gujarat. So we can start listening.
Kaushal, it's a very Kushal, it's a very common scenario. The main issue and problem is that it is the temperature control. They can bring the drug. I mean, I particularly have no issues with that. But we have to be very, very strict about the temperature control, the drugs that they bring. And as a rule in my hospital, even when any company delivers the drug, I insist that they have a temperature log inside the thermocol box. So unless and until the patient brings the drug with this thermocol box sealed with a temperature log inside, I will not accept the drug. That is my philosophy.
Here is mine.
Because you can't force the patient and tell them you cannot bring, It's fine. It doesn't matter. As long as the protocol is followed, I think we are okay with it.
So, sir, you need to say that if the protocol is maintained by the patient, you will still inject the drug if patient brings the injections?
Yeah, I do that.
So, but any specific consent which you take from them?
So
you have brought it and...
Good thing that you mentioned. Yes, I do make a specific mention of a consent in their own handwriting, saying that I have brought the drug and I will be responsible for any adverse events relating to the transport of the drug and any immediate adverse events happening, because we explain that most of the adverse events that happen in anti-VEGF drugs is because the temperature log is not mentioned. And that's why you've seen, in majority of the cases that we have seen happening as a cluster, mostly it is related to the improper management of the temperature control.
How can you track the cold chain of the patient which got the injections?
That's what I'm saying. I have a temperature log, and we have only 2 or 3 particular distributors in Ahmedabad who are really qualified, and I have faith in them, and they have a very good chat. Personally, I've been there and seen their whole cold chain maintenance program. So only if it is coming from them, then I'll accept.
No, let me give you an example. We had a patient whose son is a retinal physician somewhere in the US. They came with physician sample 11 IL injections to be given every 2 months. They come without a letter. They came without OCTs or angiograms. They were told to just keep it in ice.
Dry ice.
Yeah. And you will be surprised.
Keep it mic close.
Injecting. I mean, are they okay with even doing some
Close. Keep it mic close. Keep it mic close. So.
Yeah, but they didn't want to pay for a standby anesthetist. They said in the US there's no anesthetist, we cannot pay for the anesthetist, and I think they went elsewhere, but it is tricky sometimes. They come with 11 injections, that's a physician sample. They do come. It's not like they bought them, and their son is a doctor, so it's being done in the proper manner, it still gets tricky. So
I think just take a special consent. That is what I feel.
So another thing is that nowadays we have a lot of empanelment. So from there they procure the drug themselves, and obviously they do deliver to the hospitals. But do we have to have any consensus for the companies? It is also their responsibility to make sure that the cold chain is maintained from this like CGHS and all those empanelment or something like that.
But I personally feel that whatever consent you take, ultimately the court will take its doctor's responsibility when you inject inside the eye. So I think we should not encourage the patient to bring the injections. It should be all the hospital supply. I would like to ask other
This is especially an issue with the hand, like CGHS patients. Some of my patients just bring injections in hands and ask me to inject. Even once upon a time, the patient came with the box was totally melt in the ice packs. So such kind of scenarios are happening, and there actually we are responsible for everything. So better idea is not to encourage them for such.
If it's an obviously damaged injection, we can turn it down.
Yeah, we can turn it down. Exactly.
But injection is actually at a time what happens in CGHS and in ESIS. If you return it back, they will not take it back.
That's not
And the issue occurs here. So the patient will ultimately diagnose that why you are not.
If the injection is well maintained, the cold chain is maintained, then we can't actually refuse. You set your rules, you set your fees, charges, and do it. And take a consent.
That's what I'm saying. Ask for a temperature log. Believe me. Sealed box with a temperature log inside. That is a rule for all injection, not just patient. Even normal delivery. Because what had happened, I don't want to mention the names, but there were many of the companies when they started distributing drugs. When I saw you open the thermocol box, there's nothing inside, not even ice pack. They just deliver it. So then I said nothing doing. You have to have a temperature log, and we have a record keeping. So we have a full data record everywhere. Whenever they deliver a drug, it is signed in, the temperature log is mentioned in, we take a photograph of what is delivered. So it's a protocol. Every hospital should have your own protocol, and as they said, you should follow the protocol.
Yes, what you're saying is true. Sometimes the cold chain has been lost. So you see the box has been back, and then they
the
put it
company
back
is already supplied with the cold chain.
But you can say the box
But from
is damaged,
CGHS or from ESIS, that's doctors,
you have to take a photo, say the box is
There is no
damaged.
temperature
We
log.
are not
The
sure
box
the
is
cold
damaged.
chain was maintained. Na padide.
Because when patient is beginning the injection, we are not sure about the initial part of the cold chain
Exactly.
because at the time if it is okay, temperature is fine. But where he got it from, we don't know. And if that particular area was that the cold chain was maintained or not, we don't know. So that's the main problem.
In my personal opinion, I don't give it. I don't take risk. Because anyhow, like any consent or whatever it is, but if any adverse event happens, so it is on my head why I give the injection. So in my routine OPDs, I don't take any injections which are coming from outside. If it's coming from CGS or something, like it's a clear instruction, they have to get it from the dispensary and directly deliver it to here. If they are taking it at home, I throw it there. In front of patient only, I throw the injection.
Because
whichever injection.
Out of law, it's not admissible. The consent what we take, at the end, the responsibility is on the doctor.
Once I have faced like one patient came with one injection. He was like, from 1 month I have kept the injection in my fridge, and in his fridge, like all food items are there. What fungal infection is there in the fridge, I don't know. And with that, he's coming there. If anything happens, then it's on my head. I can't give the injection like that.
And there is another issue with the Ozurdex implant, which is available online also. So somebody has bring it online from India Mart and then bring us. So is it okay that
Every people have to take the note about it. They are here. Every people are you here. Ankur.
Also, they say it should not be frozen.
Oh, yeah, it should
When
not.
the patient says we put it in the
Deep
fridge,
freeze. Oh, yeah.
did you put it in the deep freeze or was it in the chiller?
We'll move to the next question. So related to this only, so we were talking about consent. So nowadays we have a lot of prepaid formats and templates for the written consent. But how important nowadays has become a video consent? So would like to start, Sir Mahesh, your comment in the routine practice.
We haven't been taking any video consent at the present moment. It's usual surgical consent after explaining is what we take. Video consent, maybe the consent may be required, may be necessary, but then like we need to take a permission for them to have a video taken as well. So for studies, yes, a video consent is something which may be required, but for routine clinical practice, I'm not too sure. But patients will record what we talk, but then like the other way around, I'm not too sure.
I think Madhvi is the correct person to answer. She's qualified to answer any medical legal issues. So Madhvi, what do you think about video consenting and the importance of video consenting?
Yeah, I have come to believe in it. It has become mandatory in the ICUs of Baroda for all cardiac emergency trauma cases. Also, it is your only protection where patients are coming and destroying property. or threatening doctors. So this is normally in Indian law, photos and video records are not considered, but video consent in at least ICUs in Baroda is mandatory. So if you take it, it is an additional protection.
Additional benefit.
Lately I have started in few cases, and in retinal surgery, many times when you are a solo practice, everything in the clinic comes to you only. Because anything happens, the patient's relative, they wanted to talk with you only. Okay. And majority patients many times require multiple surgery. You need oil removal, after that also you need a recurrent detachment. So I personally feel if you take a video consent with the consent of patients, so that will be helping explaining them, because many times in our scenario what I observed, when you operate some patients, after a few days or weeks, some another distant relative come to you and meet you and ask you about the patient's condition, how it happens, how this complication happens. So at that time, if you have a video consent recorded, and if you can show, that will be a profound effect. Especially in cases where you need a multiple surgery, when you see the patients are facing, patients' education level is poor, many times coming from poor social, financial issues is there with the patient. I think it does help.
Currently, even amongst, I'm doing video consent as a rule for all my ROP treatments.
So, how many of us can raise their hand and taking video consent? So, consensus is still not there. Lacking.
One-eyed, babies, endos. Makes sense.
Like special,
that's what we were discussing.
Special considerations.
Yeah, special considerations.
High-risk cases. High-risk cases. And very extreme poor prognosis cases.
Dr. Vasavda for congenital cataracts has been taking consent with the magistrate present from so many years.
As per guideline, even if you want to take a AV consent, you must have a AV consent paper prior to taking AV consent. You must have to take a consent in paper that will be taking your video consent. That is necessary as per regulations.
True.
So
you have to inform them. Similarly, when they are recording you, if they have taken it without your permission, it's not a valid. So that is the basic ground.
So another scenario is we have a lot of seniors amongst us. So as a juniors, lot of times when we are starting initial cases, sometimes we do face complications like DRDs or let us say cataract surgeon having an endophthalmitis. So a lot of times they are obviously sent to a DR surgeon. But again, patient might go for second opinion despite the DR surgeon has treated the patient best. So in such case scenarios, how do you proceed helping out the colleagues of the same fraternity? A lot of times patients do have that notion that something bad has been done despite the best effort. So would like to have opinion from the seniors.
First, the most important thing is not to criticize our colleague. And many years back I learned from Dr. Nagpal sir that in spite he was seeing a patient of endophthalmitis, post-operative endophthalmitis, and he was praising beautiful surgery, this, that. So this is very important. There is a very lot of impact on the patient and relatives.
My personal opinion, like in my routine OPDs, like when the cases comes like this, so the first response, like when if they are coming to us, we know like why they are here, like if macular edema is there, or if some other complication, or some corneal edema is there, they are coming there. But the first word, what comes out of the mouth is, like the lens is there. Like whatever good thing is there, you just explain them first. Like if they have put the IOL properly, you just tell them the lens is there, the surgery was to remove the cataract has been removed, the IOL is in place. So main work is done. Now whatever little bit edema is there, that will recover it and you will regain the vision. So whatever positive things are there, if you are telling them first, then they will gain trust in you also, and they will gain trust in that previous doctor also. Because bad mouthing is the main reason behind the legal cases. Few days ago only we had a meeting with Dr. Lahane, and he was telling about the Bombay case scenario that they don't have any medical legal cases against any of the ophthalmologists there, just because like they have that kind of fraternity that no one badmouths about anyone else. So if anything wrong is also there, then you have to protect your colleague, because that is the main thing which will give you the protection in this society. Otherwise, everyone wants to take a chunk from doctors because they know doctors are the most soft target in the society.
Another point is related to our own cases like recurrent retinal detachments. We are all aware of this. Despite best efforts, despite, let us say, a hypothetical case where patient was operated for RD, everything went well. Then post silicone oil removed also, everything went well. But after 1 month, let us say, patient develops a full thickness macular hole. So still he is not able to see as per this expectation, and he feels that silicone oil being in there, he was having good vision. But post removal, he is now facing still trouble. So he starts believing that the purpose of first surgery was to re-attach retina. So he does not understand that this hole is something which is an idiopathic case which has happened secondary. So how we can deal and how we can counsel such patients? Of course we have to be patient, but then vice versa.
It's something which will come with us as long as we are here, there is no escaping it. So how would we explain, and then we have to walk the thin line of whether we have done our best. If we have done our best for a given patient and the patient recurs, then you know that like, the disease has gone over you. So we have to walk that line. And if you have done our best, then we can confidently face the patient and say we have done our best despite which the disease. So at that point in time, if we have a guilt, then that shows up when we talk to the patient. If we don't have a guilt, then we have done our best. Of course, complications can happen despite doing our best. But if we haven't done our best under that given situation, then it helps us face the patient a little bit more confidently. That's what
I think you should face the patient more confidently, and you can, if patient is unsatisfied, you ask him to take a second opinion, you give the suggestions, it will share the responsibility also. And when he go for second opinion, third opinion, he will realize whatever is done by primary surgeon is good. So I personally feel whenever you come across with such situations, you should be more confident and you take opinion from your colleague. That will definitely share your responsibility. You call your colleague and ask him for technical opinion. So I think when a 2 or 3 persons explaining the same thing, then have it accepted.
Another very important point to note is, of course, take a second opinion, but you call that patient in a very particular time of your OPD. When you are also relaxed, you don't have 10 patients after that, because otherwise you will get irritated, because he's going to take up a lot of your time. So give him ample time. Maybe the last slot of your OPD once you finish, and then give him ample time. If you explain to them in details, they will, most cases, they will calm down. But it's like they come in the middle of the OPD, you have 15 patients to see, your mind is constantly, getting irritated. So that is also very important.
Another most important thing, as a surgeon, you should not lose the patients. Because if you lose the patient in front of you, he will forget everything and he will catch those things only. So you need to be very patient.
What you are using should be from your mind.
You should be calm, and anytime he asks, as a patient he has not got the vision. So he has all right to ask 100 questions. You should be patient enough to answer him all the questions. You should not neglect him. You should not get irritated by the patient's questions. Because we have to think in his perspective also. He has not gained the vision. That's why he is complaining us. That is also
one of the primary problems is the pre-op counseling. The first time around, you have to be realistic. Don't over-promise what is not possible. So there, 50% of the problem is solved at that stage.
But so many times it happens, like in RD cases, if you tell them you are not going to get 100% vision, after surgery they have regained the vision and they are telling, sir, other eye, दूसरी eye जैसा नहीं दिख रहा अभी.
That's still, that means your counseling is not perfect. You still have to counsel in a better way.
Next question is very much the top of the town nowadays. It's these cashless issues as well as the PNJ. So, like to have inputs on how to go about with this challenges.
I think for cashless thing, we have to have a unity, because that is the thing I have seen in so many of the good societies like Baroda. Madhu Madam will explain it better, because in Baroda at least they have unity. Like if they are doing, they'll do like cases, this many cases they are going to do, they'll do with this prices only. Minimum price caps they have given, and everyone should do at that prices only, and if they are not doing it, the societies are debarring them. They are not letting them come to that meetings, and they are not inviting them for other places wherever society is there.
Do you have in Ahmedabad cash-free insurance? So actually, in the where we know a lot of corporates are there in the city, and they are doing outright cashless. So we just cannot say outright no to the cashless. But in Surat, we have started there is one company who started cash-free insurance. What it means is, when the patient comes to you and asks for the cashless insurance, we take the insurance policy from the patients, and we part to this company. They will process and they will tell you how much insurance the patient will reimburse. And suppose that was 60,000, 50,000 is going to be reimbursed. Then we inform to the patients that your 50,000 will be reimbursed. So now what this company will do, the 50,000 they will transfer into the patient's account, and patient will pay to the hospital 50,000. So patient part is over, hospital part is over, and then they will take whole responsibility of passing the claim to the patients, but they will charge nominal 5 to 10% from the hospital. But this is the way you cannot lose the patient, because as a cashless, to go in the big companies, as a solo practitioner, it's a big challenge. They will eat you, cashless company will eat you, insurance company. So I think this cash price is a good option.
Recently, sir, I think because there is an Ahmedabad Hospital and Nursing Association, they have come out that after with effect from 1st April, they are going to ban cashless from certain companies. So I think the unity of the society comes to a significance here, that if Gujarat is doing this, so probably we can consider this as a for a VRAG also, that how to go about in the future.
For Gujarat, like we'll put a Google form and WhatsApp group. Like what are the prices like they want for their OPD, OCTs and their surgeries. And I think there should be a minimum price we should put it, except all the government hospitals. Like people should have a minimum prices from where they should start. Even in Ahmedabad, all barbers have minimum pricing, but we doctors don't have, because we don't have the unity. So unity is the main key for this cashless and everything. Otherwise, solo practitioners are not going to be there after 10 years, like what happened in the US and all.
Major problem whether it is cashless or reimbursement. Now, the injections are not getting reimbursed by the 4 major government insurances. Only the first injection is being reimbursed, and then onwards they are getting only 10%. So if you see National, United, all.
75,000. See what happened is the guy passed the guideline for the injection. Then the companies saw they were losing, so they are. So now it is a percentage of some insured or 75,000 a year, whichever is.
Yeah. So it's.
But it usually still works. At least
So
it works up
when
to
patient has to take multiple injections, it's only the first, technically it's only the first injection that is getting reimbursed, and the second, third, they're getting only 10% of the injection cost.
If patient wants to take Vabysmo, it's hardly one injection they are going to get.
Right, this was a problem. But most other injections.
So there will be 2 maximum other injections also.
Not really, because we are able to divide that one between 2 ones. It's just a little more than paracetamol. So
I think VRSI and other retina societies, even EIOS, they have to push it to the government, and government should give the guidelines that this injection should be paid.
They did. Deadline has already passed. Now we have to fight it again because
Yes.
the companies have put up a front. So it's just in round 2. It's bound to happen.
I think now officially we can push it to the third one.
Any other questions from the attendees which you would like to share? Of course, we are going to share a feedback from where we can also have suggestions, but right now, if anyone has any questions.
I'm sure the younger people are going to face a lot of problems buying machines, AMCs, and I think from 1st April, Alcon is increasing all their product prices by 5%. All the disposable prices are increasing by 5%.
Already there is a challenge with you have to buy 6.
And you have to buy 6. That is
who are using Alcon product, Alcon machine?
Yeah.
So I think you all must be buying all the products together, like packs and everything, the forceps and everything. I think we all should have a collaboration and we all should order it together. So like who all are having a license of wholesale pharma, like I am having one. So if I am buying a pack of 6, I can bill you again for 2 or 3 and then I can send it to you. So no one has the burden to give it because it's not like we are not able to invest once. But if we are keeping it at my inventory, so many times it happens that my staff is spoiling something or some things are missing in my inventory. I don't know how it happens, but
Take all record of your inventory.
yes. So it's better like how much we want, we can order it at one place and then we distribute it. So we can have a group also like that. Like not for surgical products, we can have for injections also. Like there we can get good deals also.
Fiber optics, anything which is disposables, like you can. I think that's a very good suggestion. You can work on it. Any more questions, please?
I need some guidelines about using of Avastin vial. What are the guidelines? How much time can you keep it with you?
I think VRSI also already has the guidelines.
But
So
I don't think anybody practices IT.
I know nobody practices. It is such a very strict guideline that for a solo private practitioner to absolutely follow those guidelines is almost impossible. But I think at the present moment that is the only safe document that we have.
Why you want to go for Avastin now? All the biosimilars are so cheap.
Exactly.
The problem with because of biosimilars is the incidence of serious adverse events. Little bit of higher chance. Incidence of what?
Serious adverse events. I don't know.
I've never faced. Yes, they're still cheaper, but not that cheaper either. Peace of mind is more important for me. So
The problem is NTS segment, those who are high profile NTS segments, surgeons have started doing this.
Issue will be solved very soon because the Genova Pharma is coming with preloaded Avastin for ophthalmic use only. The 3rd phase trial is going to be started very soon.
So already Reliance is doing that, and I think Intas will also come shortly in single-use Avastin.
Yes. Unless I don't think any of them are opted to DCGA for clearance of Avastin for ophthalmic. So unless DCGA is cleared for ophthalmic use, we will always be in trouble. That's the issue. So we were using Avastin.
DCJ has already given permission. It's already AIMS are also using it. The 3rd phase trial is already ongoing. We are a part of that 3rd phase trial.
So for Reliance phase 2,
it's cleared in its mind. DCGA, because Roche did not ask for DCGA application, DCGA clearance, they did not submit it. That's why DCGA would not allow Avastin to be used. So if the company which is making it ask for a clearance, then it should be okay.
Sir, Romosozumab biosimilar phase 2 has already been successfully done from Reliance and all. I don't know like whether it will come in market or not, but yeah, phase 2 has already been done from DCGI. They have already given permission. Phase 3 shortly they are going to start in Reliance, Indian-made bevacizumab, and other company has got the Jignesh store. I don't know whether it will come in market.
The company which is making it should apply for the DCGA clearance.
Yes.
So Roche do not want Avastin to be asked for it. They did not want it because they were making
Genova has actually completed phase 1 trial, and for that data they have submitted to DCGI. DCGI has given a permission for 3rd phase trial, which is already been started in 20 centers in India, and will soon be come out with phase 3 data, and then probably it will be available to the market.
Then you should be able to use it. Because the original basic molecule of Avastin, they did not clear it. So there is a biosimilar which they are asking
No,
for.
it's not a biosimilar. I clearly asked them. That's a totally different molecule, and they have made it for ophthalmic use only. It's not. The protein is similar, but the formulation is totally different than and they specifically is the syringe which has been manufactured to inject them, which is a glass syringe, which has a typical particle size which is available for ophthalmic use is mandatory as per FDA guidelines. So it's a very, very stringent molecule which is there formed. But the phase 3 data will come out within a year maybe, and then it will be available to the market.
So I think we'll end this discussion, but again I encourage everyone, if you have any questions, please post it on the group and we will have the experts, and there are a few good suggestions, so I think we will go forwards with that and try to address to those questions. With that, we'll start the last session, a very exciting session on uvea and NTA segment related complications.
So for the next session, we would like to invite amongst panelists Dr. Naveen Mehrotra, Dr. Bharat Ramchandran, Dr. Mukesh Porwal, and Madhu ma'am, can you stay back for the
Remember this. Revenge. Revenge.
Kama sir, please be part of this panel. So with that, we invite our keynote address by Dr. Sudarshan S.A. So, sir is currently senior consultant at the Department of Uveitis in Shankarandralaya, Chennai, and currently also sir is serving as the Secretary of Uveitis Society of India. So, sir is again one of the prolific publishers, and the interesting part in sir's CV was the last 2 lines what we mentioned specifically, and we know the fun-loving nature of the sir also. So that is something which we need to have with us also. So I would like to invite sir once again, and sir, over to you. Thank you.
Sudarshan is one of the funniest speakers I've ever listened to, and so making uvea a very funny session, that's his art.
With age, thanks Kushal, with age I try to be a little more mature and less jokes. And anyway, do nothing, that's what I think I did from morning. So that is one way, like different way of spending Sundays. So what's happening new these days? You're wondering. So lots in Chennai, so no politics. So there is the talk of fair delimitation, like NEP. In VR and Gujarat, yes, we have the VRAG. But then what's happening new in uveitis? But we have a teaser. We cannot have the whole of uveitis things listed. Then let's see. So I try to break it up into 3 or 4 groups about the clinical presentation, whatever we are having new, about investigation, what we are trying to do. There are some here and there, and management and others. So during the COVID era, who's seeing the pointer? During the COVID era, we were getting the COVID-related infections because of the immune deficiency, and that was causing infections. We were having ischemic episodes. Sometimes COVID altered the immune system. So what we are getting now is all those people who were actually now very quiet, the PKH and other uveitic entities which were very quiet, has started getting reactivated. People are getting uveitis at 50 years, 60 years. People are getting uveitis at 50 years, 60 years, and quiet diseases are getting reactivated. Probably because of the vaccine or otherwise, the immune system is getting reactivated. We have the COVID vaccine associated BK-like reaction and so many others. So last 4 or 5 years we are blaming COVID for everything, probably like, so enough of COVID, so let's move on to the new ones. So I'll try to show a few things where what I was doing differently before and what I am doing now. So what I used to do when I see something like this, I used to think that probably it's like some viral disease, think of infectious disease, work up to the ACTAP, chikungunya, dengue, the whole set of diseases. So irrespective of the results, try to use antivirals, use systemic and local. But now what I do, so I know that these are fever associated. It is not necessary that the patient should have fever at the time of the disease or the presentation. They would have had fever at least about 2 or 3 months before also. It is basically an immune-based reaction. If simultaneously any of the tests are positive, then you treat them also. So I go through the whole set of investigations, rule not possible, active infection. But then empirically there have been studies by Narayan group with Ankush and Padmamalini and all that, who've shown that empirical antibiotics with doxy and the full corticosteroid actually works most of them. OCG has shown that these are not actually retinitis, they are like corneal spots and they really work well. which we were already knows, but then it works very well. So now no longer I no longer treat with intravitreal anti-chemotherapy. So no need for systemic antivirals. Treat with doxy and steroids. I don't know whether doxy works or steroid definitely work. The next happening thing for some time now. So I used to have one slide before when I was those initial days at I think probably in Lavasar or one of the VRAGs where so we used to treat one uveitic entity with Vitreo, another uveitic entity with prednisolone, another one with Ahmedabad. So in other words, like anyway, that's a treatment we have. But now we have a lot of many other things. That's the happening thing for some time now. So other than the fever associated retinitis which we get many times, now is there is an article called The Return of an Old Acquaintance. So ocular syphilis. So it seems to trump all other opportunistic infections for now. No politics. So if you get something like this is a 30-year-old male on a patient, HIV known patient on heart, had diminution in the right eye. It almost looks very subtle. You hardly can make out, you know that there is something here, but then you're not very sure. It is not a very classical lesion. And here comes the thing. This is what I start doing nowadays more. You get the autofluorescent pictures and you see much more hyper-autofluorescent areas other than what you're actually seeing in the fundus. So autofluorescence is one thing that has really picked up, especially with syphilis and other lesions where you get deeper retinal lesions or outer retinal lesions. So you fundus picture relatively looks very subtle, single posterior pole or claustrophobia lesion, but you have much more lesions everywhere. This we did RKTPHA and then it turned out to be positive. And an ellipsoid zone disruption, if it is associated with this, then you are surely dealing with a patient of syphilis. The important thing in syphilis is that you can get in HIV or non-HIV, a young male with retinitis, diffuse retinitis like this, or placoid choroidal lesions, then suspect syphilis. You need to do both the tests, especially in HIV. It presents as diffuse retinitis, they are most common. In HIV patients, you have CD4 counts very low, so the inflammation is much lesser. But toxoplasmosis and syphilis are two diseases. Even in HIV, in low CD4 counts, you have significant inflammation. So if you have an atypical retinitis with low CD4 counts but significant inflammation, then you are probably dealing with syphilis or tox. So the titers remain high for a long time after treatment. That's one thing you need to remember. Penicillin is the treatment of choice and it can occur at any age. So important risk groups are the MSMs now. So are there any other groups? I was talking about diffuse retinitis and placoid lesions. If you get these subretinal precipitates or those autofluorescent lesions or a placoid lesion, these are the classical typical presentations for syphilis. So if you have these lesions, then you know that you are probably dealing with the case of syphilis. This is yesterday's coffee maker coffee. I mean, that's what we get on Saturday nights in Ahmedabad, I was told. So azure-like entities is what we are seeing on the rise nowadays. The typical trizonal pattern, probably. So you have the trizone based on the fundus autofluorescence where the normal is outside the demarcation line. You have the speckled hyperautofluorescence within the lesion or the hypoautofluorescence of choroidal atrophy. Similar trizones in ICG or OCT. So this is a very classical description of an azure. We have azure and azure related complex diseases nowadays, but the classical presentation is like this. So azure, initially they were thinking you need to treat them with antivirals and steroids, but now it is a proven fact, it is given that azure you need to treat them with immunomodulators and steroids. So there are other set of diseases which not so fully answered ones nowadays which we seem to be having on the rise. This is a young boy which we have been struggling with nowadays. Looks relatively okay, some subtle RP alterations, and these are the hypoautofluorescence lesions which you get. Progressively, the vision loss is so drastic, it's hand movements, pointing fingers, and you know that there is a significant field loss. So this patient incidentally ACTAP was positive for viral. I am not sure whether this is viral, but probably this is an atypical non-necrotizing type of viral retinitis. This is standard BCAB. You may get patients with subtle pictures like this and some autofluorescent lesions like this. If you progressively follow these patients, you know that they become more, and on treatment it resolves. You can get a better clearer areas in between when you compare. This is an indication that it is doing better. Field loss is one significant factor. You can get the sensitivity areas of the periphery which are picking up. So these are the lesions, at least for the last few months, we've got about 5-6 patients like this which are seeming to be presenting with drastic vision loss. These are the group where you are thinking probably because you are thinking it is AIR, autoimmune retinopathy, or viral, or sudden onset RP. You cannot get a sudden onset RP. So this is one thing that you need to be thinking of always. Rule out viral, then if it doesn't be positive, treat antivirals, otherwise immunomodulation and steroids. We saw the clinical presentations, imaging in the 90s and 2000s, or at least like the early stage. I'm not the 90s person, actually I'm not that old. So I used to be like trying to search the fundus picture everywhere. We were relying upon Montag picture or a stick. Now it's all about wide field photography and angiography. So you can pick up lesions everywhere. You can have doctors, Claris, Mirante, anything. I've been waiting for a long time, I cannot keep on minutes. The wide field angiogram, it picks up all these and these. So often you have other than in retina, PAM, EMN, these acronyms, I thought it is a Gujarat thing. We have a reason who likes acronyms for everything. So the tridents and where you get inflammatory syndrome. So it helps differentiate infective etiologies. So Octa actually it is not necessary that you need to do all these imaging only in white dog syndromes or the non-infective ones. So multimodal imaging actually helps even in infective conditions. This is a really surprising thing. So this was classical. I mean, like you have the best person here for related eye diseases, Dr. Banker, who see thousands of cases. And we've been seeing this severe retinitis, so classically diagnosing it straight away. This is a classical picture. We know this is the active part. But then look close. If you have an autofluorescent lesion, look at this point. There is a hyper-autofluorescent lesion adjacent to the active hypo-autofluorescent. This means that this is going to be the progressive age. This is what we were missing all those days before. See, this you know that this was so far away from the fovea, but it's not like that. It's actually quite close to the fovea. This is the point where you shouldn't miss. So it is not necessary that you treat only the clinical point of it. You know that this needs aggressive treatment, and then you can stop it at that point. You can get to know that there is a lot of inflammation based on the octa hyperreflective spots or the caverns that are classically described in CMV, or these bridging ones. These are the Muller cells which are functional still. It means that at this point, if you intervene, you can still save the retina. This is to show off our plexi-light. It looks so good. RP involvement in CMV shows up as complete loss of normal RP architecture. I mean, clinically not so great value as of now. Let's see. So this is what I want to emphasize again. This is a hyper-autofluorescent lesion, so close to the fovea. Once you start treating, this goes away farther. So it means that watch closely, hyper-autofluorescent lesions close to an adjacent active lesion means it is going to progress. Lab tests, what is I doing nowadays? ERN is one thing. Initially again it used to be clinical, but now you know sometimes that we are not very sure it is active, it is spreading or not. So every time I give an intravit, I take ECTAP and check for the RT-PCR values. He is given permission, right? So the early decreasing trend switched over to oral, and at this point you know that. So based on the RT-PCR values from the aqueous, you can decide how much of the viral copies is decreasing. That's an indication. We can have more discussion about ARN when there are cases being presented. This is one way we can monitor about the ARN progress. The newest one is the next generation sequencing. We are talking about RT-PCR. In general PCR, we give the sample and look for the organism. But in NGS, we actually have the sample itself, I mean, do the test itself, decide which organism is going to come out of it. So here we look, now what we do is we look for the particular virus, look for the particular bacteria. In this, it gives what organism is present in that sample. This is what is the future. We are talking about posterior uveitis. One entity I want to stress, which is not a posterior uveitic entity, is block. So if it is a granulomatous uveitic entity in a child, it can be TB or sarcoid, but one important thing you need to rule out is block. So block syndrome, there is something called NOD2 or CARD15 mutations. It can be sporadic or familial. So if you miss out, you are going to lose the child. So it's all about genes. So uveitis, you need to pick up subtle features, compare. It need not be nepotic, it can be genetic. Beware of imitations. And then, so management-wise, it's not about only systemic. You have local. We are talking about suprachoroidal injections. There are some indications in uveitis where you still use suprachoroidal. This is one of my friend Sriram's video. We don't use that often, but one thing we keep using very often nowadays is about in TB granulomas. This is a subretinal abscess or choroidal granuloma because of TB. So apart from treating on ADT and oral steroids, we give them anti-VEGF and moxi. The current thing is that anti-VEGF also seems to be having antimicrobial products properties now. That's what is the new one, and probably SNS is going to get a patent on it. But then the granuloma, the vascularity over the granuloma is written because anti-VEGF and moxi works. Only thing is it is short acting, so that cannot be an isolated treatment, but you can treat it along with it. It almost vanishes. So you see the first one, and in about a month's time, this is what happens. That's a very good OCT correspondingly helps very well. So what will we keep poking into the eye? It is like clindamycin. This was referred as subretinal abscess, but then if in OCT retina is involved, then it is probably not tuberculous. So if retina choroid is involved, OCT that time picks up, and then it is retina choroidal always stops up. Clinta helps, and 2-3 Clinta injections along with antitoxin, it works very well. Systemically, we always have a step-up approach, steroids, immunomodulators, and biologicals. But then now, in few situations where we can have a step-down approach, where you hit it hard with biologicals or JAK inhibitors, especially in pediatric uveitis or patients. So you have a poor man's biological called tofacitinib, probably a Janus kinase inhibitors. It's a small molecule, oral, affordable, easier access, and better penetration. It's very effective. Remember, there are something else also which is oral, affordable, and then easily. So always remember that be careful. One man's nectar is another man's poison. They say it's probably another rat's poison. So of course, tofacitinib is a very good drug, but then it can have coagulation abnormalities, can have cardiovascular risk, can have ischemic diseases and herpes infections. We have some complications in that. So even the old ones really work sometimes. So steroids, we have something called voclosporin. Sometimes you don't know who's an enemy, who's a friend. Sometimes known devil is better than unknown. We have this salami slicing, we call it in China, coming to us. So like that, uveitis people, we are trying to salami slice into diabetic retinopathy, telling it is inflammatory. That's a new thing that's happening. Probably diabetic retinopathy, we are thinking probably it is inflammatory and trying to take over some amount of money out of it, maybe. Here are inflammatory ones, anti-VEGF is uveitis is share. So those days when in doubt, it used to be gut feel. Now it's about gut microbiome. So these are the possible source of autoimmune reactions. That's what we think. So other than the infective ones, the non-infective ones, even infective, like say non-infective like HLP27 and all that, they have seen it is because of the gut microbiome that activates the peptide and causes HLP27 associated uveitis. So, politics? Yeah, correct. My language is more ancient, yeah, correctly. Neptis for nepopenic. How many other languages are okay? As uveitis specialists or patients, we just want our patient vision to get back. If all this happens, if you remove this term or remove this language, if vision is going to come back, then it's fine with it. Thank you. Thank you. As uveitis secretary, my role, we have the uveitis Society annual conference in Jammu this year, and on October 3rd, 4th, and 5th, so you can have a great time. Thank you.
Thank you, Sudarshan. So, any comments from the panel?
Very interesting about this. How frequently you give anti-VEGFs in TB granulomas? TB granuloma, like how frequently? Like?
Yeah, the one disadvantage of that, the way it shows, it's all very nice that it vanishes or so thing, but it is a short acting one. So we give every 2 weeks.
And any particular preference for any anti-VEGF?
Off late it has been Dalimab. Initially it started off with Avastin actually, but then now I have not written Dalimab actually we have a study going on with IAC, and they found that it seems to have some amount of antimicrobial property also. The antimicrobial molecule itself.
So we always combine with moxi.
Yeah, always combine with moxi.
So moxi for the reason because it acts against TB basically.
Yeah. We don't want any other thing. I mean, quinolones are known to have anti-TB effect anyway. Moxi otherwise is very short acting. There have been studies there, they've shown that local single injection of moxi itself is result. This actually is resolved very well. So I could have stopped, but then you know that it is a systemic disease, you want to have it as systemic.
So I just could go on repeating and just see if it's responding. Maybe after 1 or 2 injections I stop.
Yeah, that's all.
So every 15 days?
Every 15 days, yeah. 2 or 3 max you need. Like, see, I've given 2 maximum. Just over, I give 1 and then like, that's all. I guess it gets over. We'll do 2, 3 max.
it's really effective in granulomas. Actually, Manisha and I think Vijay also, they just use intravitreal now without any systemic anti-TB drugs.
That they were
If it's a
using-
solitary small nodule, then they just give intravitreal moxi and anti-VEGF, no systemic anti-TB at all.
I think they started with only anti-VEGF and now added anti-VEGF.
They had initially started. Now I think they have come back to the fact that except retinal vasculitis and where you need 6 months, other points they seem to be thinking that wherever chloride is involved, then you need like 9 months of ATT. They found the recurrence studies and found most of the consensus now is that you need 9 months of systemic apart from this. So last few cases of serpiginous and peripheral with some amount of NV I've given for them also seems to be working very well. It will come out maybe in some time.
Anti-VEGF plus moxi or
Anti-VEGF plus moxi.
From the ATT regimen, do you recommend to stop exam people after 3 months?
We have actually one of our fellows presented in last year USA meeting also. So he then was sparing regimens with quinolones. I mean, obviously there are people who keep telling that you are going to actually increase the drug resistance and all that. But then I don't want my case to happen in the associated optic atrophy. When you don't have a proven, these are all hypersensitive reactions. You don't need that strong. And current regimen is is very scary. So of late,
double the dose. Now double the dose.
Yeah, double the dose. So it's too long. So we, whenever possible, we try to treat. Unless there is some amount of evidence through HRCT showing something or some cholesterol abscess or abdominal, so we prefer giving non-English care. I mean, rather English care. Preferably quinolones.
One question I would like to ask regarding the management of syphilis cards. A lot of times the penicillins are not easily procurable. So what are the alternative therapies?
Yeah, the lucky thing is that we have a very good HIV center there who seem to have an abundance in their CP. But CP sometimes is not available, ceftriaxone is the better option. Right. So equivalent term is like ceftriaxone. So people have tried with doxy, but the issue with doxy is that they are not as effective. They are good in the maintenance part of it. If you have a title which are persistently high, later on you want to have it on a long-term basis, then doxy is a very good drug. But then if penicillin is not available, ceftriaxone is the better option.
But it's good that Sudarshan pointed out syphilis because we're seeing a lot of syphilis cases.
So I think it's not necessarily that it has to be HIV. Now
yeah, post-COVID, suddenly the incidence of syphilis. So, I mean, uveitis cases always do keep syphilis in mind, and it's surprising. I mean, the first 20 years of my practice, I've seen 5. Now we are seeing almost 2-3 cases a month. So it's tremendous.
The current Sun working group criteria, recommendation is that every patient of uveitis you need to do RP-anti-PH.
Sir, any role of intravitreal steroid after starting ATT in such kind of TB granulomas?
Any
TB granulomas, role of intravitreal steroid after starting ATT for
intravitreal steroids?
Yes.
We don't give steroid.
Actually, it's
better to avoid like that.
Better to avoid.
Any infective lesion. See, granuloma and subretinal abscesses are like the bacillary load is higher. So subretinal like choroiditis is a quasi-bacillary one where the bacillary load inside the eye is lesser. So even in that you shouldn't be giving, but then like I think you can get away. But a granuloma or subretinal abscess, the load is high. You don't want an intravitreal steroid.
So what is the intravitreal moxi dose you give with anti-VEGF?
Anti-VEGF is, there are two things. Now the current thing is it has an antimicrobial peptide antimicrobial property, but then basically reduce the granularity, vascular part of the anti-VEGF one. The dose
for moxi if you are giving with
0.05.
Directly
from the
directly from the
preservative free.
Yeah,
preservative free.
I give it as 2 separate injections, not having the needle inside and give it alone.
Mankind people they claim it in their moxifloxacin vial. You can inject it directly from their vial also. If you are opening that vial at a time, you can directly inject it. They have even done a study in AIMS. They are injecting post-cataract surgery.
soon after the sessions are over, maybe we'll have 10 more minutes for the judges to discuss on themselves.
Thank you, sir. So now I invite Dr. Vishal Agrawal for this presentation on intraocular neoplastic disease transferring as levels.
Thank you, VRAG, for giving me this opportunity. In today's session, I will just discuss about the few cases which I came across which were presented initially with uveitis and then ultimately turned out to be neoplastic diseases. These are the cases I will discuss briefly. So this is the first patient which presented with a picture like the subretinal abscess, and the patient was already on ATT and oral steroids, and the CT scan was showing some suspicious calcified lesions, and physician agreed to start on ATT, but it did not respond to ATT, and ultimately it led to exudative retinal detachment, and you can see this almost total exudative retinal detachment. We have to do the choroidal biopsy, and ultimately this turned out to be metastasis from the lung, which was missed on the CT scan wrongly. So in the patient where the disease is not responding, the choroidal biopsy could help. This is another patient who was a known case of adenocarcinoma of the lung, who presented with a small nodule in the nodular deposit on the surface. As I shown in this arrow, there are small nodular deposits, and the patient was having neovascular glaucoma as well. We can see in the angle as well on gonioscopy, these nodular deposits were present, and this is the neovascularization angle which was there in the and causing the high IOP. So in this patient, the diagnosis was uncertain. What we simply did was just did the fine needle aspiration biopsy from that deposits, and that deposit showed that it showed positivity of the for the metastatic cells, and it favored that this disease was the metastasis to the iris and the angle, and patient was referred to the physician for the escalation of the chemotherapy and starting external beam radiotherapy. So this is another case like where a patient was having granulomatous choroidal lesions, small lesions, and studded over the posterior pole and near the arcade area, as we can see in this picture. Other eye was fine, and the choroid was also very thickened, and it was the lumpy, bumpy choroid. So other eye was the fine. The patient was having the thickened choroid on the ultrasound as well. So all the uveitic workup was the negative, and the patient was not responding. Vision was 20/60. We decided to do fine needle aspiration biopsy from the choroidal lesions. It showed the low-grade B-cell lymphoma. Patient was treated with the external beam radiotherapy using 4 gray, which is called the ultra-low dose radiotherapy. This led to resolution of the disease as it is seen in this picture, and good resolution in the OCT, even in the ultrasound picture. This was another patient who was presented with deposits on the subretinal space and involving disc, and few deposits on the superior retina as well. The patient was thorough uveitic workup was negative, and patient was not responding to oral steroid. When we did OCT, it showed vitelliform submaculopathy, and the vitelliform submaculopathy was the one new thing to us. Again, for the confirmation, we did fine needle aspiration biopsy and from subretinal deposits, and it turned out to be large lymphoid cells with prominent nucleoli, and all this was suggestive of the intraocular lymphoma. Patient was treated with the methotrexate, and we recently published this case that the subretinal cloudy vitelliform submaculopathy could also be associated with the lymphoma. That is the one OCT biomarker. This is another case who was a known case of acute myeloid leukemia and had this kind of keratic precipitates, and the entire vitreous was studied with the cells as it is seen in the figure C. We were not sure of the diagnosis, whether it is a relapse of the leukemia in the vitreous which has never been reported, or whether this is some infection in the eye. So patient was not responding. Again we did simple vitreous biopsy, and it showed CD34 positive blast cells in the vitreous, and this was reported as a leukemia relapse in the vitreous, and patient was treated with the systemic chemotherapy with intrathecal chemotherapy, and patient responded well. I will stop here. Thank you.
You have 4 minutes.
excellent cases. Comments?
Only one, I have 2 questions. One is about the first case, we saw that mentioned that CT scan also showed there was no finding in CT scan. There were no lesions in the CT scan. CT scan was also no. But later it was a case of a metastatic.
Yes, so that was actually confusing for us that in this case we did CT scan and the CT scan also did not confirm it showed that it is some calcified lesion and it could be tuberculosis and its clinical correlation, and the infectious disease specialist started patient that yes, this could be TB and we can start on ATT. So that was a thing when we were in dilemma, because if it was picked up on CT scan, then patient would not have worsened, but ultimately patient underwent PET scan and then found to be that metastasis also somewhere else in the body from the lung.
Also depends which CT center you are going, because nowadays there are so many centers. If you see the CT scan, it's horrible. So I think that also, if you are in doubt, maybe you just get it repeated in a better scan center. It's a huge difference.
No CT scan of rates on TB.
Yes.
Initially,
yes, calcified lesions, which was diagnosed as tuberculosis.
Yeah, Kushal, when you are suspecting malignancy and you are taking a renal biopsy, what are the risks for spreading those malignant cells?
So, in the patient retinoblastoma, it is very highly malignant and the biopsy is not recommended. But when we do for this metastasis and the choroidal melanoma, the chances of disseminations are very less, and it is proven on studies that there is no any other safety precautions we need to do. We can safely take biopsy and come out. That is, it is not that metastasis, it is localized the disease. So we can, I think, go for the biopsy without any specific thing which we do for the retinoblastoma, like intravenous infusion of. Anything for the retinoblastoma, we do cryo, but anything else besides the retinoblastoma, there is no recommendation to do cryo. Even if we do biopsy for the choroidal melanoma genetic analysis, we don't cryo the injection site.
So this is basically query actually. So we have 2 different set of people in SLH, Vikas coming from our place and Suneshwari coming. So like one set was like about MRI, CNS, or whatever, and taking a biopsy route. Other one has a whole body PET scan. So when do we decide either of them?
So I think I would agree with the first doing PET scan and see before doing any intervention. So I would think that the PET scan should be done and then we should think of the next step.
Probably in this it would have picked up for the PET scan.
But I think PET scan is a very high radiation.
Yes, very high
highest radiation exposure.
But it avoids the intervention. So I think if you are highly suspicious, doing a PET scan is a non-invasive therapy. And if you are really suspecting of malignancy,
especially in this OCT or this over the lesions, actually, like you know that it is not like TB subretinal abscess.
Right.
So nowadays off late we have that like nice after the event actually. So you know that the contacts, you know the much lesser cystic ones.
Thank you. Excellent presentation.
Dr. Sarkhej for her case presentation on an interesting case of ARN in a patient of Sjogren's syndrome following treatment with immunosuppressants.
Thank you, VRAG, for this opportunity. I'll be presenting an interesting case of acute retinal necrosis in a patient of Sjogren's syndrome following treatment with immunosuppressants. So, 43-year-old female came, she was diagnosed elsewhere as chronic interstitial nephritis with Sjogren's syndrome and was started on tablet hydroxychloroquine and oral steroids for same. Following oral steroids, she developed herpes zoster at T11 dermatome, and hence she was started on tablet phencyclovir and topical acid along with oral steroids. So, this is when she presented to us. These are the scar lesions of herpes. 15 days later, she went somewhere with complaints of diminished vision in the right eye. She was diagnosed as right eye autoimmune retinitis with microvasculitis and was treated with 3 doses of intravenous methylprednisolone, followed by high-dose oral steroids and azathioprine. Since the symptoms did not improve, she came to us. When she presented to us, the vision in the right eye was perception of light. Left eye was 6/6. On slit-lamp examination, there were no anterior chamber cells of flare. The lens was clear and the vitreous had cells 3+ and flare 3+. In the left eye, there was no anterior chamber or vitreous cells and the lens was clear. The intraocular pressures in both eyes was normal. On fundus examination in the right eye, we could see acute retinal necrosis, which was spread 360° and in the left eye it was normal. So this is the right eye slit-lamp picture image showing pigmented KPs, clear lens and vitreous cells and flare. This is the fundus picture. As we can see, the media is a little hazy. There were retinitis patches 360° along with vasculitis marked by the arrows. This is the temporal side of the picture. This is the autofluorescence showing the demarcation line between the normal retina and the necrosed retina. This is the fundus picture of the left eye showing a completely normal fundus. So we went on to the labs, which was ANA was positive for SSA low pattern, and the CRP, HPSCG, XCG were negative, ESR was raised, and rest of the investigations were within normal limits. Further investigation, we did right eye anterior chamber tapping under sterile precautions, and meanwhile we started the patient also on intravenous acyclovir, 500 mg every 8 hours for 7 days. The PCR came out to be positive for VZV DNA targeting ORF 63 gene, and we detected 6 crores copy, and the PCR for CMV and HSV12 was negative. So final diagnosis of acute retinal necrosis in a patient of Sjogren's syndrome following treatment with immunosuppressants were made. And we also gave the patient an intravitreal dose of ganciclovir, 2000 microgram in 0.1 ml. 2 days after the intravitreal injection, 2 days and 4 days after the intravitreal injection, we could see the retinitis patches were resolving with reduction in the vitreous haze and vasculitis. She was continued on tablet valcyclovir 1 gram twice a day along with oral steroids. 1 month later, the patient developed total retinal detachment with optic atrophy, and the vision had gone to no perception of light. So this is the final fundus picture with a mark showing optic atrophy. To summarize, 43-year female with Sjogren's syndrome and with history of herpes, came with complaints of right eye diminished vision, treated elsewhere with steroids and INTs. So this is the fundus picture and presentation. We diagnosed as acute retinal necrosis, VZV ACTAP2-1 positive patient, and treated with oral, intravenous and intravitreal antivirals with oral steroids. This is the post-intravitreal picture showing reduction in the retinitis patches. Unfortunately, we lost the vision to retinal detachment and optic atrophy. These are my acknowledgements. Thank you.
Nice case, Subhani. So Sudarshan, you said you want to discuss about ARN.
Basically, because I saw the list of patients and then I so the one can you go back to the so one of the things in this is like when you look at the visual outer little like a PRN kind of picture. So Navneet and me were just discussing. Despite the fact that it is non-HIV, the fundus or non-emitting steroids, it looks very clear. That's because of the fact that otherwise the patient is immunosuppressed. Right? Like in the Sjogren, autoimmune retinopathy and other etc. So the patient immunity is lesser, so presents like a pure and kind of picture with outer retinal environment. So generally, when you have it, more often it is VZV. So when you have even though it's a peripheral lesion, with pure fragment kind of appearance, it's usually VZV. And this inflammation being less is because of the otherwise immunosuppressed disease. The good thing about these things is that because they are transient, they respond very well. I mean, like optic atrophy, RT is another part of it, but the retinitis resolve much very well compared to a patient who is in a regular immunocompetent ARN patient, where they can develop any kind of leukemia change can happen, retinitis can happen, atrophic cones can happen. So that way we do well. Always supplementing it along with intravitreal injections are the best option. So they know some patients who are partially resistant to valcyclovir do well with alganciclovir. So in some situations, if it is too aggressive, you can combine it with valcyclovir and alganciclovir also. In some patients, you need not wait for proscaline. And when you don't, it's not available. Valcyclovir may not be available. So when you are in doubt that is progressing, despite the fact that you are good dose of acyclovir, then you can add acyclovir, and acyclovir again definitely helps. So you needn't wait for CMV diagnosis. IV acyclovir is the drug of choice. Bioavailability is 100%. Even if you have to give 2 grams QAD of acyclovir to give 100% bioavailability, which is nephrotoxic. So at the most you can give is about 100 TDS and QAD. So steroid you can start 48 to 72 hours at the most early.
Post-COVID also, the incidence of ARN has suddenly increased.
That's what one of my early first slide was that. Like in COVID, HZ was again quite a lot. We are seeing quite a lot of HZ for reactivations. All the ubiquitous organisms which are there in the body, TORCH group, everything seems to be reactivating.
What are the chances of bilaterality?
More often in children, bilateral ARN, otherwise we see more often in children. Definitely, the risk is much higher. That is one of the reasons we have to give systemically antiviral therapy.
So now it's just like the case that we are seeing, the young child. And as he's saying, in children, it's more common to have bilateral. It's better with cidofovir.
So systemic, you augment it with intravitreal, but then you definitely give systemic. So one thing we need to have is that it usually starts resolving in the second week. Okay, so you can see the lesions, edematous ones, start getting little granular. The one posterior pole ones or the edge ones, when they start getting granular or less yellow or little of the grey shade, then you know that it is resolving. But then now with the ACTAP which I have been following off it, the first week actually the viral load is much higher. So initial few cases I used to panic, thinking that initially it was 6 crores, after it will be 8 crores. But then by the second or third week it starts reducing drastically.
You are in an institute, you have the liberty to do that. Most of us.
I have a very good HOD who waives the bills. So he actually we don't charge the patient for the intravitreal follow part of it. So off late
you have to rely clinically.
Question is related to that only, that compared to the aqueous step versus the vitreous step, because I had a case in that was an ARN, but the patient was waxing waning, subsequently developed detachment. So when I went ahead for the vitrectomy, I sent the vitreous biopsy cut out it also. So the question is that whether in such cases, if we have a significant vitreous inflammation on first presentation, should we opt for an AC tap first or to try for a vitreous tap?
Maybe if you cannot see the lesion, then probably vitreous. Because if you otherwise ARN is a very clinical diet. You don't get it toxo. When you have a posterior pole lesion with less hemorrhages, then you get confused with toxo or other things. But then if you have a peripheral lesion like this, then it's
so AC tap will
work in pan-diabetic, because ARN is generally a pan-diabetic entity. Toxo, if you have vitreitis, if you have an atypical presentation, not so sure, then probably. Okay. Toxo again, one last thing about the toxo part is, okay, when you get bleeding, toxo next case.
Yeah. Okay.
One thing you were saying after COVID, the reactivation of syphilis and TORCH. What do you think is happening?
I think there is an immune modulation and all our ubiquitous organisms are getting reactivated. So TORCH group is all
even after so many years.
Maybe vaccine, I don't know.
Do you feel at this stage we should have operated this patient and put oil?
Again, there are people who have done vitrectomy at this stage so that they remove the load of the organism. And oil they say probably prevents further progression. So the development also probably. The risk of complicated could have been less.
Thanks, Savani. It was a nice case.
So we now invite Dr. Gaudisha for his presentation. Topic is ICU again.
Good afternoon, everyone. Thank you, Dr. Ahmedabad sir and VRAG team for giving me the opportunity to present on this platform. So my case is 22-year-old male presented with diminution of vision in left eye for 3 days. This was history from May 2024. He was referred to us by an eye specialist. So he was a known case of Burkitt's non-Hodgkin's lymphoma. He was HIV positive that was diagnosed in December 2023. He had completed 5 cycles of chemotherapy and now the disease was under remission according to PET scan report. So he was treated with rituximab, etoposide, doxorubicin, vincristine and methotrexate. He had history of 7 kg weight loss in last 5 months and he had recent history of blood transfusion. So when he presented to us, his CD4 count was 58. That was in May 2024. And he was on antiretroviral therapy that was he was taking dolutegravir, lamivudine, tenofovir and Bactrim DS, and he was under care of ID specialist. He had done blood PCR, which was positive for CMV, that viral load was 25,94,050. So at presentation, his best corrected visual acuity in right eye was 6/6 and left eye was 6/18. His both eye intraocular pressure was 18 and both eye anti-segment findings were unremarkable. But on dilated fundus examination, he had this granular type of retinitis in the periphery in right eye and fulminant pizzapie pattern in left eye, which was involving the posterior pole and it was near the disc and all the quadrants. So we made the diagnosis of CMV retinitis in both the eyes and we decided to treat him with intravitreal cytophovir, and we started him on oral VRAG and cyclovir 900 mg 2 times a day, and he was continued on ART. So after 1 month on follow-up in June, his both eye CMV retinitis was completely resolved and his visual acuity was 6/6 in both eyes, and we decided to keep him on VRAG and cyclovir twice a day for at least 3 weeks, followed by once a day. But he developed neutropenia after 2 months, so we had to discontinue the VRAG and cyclovir. The disease was stable in between, but after 5 months, again in December, he presented with diminution of vision in both the eyes, and his visual acuity dropped to 6/12 in right eye and 6/9 in left eye. And in between, he had history of reactivation of Burkitt's lymphoma in August, and he was restarted on chemotherapy. And he completed his last chemo 3 days back before he presented to us. That time, ID specialist had done blood RT-PCR and viral load was less, that was 3,000. So it was 25 lakhs that dropped to 3,000, but he had CMV retinitis in both eyes. But his WBC count was 2,440. So this time also we had to give him intravitreal cytophovir because right eye was also involving the posterior pole and left eye was also aggressive. So, and we restarted him on VRAG and cyclovir. And on follow-up after 1 month in January 2025, that CMV retinitis persisted. He got pneumonitis in between and he got bacterial infection, pancytopenia, and he was admitted in ICU for the same. So, and he had multiple blood transfusion history. And when he presented to us, after 1 month of cytophovir, his visual acuity further dropped to 6/24 in right eye and 6/12 in left eye. He was given 3rd dose of cytophovir that time. So these are the photographs of right eye. These are the photographs of right eye post 2nd dose, which was given in which was given in December, and we followed up in Jan. That was still active, so we decided to give the 3rd dose of cytophovir after. And this is a photograph of injection after 3rd injection of cytophovir in February. So the retinitis started regressing in both eyes. These are the photographs of left eye, and last he came recently on 18th March with again drop in vision, and he had recurrence of CMV. So we decided, like as his WBC count was only 430 and platelet count was 28,000, and he had taken last chemo 20 days back, we decided to give intravitreal cytophovir and we hold the oral VRAG and cyclovir after consulting with ID specialist. So to conclude this case, I would like to say that CMV retinitis is always a classical clinical diagnosis. No diagnostic role of serum anti-CMV IgG or IgM is there in this case. PCR from ocular fluid is always helpful for the diagnosis. Always check for immune status of HIV patient before starting any antiviral therapy, and we have to monitor very closely for the side effects. A multidisciplinary approach in collaboration with an ID specialist is essential for optimal diagnosis and treatment planning and management. And I really want to ask one question to Dr. Sudarshan sir, that is there any correlation between CMV retinitis recurrence and serum CMV viral load? Because in this case, viral load was less, but there was recurrence. Thank you.
Difficult situation actually, one double, triple. So like one HIV is enough, like one lymphoma is enough, like we have so many things.
Very sad case.
Difficult actually, because the age is still active. So one thing they do is they check the creatinine clearance and then they can give lesser dose of anti-circular. So and frequency of injections probably. So you have the best experience maybe compared to cancer clear. That way we can probably keep giving it twice a week, more often if it was cancer clear. So and for her question, before going back, we have actually done a study where comparing blood CMV values, aqueous CMV values, and then comparing the appearance of the CMV retinitis. So wherever blood and aqueous was compared, the aqueous values whenever they were more in comparison to the serum ones, the intravitreal worked much better. Wherever blood alone was there, you had to give systemic. Okay, so that way it is. So that way, if it is a systemic serum values are much higher, then you have to give systemic. It is a systemic disease, so you have to treat it systemically. There is no question about it. Everything, for all antiviral diseases, the intravitreal is an augmenting therapy. It is not the therapy. You will have to give systemic. The only issue here is you can do something called PP65 antigen testing. So there is PP65 is a protein marker of active CMV replication. So if you find the PP65 values, whichever are higher, so based on their assays, you can decide how much of when to stop. So before you are actually stopping this, before the count became so low, and you are trying to stop it or titrate it, if you had done PP65 antigen testing, then you would have, if it was high, then it is actively replicating. So that time maybe you can. So at that point, the other option is what Namit was asking in the previous patient, where maybe vitrectomy would have probably removed the viral load. The vitreous load of the infective load could have been removed. So that would probably help. There are a few studies which have done like that.
But doing a vitrectomy in CMV retinitis would not help much because they are mainly in the ganglion cells. For ARM, I would say yes because there's a lot of vitreous.
That is what the study has shown, where they compared with the intraocular specimen evaluation of the PCR, RT-PCR values and the serum values. If you found that aqueous intraocular specimen values were higher, then probably that can help.
And when I consult the ID specialist, what they think that if the patient has a very low viral load and they have a very good heart therapy response, when I ask them to start systemic anti-CMV treatment, most are hesitant if there is really no evidence of a systemic disease. And I tell them that we are getting a very good response with our intravitreal cidofovir, then most of them they hold on giving systemic anti-CMV medication.
Yeah, because the count is so low actually in this. So the ultimate aim, they have to be increasing the counts. There are other ways of increasing the counts. We also have seen some patients of idiopathic CD4 lymphocytopenia. There are some diseases where there is something called idiopathic CD4 lymphocytopenia. So it is neither HIV nor being where the counts don't increase. They try to give interferon, immunoglobulins, trigger, and those things might increase. They cannot give it.
This is one of the rarest cases where I've given already 3 or 4 cidofovirs. Otherwise, most cases just 2 cidofovir and it's dead.
So that probably that way, at this point, in this kind of situation, probably cancer cure would have been. I mean, if you had started up the cancer cure one, we can keep giving it almost every twice a week. So the continuation would have been there. I don't know whether have you combined cidofovir and cancer cure at any time? Maybe we can try one cidofovir once and once cancer cure, or one postcard network.
Cidofovir is technically 100 times more potent than ganciclovir. It's a very high drug, so never combine with both.
Probably one of that maybe we can try something like postcarnet or ganciclovir, because what if it's partially resistant? Part of the reason is because it is counts are low. Part of the reason could be it is partially resistant.
Question for frequently, can you repeat cidofovir injection?
Yeah, you can. Not before 4 weeks. Not before 4 weeks.
Do we have anything, something like for what cancer induction and maintenance, something for cidofovir it's not needed?
No, not needed for cidofovir. Not needed for cidofovir. Because the half-life is long. So for ganciclovir it's a shorter half-life. So induction is almost twice a week until the lesions heal. And then you can go on to once a week.
You can try intravenous ganciclovir because that's another option. You'll get
That's why they gave double the dose of ganciclovir initially, just to start with.
One problem with people who have systemic blood dysplasia with ganciclovir is valve forms can have coagulation of abnormalities. So that is another additional risk to these.
You see much more detachment.
Oh yes. 100%.
CMV is much less.
Because there's not much of vitreous inflammation in CMV. With ARN, there is almost always a severe vitreous inflammation. And you have to be very aggressive with your steroids. You know, start it soon after you start the antiviral therapy. You have to be very aggressive with your systemic steroids to prevent the vitreous. Because they develop very thick vitreous condensation at the edges of the healed and the normal retina. And that's where the breaks.
At least with dealing with RDs with CMV also, that there was a very dense citizenity.
Oh yes. So again, I mean, if you have a CMV RD and when you're operating, you should never try to induce a PVD. You should just trim, because they'll have very, micro, hundreds and hundreds of micro holes. And if you try to pull, it's like a sieve-like retina. It will just tear. So you just trim it and then just use a high viscosity, 5000 viscosity silicone oil. Most of
Just a question to Sudarshan. When do you consider in ARN when it's not responding, then you should add well-glycosyl or change the therapy? How long you should wait, considering it's a non-responding patient?
I don't know how long should we wait, but I wait till the second week. By second week, you tend to get some amount of response. It starts responding by the second week, most of the time. Some granularity will start developing at the edge of the lesion, definitely, by second week. If it doesn't, then I think of changing.
Thank you, Molly. We move on to the next case.
So we now invite Dr. Tejaswita Verma for a presentation of toxoplasmosis presenting with high IOP.
Good afternoon, everyone. So I'll be presenting a case of 26-year-old male who presented with 6 days history of blurred vision in his left eye, which was gradually progressive and associated with a single floater since 3 days, and mild pain and redness since 1 day. Vision was 6:6 in his normal right eye, and left eye vision was 6:12. The left eye cornea was edematous with a moderate non-granulomatous anterior uveitis and moderate vitreous cells. The intraocular pressure was 47 millimeters of mercury. He was elsewhere diagnosed as viral uveitis with trabeculitis and was started on acyclovir eye ointment 5 times a day, antibiotic eye drops, tablet amoxicillin and clavulanic acid (BD). So on the first visit, which was on 30th September 24, the fundus examination revealed moderate uveitis and active white retinitis just superior to the macula. OCT scanning showed a full thickness involvement with hyperreflective thickening and moderate overlying vitreous cells. So a diagnosis of toxoplasmosis panuveitis was made, and he was started on a 6-week course of oral Bactrim DS, and oral steroids were added 3 days later. The elevated IOP was also aggressively managed with topical drops and oral acetazoline. So fluorescent angiography and ICGA was done, which showed hypofluorescence surrounded by hyperfluorescence on the fluorescent angiography and hypocytosis on ICGA in the late phase. So he followed up 10 days later, and post 10 days on oral steroids, the patient didn't purchase, he was advised Bactrim DS, but he didn't purchase the tablet due to some miscommunication between the pharmacist and him, and he was only taking steroids. So the vision had reduced to 618 parts, but there was improvement in the lesion, but still there was ongoing inflammation. So on the last follow-up, which was on 19th November 24, he was, when he had started taking oral steroids with Bactrim DS, 6 weeks later the vision improved to 66 parts and the IOP was 12 millimeters of mercury. The uveitis and retinitis had also resolved, leaving behind an inactive chorioretinal scar. So to summarize all the 3 visits, on first visit there was whitish retinitis lesion superior to the along the superior-temporal macula and aligned with overlying vitreous cells. 10 days later, the thickness had reduced, but there was still ongoing inflammation. And on the last follow-up, the lesion had healed, leaving behind the scar. So, inflammatory ocular hypertension has been reported in literature in 10 to 50% cases. Our case has panuveitis and ocular hypertension, which is seen rarely with toxoplasmosis, but commonly with viral uveitis. And abnormal IOP is a feature in almost half the patients with active toxoplasmosis retinochoroiditis. Elevated IOP tends to occur in 38% and low IOP in 6.6% of affected eyes. Patients with elevated IOP due to active toxoplasmosis present usually earlier than patients with normal or low IOP. And IOP of more than 21 mm of mercury has also been associated with increased JC cells and elevated flare along with macular.
So Sudarshan, how long will you continue Bactrim in toxo? So it's a controversial topic.
Nice presentation. She was the only one who finished time, I think, including myself. So nice. The thing is, I actually add Lindar Bactrim. So we give one sulfon and non-sulfon. It's almost quadruple therapy. So of late, what we've been doing is that Bactrim and Lindar, I start off. Intravitreal Clinda start giving and take off the Clinda, systemic Clinda early and then continue the Bactrim.
How long?
So 6 weeks to 3 months is the minimum dose. So the minimum time you want to give is 6 weeks to 3 months depending on what kind of lesion. If there is a recurrent once, then the consensus now is for 1 year.
So that's what I was asking. When there is a recurrence,
if there is a recurrence,
I think we usually continue for a year.
Intravitreal Clinda.
Yeah, intravitreal Clinda.
Protein leading, off late.
How frequently?
Every 2 weeks. One, they probably similar, probably
I mean, if it heals, you don't have to repeat it.
Yeah.
If it
I
doesn't,
gave interrupted cases, but I had some, in 2 cases I had some side effects. One is one developed macro and one developed attraction.
again, those are not Clinda side effects. It's because always all toxos will have a macular traction. And it's only healing.
If it's a fast healing,
yeah,
that may be
or if it's close
to the
macula.
From this NN also, he faced the same issue. We have 2 cases of macula.
There is a study which showed Linda in where IgG has been high or IgM has been high, and at which point it is. They found that whenever there has been an IgG significantly high and IgM not being positive and very close to the ones, macular puckering has been found to be more with intravitreal Clinda. So one set of people don't tend to give it within the first arcade or within the inner part of the first arcade, because otherwise the vision might be good and they might get after or above.
That I faced in 2 cases.
That's true. Intravitreal is known to scar faster.
I think it's fast faster. So you feel like in zone 1 within the macro area which are not.
Yeah, depends on the patient. At this point I might give probably. When it is within this arcade, then I don't give. I don't want to take a chance.
On the contrary, that's the teaching. Only if it is macula threatening, you use intravitreal clindamycin. That's the traditional teaching.
That's true. This risk is there.
Yeah.
There have been reports.
So I have 2 cases in which I faced this issue.
You use steroid along with it?
Yeah, I gave steroid. Linda plus also.
LVP group also uses steroid. We don't use.
I always use steroid.
We don't use.
I give intravitreal clindamycin also.
So that way probably you can take away the Linda part and back to normal you can maintain. So intravitreal is a very good option. It's also very good.
We've seen a few cases now come and present with recurrences quite often, 6 months down the line, 8 months down the line. And we've been keeping them on Bactrim for over a year now without having any recurrence.
There are these 2 studies, consensus like COTS, you don't have a like Titan for antiviral antibiotics and for toxo. For both of that, if at all there is a recurrence, the consensus now is that you need to have 1 year. If there is a repeat recurrence in viral, then it means that you need to do it for 2 years. Similarly, probably they are developing for toxo.
I just have a question. In your case, usually toxo is a retinochoroidal lesions. Here we don't see a choroidal component on the OCT.
The first one, I think.
Yeah, so this is what we see in OCT.
It's more higher up the line, higher up would have been probably better.
So how often you say high IOP is in toxo? Very rarely. This is the first case in which I saw it.
We have it Parson actually, like that. In Fuchs uveitis, we have toxo-like scars, like Parson used to describe. So Fuchs is a scattered thing with raised IOP. So probably like it was known to be a long time back. But we had a study of Fuchs-like uveitis. They showed some set of rubella, some virus, and some toxo. So toxo again, like I was actually answering Kushal last time about which I was supposed to tell. So So toxo lesion AC taps, usually PCR may not turn out to be positive, but antibodies turn out to be positive. In parasites, generally from intraocular specimen, you check for the antibodies. For viruses, you check for the genomes.
Combining bacterial cases, azithromycin, to take load of azithromycin.
Correct. Like the one thing about azithromycin is the gastric as part of it, gastric part of it. But a lot of people use it. I mean, Dr. Biswas uses azithromycin and so
combine.
Correct.
One goal is related to the other combination apart from sulfonic sulfadiazine plus spiral, because we had one in the local city where the IT specialist also recommends sometimes to use that.
The main people about toxo is the Brazilian group, so they feel quatrimoxazole group is combination is the better one compared to the other sulfadiazine part.
In the US, people use more pyrimethamine. Brazilians use protamine.
Pyrimethamine is D-drug, basically. I mean, comparatively, these are tolerability is better in this. If you want to give Bactrim, then probably they tolerate it better.
How often have you seen a reaction with Bactrim in your patients? Have you heard?
I've had only one patient so far. I mean, unless not known sulfur allergy. Clinda, a lot of people don't tolerate. Systemic clindamycin, a lot of people don't tolerate. I mean, you need little coaxing.
They also say that systemic clindamycin has no any ocular penetration also. That's why we give intravitreal because so there is no meaning of adding bacterial with clindamycin.
One patient is actually a sulfur allergy patient who is only a so that's one MCR.
Thank you for the nice presentation. Last question, we move on to the next presentation.
Sir, are there any specific guidelines regarding the peripapillary lesion for toxo? Because sir, there were 2 cases which we and my seniors have seen when intravitreal clinda was given in such cases, the patient turned out E negative. But when apart from the macula, when it was used, it was having good results.
Quickly, I think, sir, we were taught only the lesions close to the disc, peripapillary, atypical presentations, those infiltrates, where the toxins which had to be treated. Once periphery and all that, they said it will resolve on its own. That was the teaching when I was actually in college, and then now anything is treated.
Thank you, sir.
So now we invite Dr. Ahmedabad for our case on post-fever retinitis.
Good afternoon, everyone. Thank you, VRAG, and thank you, Gandhinagar, for giving me this opportunity. So I'll get on with it. I saw a 32-year-old male who presented with sudden dimness of vision since 1 week. He was on oral valsarcology and oral steroids for a suspected CMV since 3 days when he presented. So at anterior segment, he had a BCD of counting fingers at 1 meter in his right eye, and 6/24 and N12 in his left eye. IOP was normal at 14 millimeters of mercury. AC was quiet, and he has 3+ vitreous cells on his anterior vitreous face in both eyes. So this was the fundus picture. We'll have a closer look at the right eye. There was some serious detachment in the peripapillary area with hard and soft exudates all around the arcades with superficial and deep temperatures, almost like a macular star formation at the fovea. In the left eye, there was lesser involvement, but there was disc edema. And on the inferior arcade, there were exudates around the temperatures and a macular Henry star. So we did an OCT. Right eye showed subfoveal fluid along with hard exudates and cells in the vitreous space. Left eye also showed subfoveal fluid along with disc edema, some hard exudates, and fortunately there was no choroidal involvement which was seen on the OCT. So in early phase of the FFA, it showed that there was back shadowing in the areas of block fluorescence in the areas of the exudates and hemorrhages. Left eye showed an early disc leak, and there was also vasculitis in both eyes. Late phase showed disc staining in both eyes. So I came to a clinical diagnosis of bilateral retinitis, suspiciously looking infectious, most probably a viral type of retinitis. And so the detective work began, did a whole set of lab investigations. Manto came out with current toxo, IgG, IgM was negative. Rubella showed a positive IgG with a negative IgM, CMV same, positive IgG, negative IgM, same with HSV. HIV was non-reactive and RP and TPHs were also non-reactive. So we did an aqueous fluid analysis, which also came out negative for HSV, VZV, CMV, chikungunya as well as dengue. So then who was responsible? We did a thorough history taking, positive history, patient finally said something nice. He had typhoid fever 2 months back. He was treated with oral cefixime and he had a positive Vidal test at the time, but there were no other complications. He was not admitted. He had a fever for about 1 week and then went down with his just with oral cefixime. So we did an aqueous fluid analysis for S typhoid flagellant C protein, but that also came out to be negative. So the diagnosis was post-typhoid fever immune-mediated retinitis. So I did some literature digging and found a similar case, and it had vasculitis along with some serous detachment and exudates, same presenting almost a month after typhoid fever. A series of cases on post-fever retinitis have also been done. So my questions are, what would be the differential diagnosis in this case? And as sir said, doxycycline, but is there really any role of antibiotics in this case?
What happened to the case?
So I treated him with oral steroids and the lesions went down. Unfortunately, I don't have photos, but the lesions went down. The right eye did not do so well, but the left eye completely rose.
Treated only with steroids?
Only with oral steroids. I did not think about adding antibiotics at the time.
Yeah, I think like most often it is because the steroid is okay. That's what I was trying to tell even in my talk. So it's for us to feel safe. Like you see, after cataract surgery, you get stop. So this is not for everybody who want to give an antibiotic. Like that, I think probably doxy works unless narcolepsy group don't get angry. So most of them they have actually tried to treat with doxy alone, not with steroids also, and that also has
So how long doxy?
6 weeks. So they minimum of 6 weeks. Yeah, that's the thing. So PD dosing for a week and then OD for next 4 to 6 weeks. So they continue and they cover it like antibiotic steroids around. So that's what we are trying to tell. So you needn't have the fever at that particular time. It can be like before 2 or 3 months before. So basically, recent history within the 2 to 3 month period, if you have had, then probably that could be a cause. I'm not sure whether that is the cause, but probably that could be a cause. More often typhoid related ones are like vasculitic ones. So what I have seen is, I don't know the p-value significance, but occlusive vasculitic part if it is there, usually it is dengue.
Yes.
If there are more raw spots or tail centered hemorrhages, then probably it's malaria. If we have the quadruple spots more, then they are usually chikungunya. So it depends which group, which of the presentations or signs predominate. So if one of these aqueous tab, see that's what, like if at all either the patient says something nice or the lab person says something nice. So if the lab person says something nice, something is positive, you treat them. If they don't, then you treat them with steroids. Add doxy, that because more they have large series. So instead of anecdotal reports, somebody has a large series and given analysis, then better to use those drugs. You don't lose much in doxy.
But how much steroid would you give this?
Full dose.
So I think dengue also people say that initial reports when Padma presented, it's self-resolving. Sometimes you give steroids, sometimes you give antivirals and steroids. I mean nobody knows.
The problem is about the occlusive part because you really don't want the endothelitis part to thing. So you want to have the occlusion part to like the steroids. So they really you need steroids and inflammatory therapy they must have that. One of the right eye probably didn't do well because heart exudate at that point has a thing. The right triangle phobia, if you have heart exudates, those have some relatively less vision and subretinal excretions in the hair.
The phobia was fine, but the heart exudates.
In that fluid, if you have those excretions, the strength, if you have those things don't do well. Other things along that they do better.
Any other comments? The FA showed the occlusive vasculitis very nicely in the left eye actually.
So next month of occlusive vasculitis, so we need to follow up this patient with repeat after.
We don't do that only. If you want like off-time,
I mean,
don't think it is.
I think the OCT itself could show the changes occurring in the retinal layers. So probably we will not need a repeated angio.
What would be the chances of late neovascular?
Too less.
No. Because see, most of the retinitis they only have a posterior pole disease of these cases.
It was mostly limited to the
Posterior pole. That's very classical
Almost no
usually.
peripheral.
Post-fever retinitis usually it's in the posterior pole.
So this posterior retinitis and Kushner like retinopathy, sometimes you get confused. One thing you need to be worried about is the PLR. So in Kushner like retinopathy, one other thing is like SLE retinopathy is one thing that can be aggressive. So one vague fever, you shouldn't get carried away that this probably posterior retinitis. Luckily steroids work for both. And then SLE retinopathy which presents like Kushner like, then you need aggressive, you need to.
But that will show up in your angio, right?
Definitely, yes.
The retinopathy is very
So the
different.
FFA in those cases, FFA repeated follow-up with for ischemia and
So regarding the long-term follow-up of this ischemic patches, so do we see any remodeling or something?
Yeah, they usually remodel completely if it's all. That's why they says if you give early aggressive steroids, then remodeling is possible. That's why usually the visual prognosis is good. So I'm sure the vision must have been quite good. Yeah. Usually they do very well.
I think in PFR there is remodeling, but not in Kushner like and all.
Yeah.
Those are they need anti-VEGF and everything. So.
OCT angiography.
OCT angiography.
Thank you. Very, very nice.
So we come to the last presentation of the session. Now I invite Dr. Deepak Gujwani for his talk on novel surgical technique to fix foldable secondary items.
Make up for the judges. Nice case session. So that's one. You have to judge.
Before this presentation, I just wanted to know any role of AI in uveitis?
Not actually. Quite a lot is going on. There is an article coming there. You, Bala and Dapa have written. So hopefully what test to order? When to refer, that's the next thing. Like, when can get away. List of tests.
This is not a UVA case. There is some surgical case here. So in the morning session, I think Dr. Sangeet because she showed us some great orthoptics of hydrophilic lens. So this is the entire procedure which I'm showing you.
The surgical technique for refixating a subluxated or dislocated IOL are constantly evolving. Currently, Dr. Yamani's technique of flanging the haptics of IOL and Dr. Amar Agarwal's glued IOL are the preferred sutureless techniques. However, both of them need a 3-piece IOL for refixation. Can we refix or flange a single-piece foldable IOL? The first case is a 58-year-old lady with a subluxated IOL causing diplopia. Here we proceed by creating a sterile tunnel. The IOL is then mobilized from the back into the entry chamber. Vitrectomy is performed. And retina is visualized at the end of the vitrectomy. Now anterior chamber is opened up. The IOL is explanted. We now create two flanges on the optic of IOL, 180 degree apart with the help of 504 suture and thermal cautery. Sclerotomy is made 2 mm posterior limbus with 26 gauge needle, and this needle is externalized centralized through the external tunnel. The other end of cooling suture is then externalized at 3 o'clock and 9 o'clock positions. The IOL is then slided inside the eye. The external sutures are then tightened and titrated to centralize the IOL. With the help of thermal cautery, external flanges are created over the cut ends of cooling suture. Now the IOL is fixed and centered and we had to close the eye. The second case is of a 64-year-old gentleman with a small wobbling IOL in the eye causing leukothea. So here also we mobilize just the haptic of the IOL out of the engaged chamber. And then we create flanges on the haptic with the help of 5-0 cooling suture. The other end of cooling suture is then externalized. The external ends are cut and trimmed and flanges are created with the help of thermal cautery. In both the cases, the IOLs were stable with good post-operative visual acuity and without any complications noted of 5-0 cooling suture or the flanges. This 5-0 cooling suture safe to create flanges, and what is the evidence? There are multiple reports documenting the safety of 5-0 cooling suture on a short-term as well as long-term outcomes on fixing the IOLs without any serious complications related to the suture. Thank you very much for your kind attention.
Yes, panelists, discussions. I'm sure a lot of people are doing some comments. Milan, Mukesh, I think you are also.
Clearer cut.
Whatever. Why don't you give your opinions? Bharat?
The second case seems to be more sensible when you are not trying to enlarge the incision. While in the first, once you are trying to enlarge the incision, to my mind, as of in today's era, putting in foldable IOL inside the eye may not make large sense unless you have a large toric cylindrical power coming on the pre-op evaluation. If you are trying to put in an aphakic eye. Otherwise, to my mind, to those patients which I have done it, stability on any of the two axes with this cooling suture might be a tricky thing. The IOL is not as stable as we are using in the 3-piece lenses. The tilt of the IOL doesn't give the best corrected visual acuity, even if you give a good correction post-operative. This is what I have found. You may add on.
So I agree with you, sir. First case was my pilot case. I was also learning this. That's why I had to expand and see, because I was following some of the videos of Sarkhej. He used to use a PMMA non-foldable lens and create a flanges on the eyelids of it. So I was thinking, can I use a hydrophobic lens? So first one was a pilot thing for it. Once you use the hang of it, how to make a flanges, you just have to explain the flanges instead of being invisible. And you might be right, it's a learning curve. The build of the IOL is an issue, especially when using suture. The only thing is, this is not a primary scenario. Primary scenarios, I think I would still use a 3-piece lens, the Yamane technique. Only and only in rare scenarios where do not have an IOL, exactly the power of the IOL, where do not have a library of IOL. This is the reserve technique which you keep in mind to make the same IOL.
There are reports of erosion of the suture after a few years.
So generally they say after 8 to 10 years, suture erosion comes in picture. But Crowne, whatever the labels, if you see the labels of Crowne, it is written as non-degradable, non-erosible suture. The label says it.
I think even as early as 3 years I've seen it. One has gone inside. So maybe technique-wise.
As it's a very technical in these cases, like secondary, in cases with RA, like those two kind of drugs that I was getting. Do you prefer one of these techniques, Japanese techniques?
Probably not as a primary one, as you said. This is not a situation for elevating entity. Maybe they will wait for it and another increase with it. Anyway, secondary IOL, I have more experience of dropping IOL than fixing it.
So I would like to put forward one interesting question. What about those patients who are having dislocated single piece, non-foldable PLM? Have you ever tried for moving those with the standard technique of scleral fixation?
Unfortunately, I tried one of those to optic tracks. I was not able to make a full optic.
No, I am talking about just pulling out the haptic and putting it like a three-piece.
Like three-piece?
Yeah.
I haven't tried it.
Should not be done. I have seen patients with that. Even I have seen people using this haptics of this foldable being kept there. There is almost totally non-healing of the flaps. They keep on losing. You can see on this fluorescence test also. And hypotonic patients have ended up to us. So to my mind, this is not a good idea to take out those. Until those haptics are made of modified fluorine SBC in 3-piece cells.
Non-foldable lenses, I don't think you should try this technique. This is only for
Foldable haptic knob is very thickened for the cerebral orientation. It's not a good option. How long? Longest follow-up has been for how long?
I think it's more than 1 year now, both of these patients.
Like in these cases, you did not remove the rest of the rim of the capsule. So will not that help in maintaining the preventing tilting? Like once you clear the whole of the bag and then you insert the IOL and then fix it, then I think that tilting and all will be prevented.
So I think surgically, if you want, if the IOL is a PCR, the IOL is in sulcus, you will mobilize the IOL. At the end of the day, you are going to remove all the capsule remnants to make sure there is no inflammatory episode after the postoperative period. The only thing is you have to do a clean cure. Do not leave any remnants of it.
I think it will be pertinent to point out, ARC has a scleral cut IOL, which is licensed and patented. And because it's all soft, the haptics also, they fit snugly in a tunnel and probably provide no foreign body irritation in the connector.
Similar on lines of what I have, I think CMT flex. I use CMT flex. The only problem with CMT flex, the haptics are too dirty. You have to put them under the flaps.
Dr. Deepak just came back. I would invite Dr. Sudarshan sir just to hand over the certificate for presentations.
I think we come to the end of the meeting. We still have to announce the winners.
Dr. Saloni Desi. Dr. Mahavishan. Dr. Tejasvi Saravanan.
It feels like our department meeting.
I know. SN Media Department.
Dr. Raghunath.
So now I think it's time to announce the winners of the session, and I would like to invite Kumar sir to give away the trophy. To begin with the medical retina session, the winner is Dr. Kunjan Shah. For the surgical retina session, this is Dr. Ruchi Mehta. And for the UVA and NTS segment session, it is Dr. Kushal Agarwal. With that we come to the end of the meeting, and I really want to thank you all for staying back till late on this Sunday and helping us organize this first meeting. Hopefully we'll improve on this, and again I'm saying it again and again, we want more active participation from your side. So hopefully next year it should be even more interactive than it was this time. And I would especially like to thank the entire team, Kushal, Parth, Madhvi, Kamar sir, of course, our mentor. He's always every day guiding us what to do. And the team of Parth and his hospital, the entire team of the sponsors. I think we should give a big applause to the AV team. It was absolutely flawless. Absolutely flawless. All our event managers, they've been taking care of all the logistics. I think our photographer, our cameraman, and lastly the hotel staff also, the Crowne Plaza. Actually, they've been very, very cooperative. We were not able to give them the actual money till late, and they have agreed to do this even then. So again, on behalf of the VRAG, I would like to thank you all and hopefully see you next year in Baroda.
Thank you.
Yeah, I would again, please fill the feedback form so that we can think of innovating our academic program. And whoever have not taken their participation certificates, kindly collected from the registration desk. Do join us for high tea before we leave. Coffee, sir. Thanks for coming. Thank you.